This is a video in clinical medicine from the New England Journal of Medicine.
This video will demonstrate arterial line placement in the radial artery using two of the many techniques available for arterial line placement, an over-the-wire technique and an over-the-needle technique. Placement of an arterial line is indicated for continuous monitoring of arterial pressure and direct arterial blood sampling. The radial pulse is palpated between the distal radius and the flexor carpi radialis tendon. Prior to line placement, perfusion of the extremity should be checked. For radial arterial catheters, an Allen test or a modified Allen test may be performed. While the value of the Allen test has not been firmly established, it may give some qualitative assessment of collateral perfusion. In the Allen test, the operator occludes both the ulnar and radial pulses while the patient tightly clenches their fist. The hand is then opened and pressure on the ulnar artery is released. Circulation should return to the extremity within 5 seconds, with delayed return suggesting poor collateral circulation. The test should then be performed on the radial artery circulation in the same manner. Other contraindications include coagulopathy, advanced atherosclerosis, Raynaud's phenomenon, or thromboangiitis obliterans. For both procedures, similar equipment will be used: material for a sterile prep and a sterile field, a needle, catheter and wire, 1% lidocaine, a 25-gauge needle and 1 cc syringe, a larger bore needle or scalpel, suture and needle driver, and a wrist board or roll. Prior to sterile field preparation, position the wrist. By positioning the wrist in dorsiflexion, the radial artery is brought in closer approximation to the skin. This can be instrumental to the success of the procedure. Proper positioning can be maintained by placing a roll of gauze under the wrist or by using a specially designed arm board and securing the arm with tape. Once positioned, the field can be sterilely prepared and draped using towels or a drape. As with all invasive procedures, meticulous care should be taken to minimize the risk of infection. After sterile preparation, a small wheal of 1% lidocaine can be infused in the conscious patient to help decrease pain associated with line placement. A small wheal should be raised. In the over-the-wire technique, the catheter and needle assembly are checked first to make sure the catheter glides easily. The assembly is then advanced toward the artery at a 30 to 45 degree angle. When blood return is noted, that catheter is then advanced through the vessel and the needle is removed. The wire is prepared and the catheter is slowly withdrawn until pulsatile blood flow is observed. The wire can then be advanced into the vessel. Once the wire is in the vessel, the catheter can be advanced. While holding pressure on the artery distal to the catheter, the wire can be removed and the catheter can be connected to the transducer system. In the over-the-needle technique, an angiocath is used and advanced at a similar 30 to 45 degree angle. Once blood return is obtained, the needle is advanced slightly farther to assure that the catheter has entered the vessel. The needle angle is then lowered to 10 to 15 degrees and the catheter is advanced into the vessel. Proximal pressure is applied to the artery and the needle can then be removed and the catheter can be connected to the transducer system. Regardless of the technique used to place the catheter, great care should be taken to make sure it stays in place. Although there are ways to secure the catheter with adhesive tape, the best way to secure the catheter is by suturing it in place. A moderate diameter, non-absorbable suture material such as silk or nylon should be used. There are many ways to suture the catheter in place. The key is to make sure it is secure. A clear dressing can be placed over the catheter to help further secure it. Once the arterial line has been secured in place and the transducer connected, perfusion to the extremity should be rechecked. Perfusion should be checked periodically throughout the time the arterial line remains in place. There are some common problems that can occur during arterial line placement. If, in the over-the-needle technique, no blood return is obtained after the initial flash, the catheter can be advanced through the vessel and the over-the-wire technique can be employed. Occasionally, free flow of blood is observed, but the catheter will not pass easily. In the animation, you can see how the tip of the needle might be within the vessel, while the catheter remains outside. By advancing the needle slightly farther after the initial flash of blood, the catheter can enter the artery, allowing for successful cannulation. In some instances, the catheter may get hung up on the skin, making it hard to advance. The risk of this can be minimized at the start of the procedure by making a skin nick using either an 11-blade scalpel or a larger bore needle. Finally, after multiple attempts at cannulation, the artery may go into spasm, which will make it nearly impossible to cannulate. In this setting, attempts at the artery should cease, and a new site should be selected. By following these steps, arterial catheterization can be a safe and effective procedure.
This is a video in clinical medicine from the New England Journal of Medicine.
Insertion of an arterial catheter is a common procedure in critical care units. Ultrasonography may be used to ensure safe and successful insertion of an arterial catheter. This video will demonstrate the use of ultrasound guidance for the insertion of a radial arterial catheter in adults. Arterial catheterization allows for the continuous recording of arterial pressure measurements and can be used to adjust the doses of vasoactive drugs that are administered for hemodynamic support in critically ill patients. Arterial catheterization also provides easy and convenient access to arterial blood when arterial blood gas sampling and other laboratory tests need to be performed. Ultrasound guidance can be more effective than palpation for the insertion of an arterial catheter in patients with obesity, edema, hypotension, or vascular abnormalities such as tortuous vessels. In general, the use of ultrasound guidance for the insertion of a radial arterial catheter is faster than the palpation method and has a higher success rate. Also, successful insertion is achieved after fewer attempts, which means that there are fewer attempted sites of insertion, thereby minimizing patient discomfort. There are no contraindications to the use of ultrasound guidance. However, radial arterial catheterization is contraindicated in patients with infection of the skin or soft tissue at the insertion site, severe peripheral vascular disease, impaired collateral circulation, or severe coagulopathy. After obtaining the patient's consent for the procedure, gather the necessary equipment. You will need 2 pairs of sterile gloves, a mask, a sterile gown, a skin preparation solution such as chlorhexidine, sterile drapes, 1% lidocaine without epinephrine, a 5 cc syringe and a 25 gauge needle for delivery of the local anesthetic, and angiocatheters. Radial arterial catheterization can be performed with standard angiocatheters or with safety angiocatheters. Use the equipment that complies with the safety practices at your institution. You will also need a sterile ultrasound probe cover with sterile gel, sterile gauze, and materials for dressing and securing the catheter. You will also need a pressure bag, a pressure transducer, and a monitor that is appropriate for arterial catheter transduction. In order to assess the vasculature, you will need a linear array transducer ultrasound probe with a frequency range of 5 to 13 MHz. Wash your hands before touching the patient and put on the mask. Position the patient's wrist so that the forearm is flat. Put on a pair of sterile gloves and use antiseptic solution to wash the skin of the patient's forearm from the wrist to the antecubital fossa. Discard the gloves, wash your hands again, and put on the gown and a new pair of sterile gloves. Drape the patient, exposing only the cleaned forearm from the wrist to the antecubital fossa. Have an assistant clean the ultrasound transducer with an antiseptic wipe. Apply sterile gel to the inside of the sterile sheath and cover the ultrasound probe without contaminating the sterile gloves or the sheath. Remove any air pockets from around the probe, which if present will cause poor quality ultrasound images. Make sure that the left part of the ultrasound probe corresponds to the left side of the ultrasound screen. Starting at the wrist, scan the lateral aspect of the forearm in the transverse orientation and identify the radial artery and associated veins, which will be located between the styloid process of the radius and the flexor carpi radialis tendon. If necessary, apply light pressure to help differentiate the artery from the veins. Veins will collapse while the artery will not. Have the assistant adjust the gain and depth of the ultrasound machine so that the artery appears in the center of the screen and is clearly visible. As you scan the artery from the wrist to the antecubital fossa, look for arterial tortuosity and calcification. Locate a section of the artery with a large diameter and minimal calcification. To prevent the development of kinks in the catheter after it has been inserted, choose a site that is proximal to the wrist and distal to the elbow. Kinking can occur when the patient moves or is repositioned. After locating an appropriate site for catheterization, slide the probe so that the artery is centered on the screen. After anesthetizing the skin, insert the angiocatheter covered needle at the middle of the probe at a 45 to 60 degree angle. Slide or tilt the probe towards the needle tip until you can visualize the tip on the monitor. Make small bouncing movements with the needle to locate the tip. As you advance the needle towards the artery, tilt the probe in the direction of the needle's trajectory to ensure that you can see the needle tip at all times. Reposition the tip periodically to confirm that it is directly above the artery. Insert the needle tip into the arterial lumen and examine the angiocatheter for flashback or blood return in order to confirm its position. Flatten the angle of the angiocatheter and then re-examine the area on the ultrasound monitor to make sure that the needle tip is still in the artery. Slide the catheter over the needle into the arterial lumen. Apply pressure proximal to the catheter, remove the needle, and attach the catheter to the transducer. The catheter can also be inserted in the longitudinal orientation. To do so, begin the procedure with the ultrasound probe in the transverse orientation to locate the artery. Center the artery on the ultrasound screen and then rotate the probe 90 degrees. You should see the artery in the center of the screen with a view along its long axis at its maximum diameter. Insert the angiocatheter at a 15 to 30 degree angle at the exact midline of the long axis of the probe. Advance the needle parallel to the long axis of the probe. If you do not see the needle, it is probably medial or lateral to the vessel. Pull back on the needle without withdrawing it completely or letting it leave the skin, and readjust the angle so that you can see the needle tip on the ultrasound screen. Then advance the needle again until it is within the lumen of the vessel and look for flashback in the angiocatheter. Slide the catheter over the needle and into the arterial lumen. Apply pressure proximal to the catheter remove the needle, and attach the catheter to the transducer. The main challenge when performing ultrasound-guided catheterization is visualizing the needle tip and differentiating the needle tip from the needle shaft, since both will appear as white dots on the screen. Novice operators sometimes believe that they are visualizing the needle tip on the monitor, but they are actually viewing the needle shaft. In such instances, the unseen needle tip has been inserted more deeply than the operator assumes and can cause injury to deeper structures. For this reason, visualization of the needle tip at all times is crucial during angiocatheter insertion. It is easy to learn how to use ultrasound guidance when performing radial arterial catheterization in either the transverse or the longitudinal orientation. Clinicians who regularly insert arterial catheters should master this technique because it can increase the success rate and reduce the number of attempts required for successful catheterization as compared with the palpation method.
This is a video in clinical medicine from the New England Journal of Medicine.
The placement of a central venous line is an essential technique in the treatment of many hospitalized patients. This video will demonstrate the placement of a central venous catheter in the internal jugular vein with the use of one of several variations of the Seldinger technique. An additional video on subclavian line placement will be forthcoming. We will demonstrate and review the regional anatomy of the neck, indications for the insertion of a central line, the recommended site and technique for placement of a line in the internal jugular vein, selected complications associated with the procedure and suggestions for how to avoid them, and appropriate care of the line after it has been placed. The placement of a central venous line is indicated for the continuous monitoring of central venous pressure, the delivery of critical or caustic medications, for emergency resuscitation, hemodialysis, and pulmonary artery catheterization. General contraindications for the placement of a central venous line include infection of the area overlying the target vein and thrombosis of the target vein. Site-specific and relative contraindications include coagulopathy. Although this is not an absolute contraindication, extreme care must be exercised in patients with coagulopathy and in other patients for whom complications would be life-threatening. After the procedure has been explained and consent obtained, review the records to confirm that there are no contraindications and examine the patient, concentrating on the regional landmarks. The internal jugular vein can be found at the apex of the triangle formed by the sternal and clavicular heads of the sternocleidomastoid muscle just lateral to the carotid artery. To assure that there is the highest level of sterility, the operator should wear a sterile gown and gloves, as well as a surgical cap, mask, and face shield. Most of the equipment can be found in commercially prepared kits, and should include skin preparation solution, sterile towels or drapes sufficient to cover the entire body, 1% lidocaine, sterile 4x4 gauze, non-luer lock or slip-tip syringes, which are easy to remove from the needle, a number 11 blade scalpel, saline or heparinized flushing solution, a catheter with the appropriate length and number of lumens, a compatible skin dilator, usually 1 French larger than the line, an appropriate sized needle, a guide wire of compatible size, which will pass through the catheter and needle, suture, and a needle driver. There are numerous types of central venous catheters to choose from. 7 French triple lumen catheters of either 15 or 20 centimeter length are most commonly used in adults. For resuscitation or dialysis, Large bore catheters are preferable since there is less resistance to flow than the smaller bore types, allowing for much higher infusion rates, although large bore peripheral IVs often allow even more rapid fluid administration than central venous lines. For small adults and children, or for those in whom access to the jugular vein is difficult, 5 French and 4 French catheters can be used. If there are no contraindications, proceed by placing the bed in a 10 to 15 degree Trendelenburg position to decrease the risk of air embolism and to engorge the vein. Turn the patient's head so that the chin points away from the vein. Generally, the right internal jugular vein is preferred, since it provides a more direct approach to the superior vena cava. Remember, positioning is instrumental in the success of the procedure. Identify the triangle formed by the sternal and clavicular heads of the sternocleidomastoid muscle and the clavicle. Determine the location of the carotid pulse. The path of the vein runs just lateral to the carotid artery. The needle will enter the skin at the apex of this triangle just lateral to the carotid pulse and will be aimed toward the ipsilateral nipple. Following these landmarks can be challenging in the obese patient. Ultrasonographic guidance is becoming the standard of care in the placement of a central line. It can help to illustrate aberrations in the anatomy, facilitate rapid placement of the central line, and decrease the risk of inadvertent arterial puncture. To identify landmarks with the use of ultrasonography, the probe is placed directly on the needle insertion site. The vein and artery are identified on the image as circular and black. The vein is identified by applying gentle pressure with the probe. The non-muscular vein will collapse easily, whereas the artery will remain relatively circular. Prepare the area by scrubbing the skin with chlorhexidine for 60 seconds and drape the site. Be sure to include all landmarks within the sterile field. If the patient is conscious, explain that his or her face will be covered, but that breathing will not be obstructed, and that he or she can signal for attention by raising his or her hand. Flush the lumens of the central line with saline or heparin, and ensure that the guide wire threads easily through your needle. Remove the cap from the port through which the guide wire will be threaded. This is commonly the longer lumen. If using ultrasound, prepare the ultrasound probe with a long sterile sleeve, being careful not to contaminate the sleeve prior to placing it on the sterile field. During the placement of the line, any assistant or observer should feel empowered to halt the procedure if there is a break in sterile technique. Confirm the needle insertion site again. Generally, it is at the apex of the triangle, just lateral to the carotid pulse. During needle puncture, palpation of the carotid artery can be maintained with the non-dominant hand. In a patient who is awake or minimally sedated, the skin should be infiltrated with a local anesthetic, such as 1% lidocaine, with a 25-gauge needle to help minimize pain on insertion of the catheter. Using the insertion needle, approach the site at a 45-degree angle from the coronal plane, with the long axis of the needle directed toward the ipsilateral nipple. Puncture the skin at the apex of the triangle at the medial border of the sternal head of the sternocleidomastoid muscle, entering just lateral to the carotid pulse. Advance the needle while applying gentle suction to the syringe. Continue to aim toward the ipsilateral nipple at a 45-degree angle to the skin, avoiding penetration into the deep tissues of the neck. Typically, the vein is accessed at a depth of less than 1/2 inch, or 1.3 centimeters. When using ultrasonography, watch for the shadow of the needle to appear on the image. The needle can then be followed into the vessel with ultrasonographic guidance. When the internal jugular vein is entered, a flash of venous blood is obtained. Because of the collapsibility of the vein, this commonly occurs while the needle is being withdrawn, which tents the vein. Once the needle has entered the vessel and steady blood return has been obtained, maintain a steady position of the needle with the non-dominant hand while gently removing the syringe. Dark, non-pulsatile flow confirms access to the vein. Once the needle is in the vein and free flow of blood has been obtained, employ the introducer. Using the introducer, advance the curved end of the guide wire through the needle. An assistant should watch the monitor, looking for signs of arrhythmia during advancement of the guide wire. Arrhythmias indicate that the wire has reached the heart. If arrhythmias occur, withdraw the wire slightly until they cease. After the guide wire has been inserted, withdraw the needle, leaving the guide wire in place. As the needle exits the skin, be sure to grasp the guide wire at the skin. At this point, only the wire remains in place. Using an 11-blade scalpel, make a small superficial incision at the entry point of the wire to facilitate passage of the dilator through the skin. Be careful not to cut the wire. Place the dilator over the guide wire, being certain to maintain control of the wire at all times in order to prevent a wire embolism, and advance the dilator 1 to 2 centimeters by holding it close to the tip and rotating it. Be careful not to introduce a bend or kink in the guide wire. Remove the dilator, anticipating increased bleeding. Maintain a grasp on the wire. A 4x4 gauze pad can be applied to the insertion site to minimize blood loss. Once again, only the wire remains in place. Now, feed the catheter over the guide wire, being certain to maintain control of the external end of the wire before advancing the catheter through the skin. This usually requires that the wire be pulled slightly out of the patient until the external end of the wire extends out of the catheter hub and can be grasped. While grasping the external end of the guide wire, advance the catheter over the wire using a rotating motion. If resistance is met, the tract may not have been adequately dilated. Remove the catheter and try again to insert the dilator. Insert the catheter to a depth that places the tip at the junction of the superior vena cava and the right atrium. Remove the guide wire and check for blood return in all ports. Flush all ports, place caps on the hubs, and secure the line in place. Apply a sterile dressing. Obtain a chest X-ray to assess for proper placement and to assure that no hemothorax or pneumothorax has occurred. All sharps should be properly disposed in approved sharps containers. Scalpels should be retracted into their protective sleeves. Needle stick injury can be minimized by using needle lock devices found in most commercial central line kits. There are some common problems that can occur during placement of a central venous line. Puncture of the adjacent artery is usually obvious if pulsatile or bright red blood flows into the syringe. However, in patients with hypotension, hypoxemia, or both, it may be difficult to differentiate placement in the artery from that in the vein. The possibility of this complication should be recognized before the wire is inserted. If the catheter is in place and its location in the artery is suspected, the line should be connected to a transducing system. Pulsatility or any pressure higher than 30 millimeters of mercury or approximately 30 centimeters of hydrostatic pressure is probably arterial in nature. Ideally, transduction should occur before the wire is passed and should be performed routinely. If arterial puncture occurs, remove the catheter and place firm, direct pressure on the site for 10 minutes or until there is no further bleeding. Occasionally, air may be aspirated into the syringe. If this occurs, check the syringe to be sure that the needle or catheter and syringe are firmly attached. If so, immediately remove the needle or catheter since there may be a pneumothorax at that site. This is especially important if the patient is having symptoms of increasing respiratory distress. Immediately obtain a chest X-ray and insert a chest tube if necessary. For persistent bleeding at the catheterization site, apply direct pressure and check the results of coagulation studies. Replace blood products as necessary. If bleeding continues, there may be an arterial or venous tear that requires surgical exploration. In any of these circumstances, do not attempt to place the line at the opposite site, since you risk contralateral pneumothorax and further respiratory compromise. If arrhythmias are seen on the monitor, the line may be in the heart, in which case the line will need to be pulled back. By approximating the necessary length of the wire before catheterization and confirming its placement with a chest X-ray, this problem can be avoided. Always be sure to work within a sterile field when placing a central venous line, and to keep the site clean after placement to prevent local or systemic infection. If the wire will not thread through the needle, you may need to adjust the placement of the needle, since it may have inadvertently been advanced during manipulation. If so, adjust the needle and re-aspirate to be sure that you are still within the vessel. If you are unable to re-establish blood flow, remove the needle and start over. If the vein has been difficult to cannulate, the presence of a clot in the needle will further complicate assessment of whether the vein has been successfully entered. In this circumstance, remove the needle and flush it thoroughly with saline to clear it before re-attempting placement of the line. A sterile dressing should be placed on the insertion site. The dressing should be changed daily, and whenever blood or liquid accumulates or it loses its seal. In order to minimize the potential for infection in the central venous line, the following precautions should be observed. The number of times the line is accessed should be kept to a minimum. Each time the line is accessed, this should be done under either sterile or clean conditions. The access site should be prepared with an alcohol-based solution. There should be a daily assessment to determine whether the central line is still needed, so that it can be removed as soon as it is no longer necessary. A central venous line is a convenient and often necessary tool in the treatment of the critically ill patient. However, one must always be aware of the potential for infection.
This is a video in clinical medicine from the New England Journal of Medicine.
Evidence suggests that the risk of major central venous line complications, particularly line-related bloodstream infections, is lower when the subclavian approach is used. This video will identify the landmarks and procedure for placement of a subclavian central line. Specific contraindications for the placement of a central venous line in the subclavian vein include infection of the area overlying the target vein and thrombosis of the target vein, and fracture or suspected fracture of the clavicle or proximal ribs. Coagulopathy, while not an absolute contraindication, should be of greater concern with the subclavian approach because of the difficulty in applying direct pressure to the artery and vein as they pass under the clavicle. To assure that there is the highest level of sterility, the operator should wear a sterile gown and gloves, as well as a surgical cap, mask, and face shield. Most of the equipment can be found in commercially prepared kits, and should include skin preparation solution, sterile towels or drape sufficient to cover the entire body, 1% lidocaine, sterile 4x4 gauze, non-luer lock or slip-tip syringes, which are easy to remove from the needle, a number 11 blade scalpel, saline or heparinized flushing solution, a catheter with the appropriate length and number of lumens, a compatible skin dilator, usually 1 French larger than the line, an appropriate sized needle, a guide wire of compatible size, which will pass through the catheter and needle, suture, and a needle driver. There are numerous types of central venous catheters to choose from. 7 French triple lumen catheters of either 15 or 20 centimeter length are most commonly used in adults. For resuscitation or dialysis, large bore catheters are preferable since there is less resistance to flow than the smaller bore types, allowing for much higher infusion rates, although large bore peripheral IVs often allow even more rapid fluid administration than central venous lines. For small adults and children, or for those in whom access to the subclavian vein is difficult, 5 French and 4 French catheters can be used. If there are no contraindications, proceed by placing the bed in a 10 to 15 degree Trendelenburg position to decrease the risk of air embolism and to engorge the vein. Turn the patient's head so that the chin points away from the vein. A small roll can be placed under the spine to help make the clavicles more prominent. Identify the clavicle. The subclavian vein flows just under the middle third of the clavicle, while the artery runs posterior and superior to the vein. The middle third begins at the point where the clavicle angles posteriorly and is joined by the costoclavicular ligament. It is only in this middle third that the vein closely approximates the clavicle. Because ultrasonography does not penetrate bone, usage is more challenging than in internal jugular placement. But several articles suggest it facilitates placement. To identify landmarks using ultrasonography, place the probe just proximal to the insertion site. The vein and artery can be distinguished either by the compressibility of the vein or by using Doppler flow to demonstrate pulsatility in the artery. Prepare the area by scrubbing the skin with chlorhexidine for 60 seconds and drape the site. Be sure to include all landmarks within the sterile field. If the patient is conscious, explain that his or her face will be covered, but that breathing will not be obstructed, and that he or she can signal for attention by raising his or her hand. Flush the lumens of the central line with saline or heparin, and ensure that the guide wire threads easily through your needle. Remove the cap from the port through which the guide wire will be threaded. This is commonly the longer lumen. In a patient who is awake or minimally sedated, the skin should be infiltrated with a local anesthetic, such as 1% lidocaine, with a 25-gauge needle to help minimize pain on insertion of the catheter. Using the insertion needle, approach the site at a 30-degree angle to the skin, with the long axis of the needle directed toward the sternal notch. Puncture the skin just lateral to the middle third of the clavicle. Continue to aim toward the sternal notch with the needle tracking just beneath the clavicle, avoiding penetration into the deep tissues of the neck. Typically, the vein is accessed immediately beneath the clavicle, although needle penetration under the skin may reach several centimeters. An assistant should watch the monitor, looking for signs of arrhythmia during advancement of the guide wire. Arrhythmias indicate that the wire has reached the heart. If arrhythmias occur, withdraw the wire slightly until they cease. After the guide wire has been inserted, withdraw the needle, leaving the guide wire in place. Using an 11-blade scalpel, make a small superficial incision at the entry point of the wire to facilitate passage of the dilator through the skin. Be careful not to cut the wire. Place the dilator over the guide wire, being certain to maintain control of the wire at all times in order to prevent a wire embolism, and advance the dilator 1 to 2 centimeters by holding it close to the tip and rotating it. Be careful not to introduce a bend or kink in the guide wire. Remove the dilator, anticipating increased bleeding. Maintain a grasp on the wire. A 4x4 gauze pad can be applied to the insertion site to minimize blood loss. Once again, only the wire remains in place. Now, feed the catheter over the guide wire, being certain to maintain control of the external end of the wire before advancing the catheter through the skin. This usually requires that the wire be pulled slightly out of the patient until the external end of the wire extends out of the catheter hub and can be grasped. While grasping the external end of the guide wire, advance the catheter over the wire using a rotating motion. If resistance is met, the track may not have been adequately dilated. Remove the catheter and try again to insert the dilator. Insert the catheter to a depth that places the tip at the junction of the superior vena cava and the right atrium. Remove the guide wire and check for blood return in all ports. Flush all ports, place caps on the hubs, and secure the line in place. Apply a sterile dressing before removing the drape. Obtain a chest X-ray to assess for proper placement and to assure that no hemothorax or pneumothorax has occurred. All sharps should be properly disposed in approved sharps containers. Scalpels should be retracted into their protective sleeves. Needle stick injury can be minimized by using needle lock devices found in most commercial central line kits. There are some common problems that can occur during placement of a central venous line. Puncture of the adjacent artery is usually obvious if pulsatile or bright red blood flows into the syringe. However, in patients with hypotension, hypoxemia, or both, it may be difficult to differentiate placement in the artery from that in the vein. The possibility of this complication should be recognized before the wire is inserted. If the catheter is in place, and its location in the artery is suspected, the line should be connected to a transducing system. Pulsatility or any pressure higher than 30 millimeters of mercury or approximately 30 centimeters of hydrostatic pressure is probably arterial in nature. Ideally, transduction should occur before the wire is passed and should be performed routinely. If arterial puncture occurs, remove the catheter and place firm, direct pressure on the site for 10 minutes or until there is no further bleeding. Occasionally, air may be aspirated into the syringe. If this occurs, check the syringe to be sure that the needle or catheter and syringe are firmly attached. If so, immediately remove the needle or catheter since there may be a pneumothorax at that site. This is especially important if the patient is having symptoms of increasing respiratory distress. Immediately obtain a chest X-ray and insert a chest tube if necessary. For persistent bleeding at the catheterization site, apply direct pressure and check the results of coagulation studies. Replace blood products as necessary. If bleeding continues, there may be an arterial or venous tear that requires surgical exploration. In any of these circumstances, do not attempt to place the line at the opposite site, since you risk contralateral pneumothorax and further respiratory compromise. If arrhythmias are seen on the monitor, the line may be in the heart, in which case the line will need to be pulled back. By approximating the necessary length of the wire before catheterization and confirming its placement with a chest X-ray, this problem can be avoided. Always be sure to work within a sterile field when placing a central venous line, and to keep the site clean after placement to prevent local or systemic infection. If the wire will not thread through the needle, you may need to adjust the placement of the needle, since it may have inadvertently been advanced during manipulation. If so, adjust the needle and reaspirate to be sure that you are still within the vessel. If you are unable to reestablish blood flow, remove the needle and start over. If the vein has been difficult to cannulate, the presence of a clot in the needle will further complicate assessment of whether the vein has been successfully entered. In this circumstance, remove the needle and flush it thoroughly with saline to clear it before reattempting placement of the line. A sterile dressing should be placed on the insertion site. The dressing should be changed daily, and whenever blood or liquid accumulates or it loses its seal. In order to minimize the potential for infection in the central venous line, the following precautions should be observed. The number of times the line is accessed should be kept to a minimum. Each time the line is accessed, this should be done under either sterile or clean conditions. The access site should be prepared with an alcohol-based solution. There should be a daily assessment to determine whether the central line is still needed, so that it can be removed as soon as it is no longer necessary. A central venous line is a convenient and often necessary tool in the treatment of the critically ill patient. However, one must always be aware of the potential for infection.
This is a video in clinical medicine from the New England Journal of Medicine.
The ability to obtain peripheral intravenous access is an essential skill for all physicians. Although considered one of the simplest invasive procedures, mastering this potentially life-saving intervention requires refined skills and experience. Cannulating a vein, particularly a small one, can be challenging. The purpose of this video is to demonstrate how to access peripheral veins using an intravenous catheter. Peripheral intravenous catheterization is required in a broad range of clinical applications, including intravenous drug administration, for intravenous hydration, transfusions of blood or blood components, during surgery, during emergency care, and in other situations in which direct access to the bloodstream is needed. Relative contraindications to inserting a peripheral catheter in a specific site may include infection, phlebitis, sclerosed veins, previous intravenous infiltration, burns or traumatic injury proximal to the insertion site, arteriovenous fistula in an extremity, and surgical procedures affecting an extremity. Other situations may preclude obtaining peripheral intravenous access. For instance, extreme dehydration or shock may render cannulating collapsed peripheral veins impossible. Some patients may lack suitable peripheral veins because of prior chemotherapy or intravenous substance abuse. When access to peripheral veins is impossible, and in other situations in which accessing peripheral veins may take too long, insertion of a central venous or intraosseous catheter or peripheral venous cut-down may be required. A detailed understanding of the venous system of the upper and lower extremities will facilitate successful cannulation. The upper extremities have two primary venous systems: the cephalic vein, traveling on the radial side of the forearm, and the basilic vein, originating from the ulnar side of the forearm. Although venous anatomy may vary considerably from patient to patient, these two systems generally remain distinct, other than communicating at the antecubital fossa and the wrist. However, be careful to avoid inadvertently cannulating the brachial artery, which usually lies just medial to the median cubital vein. The same applies for the radial and ulnar arteries at the level of the wrist. Use careful palpation to identify arterial pulsations to minimize the possibility of this complication. The venous system of the lower extremities consists of the greater and lesser saphenous veins. The greater saphenous vein originates from the medial side of the dorsal venous arch of the foot, passes just in front of the medial malleolus, and follows the medial border of the tibia to the knee. The lesser saphenous vein originates at the lateral side of the dorsal venous arch, passes behind the lateral malleolus, and pierces the muscle fascia of the gastrocnemius muscle. Choosing a site for intravenous cannulation depends on many factors, including the intended use of the catheter, accessibility of the vein relative to the position of the patient's age and comfort, and the urgency of the situation. In general, upper extremity veins are preferred, as they are more durable and are associated with fewer complications as compared with lower extremity veins. The preferred cannulation sites are the veins of the forearm, particularly the metacarpal veins on the dorsal aspect of the hand, the median antebrachial vein, the cephalic vein, and the basilic vein. The median cubital vein, which crosses the antecubital fossa, is frequently cannulated in acute situations, as it accommodates large-bore catheters and may be easier to cannulate. When upper extremity veins are inaccessible, the dorsal veins of the foot or the saphenous veins of the lower extremity may be used. Cannulation of lower extremity veins is associated with a higher incidence of thrombosis and embolism, as compared with upper extremity veins. This risk is lower in children and infants. Therefore, the veins of the legs and feet are an acceptable alternative when cannulation of the upper extremities has failed. Other alternative intravenous cannulation sites include scalp veins, used in neonates and young infants, and the external jugular vein. Gather the equipment and have it ready at the bedside before beginning the procedure. You will need gloves, eye protection, a non-latex tourniquet, chlorhexidine-based antiseptic solution, sterile 2x2 gauze, a saline flush, a transparent occlusive dressing and tape, and appropriately sized catheter ranging from 14 to 24 gauge, an intravenous fluid bag with tubing, and a sharps container. A local or topical anesthetic may be required if the catheter is 20 gauge or greater. There are many catheters varying in style, length, and safety mechanisms. The two most common types of catheters are the over-the-needle catheter and the winged butterfly catheter. The butterfly catheter comes with attached tubing, whereas the over-the-needle catheter does not. For both catheters, the steel inner needle is removed, leaving only the plastic cannula in the vein. Different safety mechanisms have been developed to minimize the possibility of inadvertent needle sticks. Some catheters are equipped with a spring-activated retractable needle. Others have a protective clip that covers the needle as it is withdrawn from the plastic cannula. Needles should always be discarded appropriately in a sharps container. The size of the catheter selected will depend on the clinical situation. The smallest effective catheter should be used because small catheters allow for less resistance to blood flow around the cannula and are associated with fewer complications. Large catheters, such as 14 and 16 gauge, are used in acute situations for fluid resuscitation. For example, in managing hypovolemia in a trauma patient or in a patient with severe dehydration. Other factors that may influence the size of the catheter used include age-related vessel size, the need for pressurized boluses for administration of contrast or medication, and the viscosity of the fluid to be infused. Explain the procedure to the patient and address any specific questions or concerns. Discuss potential complications such as bleeding, bruising, and infection. You must follow standard precautions when placing a peripheral venous catheter. This includes washing hands, wearing gloves, and using eye protection because of the risk of blood splatter. When the selected site is in an upper extremity, the patient should be placed in the supine position with the arms supported. A comfortable position for the practitioner and proper lighting are important for successful intravenous cannulation. Tie the tourniquet with a half knot 8 to 10 centimeters above the targeted insertion site. Place the tourniquet flat against the skin and bring the tourniquet ends together, overlapping one another. Stretch the ends of the tourniquet and with one finger, tuck the top tail beneath the bottom, directing the end away from the puncture site. When evaluating a vein for cannulation, inspect and palpate the available veins. Gently tilt the extremity or adjust the angle of the light to reveal better the contours of the vessel. To palpate a vein, place 1 or 2 fingertips over the selected vein and gently apply pressure. Release the pressure to watch and feel the refilling rebound of the vein. An ideal vein feels round, firm, flexible, and full. Once you have selected the vein, clean the site with a chlorhexidine-based antiseptic solution using a back and forth motion. Allow the area to dry completely. Do not repalpate the area. If a larger gauge catheter is used, the site may be anesthetized with a local injection, topical cream, or ethylene glycol cryoanesthesia. To prepare the catheter, inspect the metal needle and plastic cannula for any damage or contaminants. Both should be smooth. Spin the hub of the plastic cannula to verify that it moves easily off the metal needle. Do not move the tip of the cannula over the bevel of the metal needle, as this could damage the end of the cannula. Superficial veins are displaced easily and need to be stabilized. Use your non-dominant hand to apply traction to the skin distal to the venipuncture site. If the catheter is placed in the dorsum of the hand, grasp the patient's hand with your non-dominant hand, fingers beneath the palm. Pull downward to flex the wrist, and use your thumb to keep the skin taut. If a forearm vein is selected, use your non-dominant hand to encircle the patient's arm. Place your thumb on the skin distal to the venipuncture site and pull down. Regardless of the venipuncture site, always maintain a firm grip on the patient's hand throughout the procedure. With your dominant hand, insert the metal needle bevel up at a 5 to 30 degree angle through the skin and into the vein. The angle used to approach the vein is dependent on the depth of the vein. A lesser angle is required for superficial veins. Do not insert the catheter too deeply, as this risks penetrating the far wall of the vein. When the catheter enters the vein lumen, watch for the initial flashback of blood, which will slowly fill the catheter chamber. Once the metal needle and plastic cannula are in the lumen, lower the catheter so that it is almost parallel to the skin. Hold the end of the catheter with the thumb and index finger of your dominant hand. Maintain tension on the vein and the skin, stabilize the needle, and carefully advance the catheter into the vein. When the catheter has entered the vein lumen completely, remove the tourniquet. To prevent blood loss from the open plastic cannula hub when the metal needle is removed, place direct pressure over the vein proximal to the end of the catheter and place a gauze pad beneath the cannula hub. Remove the metal needle from the plastic cannula and place it in the sharps container. Never attempt to reinsert the metal needle into the plastic cannula. Doing so may shear off the plastic cannula, releasing it into the bloodstream, resulting in a possible embolus. Make sure that the tourniquet has been released and confirm that the cannula is patent by flushing it with normal saline. The volume used depends on the size of the vein and the gauge of the catheter. Check that there is no swelling, redness, leakage, or discomfort around the insertion site. Attach the intravenous fluid tubing to the cannula and start the fluid infusion. Ideally, you should secure the cannula with a transparent occlusive dressing placed over the cannula hub. Confirm that the hub of the cannula is clearly visible through the dressing to facilitate monitoring. After securing the cannula with tape, loop the intravenous tubing and secure it away from the insertion site. Looping the tubing may prevent accidental displacement of the cannula, decrease cannula manipulation, and lower the risk of venous contamination or irritation. It is recommended that you write the date of insertion on the dressing to facilitate determining how long the cannula has been in place. To reduce the risk of infection, continue to review the indications for peripheral intravenous catheterization and remove the cannula as soon as possible. When a vein is difficult to see or to identify on palpation, several methods can be used to increase its dilatation. These include lowering the arm below heart level, gently tapping on the vein, instructing the patient to open and close his or her fist repeatedly, and applying a warm compress to the selected site for 3 to 5 minutes to increase vasodilatation. Transillumination or ultrasound may also be used to help locate a vein. These have been shown to improve the success rate of the procedure and to reduce the amount of time needed to perform it. Blood might flash back into the chamber if the tip of the needle has entered the lumen, but the cannula has not yet entered the vessel lumen itself. This problem can be avoided by reducing the angle of the catheter and advancing the needle a few more millimeters into the vein. A valve within the vein may prevent advancement of an inserted catheter. If this occurs, hold the cannula hub in place, remove the tourniquet, and connect the intravenous tubing to the cannula. Running fluid into the vein may open the valve and allow the cannula to be completely inserted. Occasionally, it is possible to advance the catheter when it is outside the vein or when the catheter has perforated the vein's opposite wall. Either of these situations can cause pain and swelling at the insertion site because the intravenous fluids are administered into subcutaneous tissue, When this occurs, the cannula should be withdrawn completely and another cannula should be placed at an alternative site. When a cannulation attempt is unsuccessful, the subsequent attempt should be performed in a vein proximal to the initial puncture site. The most common complications arising from intravenous cannulation are pain, bruising, bacterial infection, extravasation, possibly leading to necrosis, phlebitis, thrombosis, embolism, and nerve damage. Proper sterile technique and the selection of an appropriately sized catheter should help to avoid these complications. Ensure proper and adequate fluid administration or flush the site with saline to prevent the more serious complications of thrombosis and embolism. An attempt should also be made to prevent IV fluid bags from becoming empty, which may cause cannula obstruction from blood clots or the infusion of air. If fluid extravasation or thrombosis occurs, remove the cannula immediately and place a new line if needed. The chances of successful peripheral intravenous cannulation increase with meticulous attention to proper technique, the use of proper equipment, familiarity with anatomy, and a knowledge of a variety of approaches to accessing peripheral veins.
This is a video in clinical medicine from the New England Journal of Medicine.
The purpose of this video is to teach physicians, nurses, and other medical providers how to use ultrasound guidance to place catheters in peripheral veins. Placement of a peripheral intravenous, or IV catheter, is indicated for the administration of intravenous fluids and medications. Placement of IV catheters is a fundamental skill that all professional healthcare providers should possess. IV access may be difficult because of obesity, IV drug abuse, the placement of multiple previous IV catheters, and other factors. In these situations, ultrasonography can facilitate IV catheter placement by allowing visualization of veins that are not apparent on physical examination. It is reasonable to use ultrasound guidance after 2 failed attempts at standard IV catheter placement, and it may be best to use ultrasound guidance immediately if there has been a history of difficulties with IV access in the patient. We will review the proper technique for standard IV catheter placement and then demonstrate ultrasound guidance. We will limit our discussion to the upper extremity veins, but the same techniques can be used to cannulate any peripheral vein. To find the best site for an IV catheter, it is important to know the venous anatomy. The metacarpal and dorsal veins on the hand are good sites for initial cannulation attempts. The cephalic vein is usually prominent on the anterior radial aspect of the forearm. The basilic vein on the ulnar side of the forearm is often neglected because of its posterior position, but is usually prominent and often larger than the cephalic vein. In the medial antecubital region, the basilic vein is medial and the cephalic vein is lateral. The median cubital vein runs diagonally through the antecubital fossa, connecting the cephalic and basilic veins. Antecubital vein cannulation is common in emergency situations, but not ideal for long-term IV therapy. Proximal to the antecubital region, the basilic and cephalic veins are deeper and often inaccessible without ultrasound guidance. In addition, the deep brachial veins run down the middle of the upper arm, adjacent to the brachial artery. Blind cannulation of these veins has a high complication rate, but they can be safely accessed with ultrasound guidance. Before starting the procedure, collect the necessary supplies. You will need a tourniquet, an antiseptic swab, an adhesive dressing, a needle and catheter, a Luer lock adapter, and a saline flush. The most common IV catheter consists of an inner needle and an outer catheter. Common sizes range from 24 gauge for newborns to 14 gauge for adult trauma patients. Most IV catheters are about an inch long, but longer catheters are available for cannulation of deeper peripheral veins. Potential complications of IV catheter placement include phlebitis, thrombosis, infection, ecchymosis, hematoma, and infiltration. Wash your hands and use universal precautions. Apply the tourniquet. Palpate or visualize the vein. Veins should be soft, elastic, and resilient, and should be pulseless. Clean the skin with the antiseptic swab. Stabilize the vein with the fingertips of your non-dominant hand. Hold the needle with your dominant hand between your thumb and index finger. Make sure the bevel is pointed up. The needle approach should be along the course of the vein at an angle of 10 to 30 degrees to the patient's skin. Puncture the skin and then the vein with a quick forward motion so the needle tip penetrates the wall of the vein instead of just pushing it aside. When the needle tip enters the vein, there will be a flash of blood into the catheter. Decrease the angle of the needle and advance 1 to 2 millimeters further to ensure that the entire needle tip and the tip of the catheter are fully within the vessel. While holding the needle still, slide the catheter into the vein. Apply firm pressure to the vessel proximal to the tip of the catheter. Remove the needle and place it into a sharps container. Remove the tourniquet. Place the luer lock adapter on the end of the catheter. Anchor the catheter, adapter, and connection tubing to the skin using adhesive dressing. Flush the catheter with sterile saline. The flush should flow smoothly into the catheter. If there is resistance, the catheter may be kinked, occluded, or outside the vein. Look for signs of extravasation, such as pain, swelling, or blanching. Providers who are proficient at standard IV catheter placement will find it relatively easy to learn ultrasound-guided techniques. Novices need to understand a few basic ultrasound concepts. Ultrasound images are created by reflections of sound waves, so denser structures appear bright and fluid-filled structures appear dark. Changing the gain changes the brightness of all structures on the ultrasound image. Gain should be adjusted so vessels appear black and the surrounding soft tissue appears gray. The ultrasound image plane is several millimeters long in the longitudinal axis and only about 1 millimeter wide in the short axis. By convention, the top of the ultrasound image represents the skin surface and deeper structures are at the bottom of the image. There are centimeter marks on the sides of all ultrasound monitors, so it is always easy to determine the depth. Depth should be adjusted so that the target vessel is in the center of the image. Left-right orientation should also be easy because the symbol on the left side of the ultrasound image correlates with the indicator mark on the transducer. A linear array transducer with a frequency of 5 to 13 MHz is usually used for ultrasound-guided vascular access. Short linear transducers are made specifically for ultrasound-guided procedures. It's best to place the arm in a horizontal position so the ultrasound images and needle movements are in the vertical plane. Elevate the bed or sit down so that you are not bending or stooping, but working with your hands comfortably in front of you. Place the monitor so you don't need to turn your head or look over your shoulder to see the ultrasound images. There are two commonly used techniques for ultrasound-guided vascular access, the transverse technique and the longitudinal or in-plane technique. Transverse or longitudinal describes the orientation of the ultrasound plane with respect to the vein and the needle. In the transverse technique, the ultrasound plane is transverse to the vein and the needle, so the vein is circular and the needle is a single bright dot. With the longitudinal technique, the long axis of the vein and needle are in line with the ultrasound plane, so the vein appears as a tubular structure and the entire needle is visualized. The transverse technique gives less information, but is easier to learn and is recommended for novices. The longitudinal technique is more difficult to learn, but is preferred by many experienced providers. We will demonstrate these techniques and explain why it is best to learn both. Regardless of which technique is used during the procedure, start by evaluating the anatomy using the transverse approach. Transverse imaging provides a cross-sectional view of the anatomy and allows simultaneous visualization of veins, arteries, and other structures. It is important to align the transducer so that its left and right sides correlate with the left and right sides of the image on the monitor. Aim the transducer indicator in the same direction as the indicator symbol on the display, or simply touch one side of the transducer and look for movement on the monitor, then align the transducer as needed. In transverse images, the veins and arteries appear as circular structures. Veins are thin-walled and compressible. Arteries have thicker walls, are not compressible, and have visible pulsations. The easiest way to differentiate veins from arteries and ensure vessel patency is by simple compression. Using Doppler ultrasound is more difficult and unnecessary. Look for more distal veins first and move proximally as needed. The antecubital veins may be the best option in an emergency. In the upper arm, the basilic vein is often the best choice because it is usually large and does not have an accompanying artery. In the proximal upper arm, the basilic vein is fairly close to the brachial artery and the ulnar nerve, but distally it moves away from those structures. The cephalic vein is a good choice if it is large enough, because it is more superficial and has no accompanying artery or nerve. Cannulation of the deep brachial veins is possible with ultrasound guidance, but caution should be used because of the proximity to the brachial artery and the median nerve. Consider the following guidelines when choosing a site for ultrasound-guided IV catheter placement. Choosing a vein with a larger diameter improves the likelihood of success. Standard IV catheters are 3.2 centimeters long and usually adequate for cannulating veins less than 1 centimeter deep. Double-length catheters are available and adequate for veins up to 2 centimeters deep. Specialized equipment may be needed for veins deeper than 2 centimeters. Placing a peripheral IV does not require the operator to wear sterile gloves and a gown. However, hand washing, clean gloves, and universal precautions are indicated. Clean the ultrasound transducer thoroughly with a germicidal solution. Apply the tourniquet. Apply gel or surgical lubricant. Identify the target vein. Note the depth of the anterior wall of the vein. Clean the skin with an antiseptic swab. Insert the needle through the skin at an angle of about 45 degrees and adjust the trajectory as needed. Advance the needle toward the vein and look for the needle tip to appear on the ultrasound image. The needle tip will appear as a single bright dot with posterior shadowing or a repeating artifact. Follow the needle tip as you advance it by fanning or tilting the transducer in the direction that the needle is traveling. If you can't identify the needle tip, look for compression and movement of the adjacent soft tissue and tenting of the anterior wall of the vein. Subtly bouncing or vibrating the needle will cause movement of the soft tissue adjacent to the needle and may help you identify the position of the needle tip. Be careful not to advance the needle too deeply. Look for indentation of the anterior wall as the needle tip enters the vein. Watch for blood return. Decrease the angle of the needle and advance it 1 to 2 millimeters further to make sure the entire needle tip and the tip of the catheter are inside the vein. Hold the needle still and advance the catheter into the vein. Remove the needle and place it into a sharps container. Remove the tourniquet. Anchor and flush the catheter as previously demonstrated. The transverse approach is best for less experienced providers and when there is patient movement during the procedure, because it does not require perfect alignment of the transducer, the vein, and the needle. It also allows the operator to visualize the structures adjacent to the vein during the entire procedure. The problem with the transverse approach is that it can be difficult to visualize the needle tip and the ultrasound image can be deceiving. The needle may appear to be in the vein or more superficial when the tip is actually much deeper. The longitudinal or in-plane approach provides good visualization of the needle tip and vein, but it does not allow simultaneous visualization of surrounding structures, so always evaluate the anatomy transversely before attempting the longitudinal technique. Apply the tourniquet. Apply gel or surgical lubricant. Visualize the vein transversely and use simple compression to differentiate arteries from veins. Rotate the transducer 90 degrees and visualize the vein longitudinally. The transducer indicator can be aimed proximally or distally, depending on personal preference. However, it is crucial to know which side of the image represents the distal vein, because that is where the needle will enter the image. Hold the transducer with your thumb, index finger, and middle finger. Place your other fingers on the patient's skin so you can hold the transducer completely motionless during the procedure. Use an antiseptic swab. Carefully align the needle before insertion so that the trajectory will be precisely within the ultrasound plane. Puncture the skin just distal to the transducer. You should be able to clearly visualize the needle tip during the entire procedure, but this requires perfect alignment of the needle with the ultrasound plane. If you can't see the needle, it is lateral to the ultrasound plane. Back up and redirect the needle as necessary. Do not advance the needle unless you can see the tip. Visualize the needle tip inside the vein. Hold the needle still, advance the catheter, and watch it slide into the vein. Remove the needle and place it into a sharps container. Remove the tourniquet. Anchor and flush the catheter as demonstrated previously. Ultrasound guidance facilitates.
This is a video in clinical medicine from the New England Journal of Medicine.
Femoral venous catheterization is a rapid way to obtain intravenous access in hospitalized or emergency department patients. In this video, you'll learn how to safely place a femoral line. Placement of a femoral line may be indicated in the following situations: to obtain vascular access when peripheral access cannot be accomplished, to administer hemodialysis when access at a preferable site is not an option, to perform cardiac catheterization, or to administer large or caustic infusions. The following situations are relative contraindications: an uncooperative patient, the presence of infection, trauma, or distorted anatomy at the insertion site, obesity if it will significantly impair your ability to find the femoral vein, coagulopathy, and operator inexperience or lack of supervision. Femoral venous catheters, especially if left in place for more than a few days, are associated with an increased risk of infection and thrombosis as compared with subclavian and jugular lines. Therefore, if there is a safer insertion site, avoid performing femoral venous catheterization. When possible, explain the procedure to the patient and obtain informed consent before placing the catheter. In accordance with your institution's regulations and policies, go through your checklist and verify the patient's identity, check for contraindications, and then verify the procedure and site. A colleague should assist you with this process. Gather the necessary equipment. You will need intravenous fluid and tubing, additional anesthetic, a central venous catheter kit, and blood drawing equipment. You will also need a cap, face shield, sterile gown, and gloves. The basic components of a central venous catheter kit include chlorhexidine skin prep, a sterile drape and several pieces of gauze, ampules of lidocaine and saline, temporary and permanent sharps disposal cups, a syringe and small gauge safety needle for administering local anesthetic, a larger introducer needle for identifying the target vessel, a guide wire, a scalpel, a dilator, and a central venous catheter. Notice that each port on this triple lumen catheter is color-coded. The most distal port is brown. For securing the catheter, you will need either staples or sutures on a curved needle and a needle driver. A transparent adhesive dressing is needed to cover the insertion site. Review the anatomy shown here on a cadaver. The position of the femoral nerve, artery, and vein from lateral to medial can be remembered with the mnemonic navel, or nerve, artery, vein, empty space, and lymphatics, pointing to the navel in that order. The femoral vein can be found 2 centimeters beneath the inguinal ligament and 1 centimeter or approximately 1 finger breadth medial to the femoral artery pulsation. In a pulseless patient, you can approximate the location of the vein by placing your thumb over the pubic tubercle and your index finger over the anterior superior iliac spine. The vessels should lie within the web space. The head of the bed should be flat to minimize any flexion at the hip. Abduct the patient's leg away from the midline and externally rotate the hip. Assess the site with ultrasound whenever possible to confirm that the vein does not lie directly over or under the artery. This is the bifurcation of the femoral artery, and medial to it is the vein, which collapses when compressed. Before getting sterile, wash and sanitize your hands, and open the central line kit. Then, in a sterile fashion, mask, cap, gown, and glove yourself. Appropriate sterile technique has been shown to significantly decrease infectious complications. Prepare the central line kit. Add sterile saline for the line flush as well as extra anesthetic. Draw several milliliters of saline into a syringe and flush the catheter ports. Remove the cap from the distal port to allow the wire to pass during the final step of catheter placement. Test the seal between the needle and the syringe. The needle should detach easily. Adjust the wire so that the end is straight. Next, prepare the skin by applying chlorhexidine to the femoral region, using a much larger area than you would expect to need. Allow the skin to dry for at least 30 seconds, then drape the patient and place the wire on the sterile drape. Now, anesthetize the region. The amount of 1% lidocaine provided in standard kits is often too little and too short-acting. Obtain additional lidocaine with epinephrine or bupivacaine, both of which last about 2 to 4 hours. Use a syringe and a 25-gauge or smaller needle to deliver the anesthetic. Alternatively, you may use a longer, small-gauge finder needle to anesthetize deeper tissues. Test the site to confirm that the region has been properly anesthetized. Adequate analgesia will increase your patient's comfort and your chance of success. Several studies have shown that using ultrasound to assist in the placement of a central line increases success and reduces patient complications. This animation demonstrates how to scan the femoral region and accurately locate the femoral vein. The ultrasound screen shows a cross-section of the femoral vessels. Objects close to the probe appear at the top of the screen, whereas objects far from the probe appear at the bottom. Notice that the probe has a mark on one side. This index marker corresponds to the green dot on the monitor. Choose a linear, high-frequency probe for best resolution. Begin by covering the ultrasound probe with a sterile sleeve as shown. Apply gel to the inside and outside of the protective covering. Make certain to use a sterile gel on the outside. The ultrasound monitor should be facing you and placed to the side of the patient where you are standing. Position the probe with the orientation mark to the patient's right. Notice now that your left also corresponds to the left of the monitor. This is the artery, which is pulsating, and just medial to it is the vein, which collapses when compressed. Position the probe so that the vein is in the center of the screen. Insert the needle at the center of the probe and watch the monitor to see the needle pierce the vein. Once you see a flash of blood, take the ultrasound probe off the patient and continue with the procedure. The modified Seldinger technique minimizes the risks associated with intravenous catheter placement by locating the vessel with a needle and introducing a guide wire into the vessel lumen. There are 5 steps to proper technique. First, find the vein with the introducer needle. You will know when you are in the vein when non-pulsatile venous blood is identified. Second, advance the guide wire into the vessel lumen. Third, withdraw the needle and use a scalpel to cut the skin adjacent to the wire. Fourth, dilate a tract from the level of the skin into the vessel lumen. Fifth, advance the catheter over the guide wire into the vessel, while maintaining control of the guide wire at all times. When not using ultrasound, palpate the artery and insert the introducer needle at a 45-degree angle from the skin while aspirating with the plunger. To avoid an arterial stick, know where the artery is by maintaining palpation of the arterial pulse whenever you are advancing the needle. Now stabilize the needle with your other hand. This is the most common time for the needle to dislodge from the vein. Preserve the exact angle and depth of the needle by resting your hand on the patient. Detach the syringe with a twisting motion and thread the wire, holding the wire at all times. Remove the needle and use the scalpel to nick the skin at the site where the wire enters the body. Hold the scalpel so that the sharp end of the blade is away from the wire. Use the dilator to make a tract through the tissues. Hold it close to the skin and use a twisting motion to advance the dilator. There is often heavy bleeding from the insertion site after the dilator is removed, so be prepared to hold pressure with some gauze. Remove the dilator and thread the catheter onto the wire. Hold the wire at the skin while sliding the catheter forward. Do not let the catheter pass through the skin until the wire has passed out of the distal catheter port and you have grasped it firmly. Remember, do not let go of the wire. After you have threaded the catheter, remove the wire, aspirate blood from each port, and flush with saline or heparinized saline. Now that the catheter is in place, secure the catheter using the suture material or staples found in the kit. Be sure that the patient knows you are going to be securing the line. Confirm local anesthesia, and provide additional anesthetic if necessary. Staples are more convenient and decrease the risk of needle sticks, but may not secure the catheter as well as sutures. When you have finished, apply a sterile, transparent, occlusive dressing over the site. If there is good flow on initial aspiration, and the wire does not pass through the needle, remove the wire and reconfirm flow into the syringe. If you are unable to reaspirate blood into the syringe, it's possible that the needle has been advanced through or pulled back out of the vein. Adjusting the depth of the needle until blood can be aspirated will allow proper positioning of the needle for readvancement of the wire. If the wire will not pass despite good blood flow, flattening the angle of entry or twisting the wire in your fingers to change the direction of the distal end may allow passage of the wire. Never force the wire against resistance. It may be kinked or extraluminal. Femoral venous catheterization is not a risk-free procedure. The following are possible complications: infection, hematoma, arterial puncture, fistula, pseudoaneurysm, and catheter embolization. You may be able to prevent the development of a hematoma by reducing the number of attempts and applying pressure after withdrawal of the needle or catheter. If you puncture an artery, apply pressure to the site for at least 10 minutes. Infection risk can be minimized by applying a sterile dressing, reducing manipulation of the line, accessing the line under sterile or clean conditions, and removing the line as promptly as possible. After you have finished, be sure that all sharps have been removed from the patient's bedside and placed in a sharps container. Deposit the remaining trash in an appropriate receptacle.
This is a video in clinical medicine from the New England Journal of Medicine.
Traditionally, when internal jugular vein cannulation has been performed, external anatomical landmarks and palpation have been used to guide insertion of the needle into the vessel. However, depending on the operator's experience and the patient's anatomy, this procedure may be difficult or unsuccessful. Over the past decade, the increased use of ultrasound to guide internal jugular vein cannulation has improved success rates, reduced the time required to perform the procedure, and resulted in fewer complications. This technique requires an understanding of the neck anatomy as well as skill in performing and interpreting the results of the ultrasound examination. This video demonstrates the equipment and techniques used to carry out real-time ultrasound-guided internal jugular vein cannulation. Ultrasound-guided internal jugular vein cannulation is performed to establish central venous access for a variety of purposes, such as monitoring of central venous pressure, insertion of pulmonary artery catheters, administration of intravenous therapeutic agents and nutrition, performance of hemodialysis, and placement of cardiac pacemakers. This procedure is also used in other situations in which direct access to the central circulation is needed. General contraindications for internal jugular vein cannulation include infection of the placement site and suspected pathologic conditions affecting the internal jugular vein or superior vena cava, such as occlusion due to coagulopathy. Caution should be used when landmarks are distorted by trauma or other anatomic anomalies, such as a goiter. Be careful when using this site in patients who have had prior injury to the internal jugular vein, have very small internal jugular veins, or are morbidly obese. Under these circumstances, you should consider alternative sites, such as the contralateral internal jugular vein or subclavian vein. The femoral vein should be avoided because of a higher incidence of infection. Ultrasound is a non-ionizing form of imaging that is safe for use in patients of all ages, as well as in women who are pregnant. There are no contraindications specific to the use of ultrasound guidance when performing internal jugular vein cannulation. Central venous catheters vary in size, length, and number of infusion ports. The choice of catheter depends on the clinical circumstances. Commercially packaged catheterization kits are available. Kits may include drapes, disinfectant sponges, gauze pads, sutures with needles, a guide wire, a scalpel, a vein dilator, a penetration syringe, a guide syringe, an anesthetic syringe, and 1% or 2% lidocaine anesthetic solution. Ultrasound machines with linear array, high-resolution vascular transducers are preferred for this procedure. You will also need sterile transduction gel, an acoustically transparent sterile transducer sheath, and sterile rubber bands or clips to secure the sheath around the transducer. When possible, explain the procedure to the patient and obtain written informed consent. Complications such as infection and bleeding should be discussed. A procedural timeout and checklist must be reviewed before you start the procedure. Continuous electrocardiography and pulse oximetry monitoring should be maintained throughout the procedure. Place the patient in the supine position. If the central venous pressure is not elevated, place the patient in the Trendelenburg position with the head down 10 to 15 degrees to increase jugular filling and reduce the possibility of air embolism. Alternatively, venous pressure can be elevated by placing a wedge beneath the patient's legs. Caution is advised when situating patients with high intracranial pressure or congestive heart failure in these positions, as they may exacerbate these conditions. Rotate the patient's head slightly to the contralateral side of the chosen site. Minimizing head rotation lessens the chance of causing the common carotid artery to lie posterior to the internal jugular vein. When the vein overlaps the artery, a through and through puncture of the jugular vein may inadvertently lead to carotid artery puncture. You can minimize this possibility by making sure that the needle is not perpendicular to the vein as you advance it. Cannulation of the right internal jugular vein is generally preferred to cannulation of the left because it provides more direct access to the right atrium, avoids the thoracic duct, reduces procedure time, and is associated with fewer complications. The two heads of the sternocleidomastoid and the clavicle form a triangle at the anterior neck. The internal jugular vein may be accessed within this triangle, approximately 2 to 3 centimeters above the clavicle. Performing venous puncture higher in the triangle reduces the risk of pneumothorax and allows for better compression of the carotid artery in the case of inadvertent carotid puncture. Before starting the procedure, perform an ultrasound survey to assess the location and patency of the internal jugular vein and to evaluate the neck anatomy. Place the transducer so that the resulting image on the screen correlates with the orientation of the anatomy. Place the probe parallel and cephalad to the clavicle and along the sternocleidomastoid muscle. The common carotid artery and internal jugular vein should be easily identifiable. You will see the common carotid artery as a pulsating image, and it will be difficult to compress. The internal jugular vein is larger, easily compressible, and non-pulsating. Make sure that the internal jugular vein is patent by gently compressing the vein with the transducer. Slight pressure is sufficient to collapse the lumen of the internal jugular vein. Use Doppler color flow imaging to assist in identifying the vessels and determining flow. Doppler flow can be used to further identify the carotid artery and the internal jugular vein. You may place the transducer in either the cross-sectional or the longitudinal view. Placing the transducer in a standardized position during the ultrasound examination facilitates interpretation of the resulting images. Many probes have a marker on one side that corresponds to the same side of the image on the screen. This helps the operator to identify the correct orientation of the image. The longitudinal view aligns the large vessels and needle parallel to the ultrasound beam. In this view, the entire shaft and tip of the needle, as well as the course of a single vessel, can be visualized. The transverse approach aligns the anatomy and needle perpendicular to the ultrasound beam. Structures are visualized in cross-section, allowing you to identify both the internal jugular vein and the common carotid artery. If there is no contraindication, have the patient perform the Valsalva maneuver, which facilitates identification of the vein by increasing intrathoracic pressure and decreasing venous return. The maneuver will further dilate the internal jugular vein, helping to confirm its location. Whether you use longitudinal or transverse alignment of the transducer, you should try to locate the tip of the needle in relation to the ultrasound beam and the internal jugular vein. This is especially important when viewing the structures in cross-section, since the needle will appear as only a dot on the screen, and determining the exact location of the tip may be difficult. Evaluate the potential placement site with the use of ultrasound before establishing a sterile field. Confirm that the proposed vein is patent by ensuring that it is compressible. After you have identified an acceptable site for cannulation, you will need an assistant. Since performing central venous access carries the risk of infection, follow universal precautions when placing a central line. This includes hand washing, wearing a sterile gown, surgical cap, mask, eye protection, and gloves, and using a full-size sterile drape. Once the patient is positioned, prepare the skin using a chlorhexidine-based antiseptic and cover the area with a sterile, fenestrated drape. If the patient is not receiving general anesthesia, anesthetize the insertion site with 1% or 2% lidocaine. Take great care to avoid the intra-arterial injection of lidocaine, as even a small amount of the local anesthetic may precipitate central nervous system toxicity. Lidocaine should also be used for sedated patients in the intensive care unit. To prepare the ultrasound probe, have the assistant, who need not be dressed in sterile garb, dispense enough acoustic gel into a sterile transducer sheath to cover the transducer surface inside the sheath. Have the assistant carefully feed the probe into the sheath and through the gel, while extending the sterile sheath away from you over the length of the probe wire. Eliminate any wrinkles in the sheath and any air bubbles between the transducer and the sheath. Secure the sheath around the transducer using sterile rubber bands or plastic clips. To complete acoustic coupling, Apply a small amount of sterile ultrasound gel to the covered ultrasound probe or to the patient's skin. Because the sterile ultrasound probe is used intermittently throughout the procedure, it is necessary to identify a convenient sterile area on which the probe can be placed when it is not in use. This demonstration will illustrate the use of ultrasound guidance in a central approach in which the needle is inserted between the two heads of the sternocleidomastoid muscle for internal jugular cannulation. Position the transducer so that the internal jugular vein is centered in the resulting ultrasound image and between the two heads of the sternocleidomastoid muscle. Gently palpate the skin to confirm that the puncture will be between the muscle heads and not through one of the heads. Using an 18-gauge needle, puncture the skin at the center of the transducer, being careful not to damage the sterile sheath. Advance the needle at a 45-degree angle. As you advance the needle, maintain negative pressure in the syringe until the vein is punctured. When the needle passes caudally underneath the transducer, the needle, as well as soft tissue tenting, can be viewed on the ultrasound screen. While it may not be possible to see the needle clearly as it advances toward the vein, soft tissue tenting is almost always observed. After the needle has penetrated the tissues, the use of short in and out or tapping movements may help you to visualize the trajectory of the needle. In addition, the location of the needle tip may be visualized by tilting the transducer back and forth or by withdrawing the needle and realigning it. However, since ultrasonography does not necessarily confirm the location of the tip, look for aspiration of blood in the syringe. If you do not aspirate blood as the needle is advanced, slowly withdraw the needle while maintaining negative pressure. Venous puncture may become evident as you withdraw the needle. Occasionally, pressure from the ultrasound probe may compress the vein, making it difficult to enter the vessel. The tip of the needle may only compress the wall of the internal jugular vein rather than puncture it. This is more likely to occur when larger gauge needles are used. In this situation, a short, quick thrust may be sufficient for the needle to penetrate the lumen of the vein. As soon as blood is freely aspirated, place the probe in the predetermined sterile location, stabilize the needle, and disconnect the syringe. Confirm that the blood flow is non-pulsatile. Bright red pulsatile blood is suggestive of arterial puncture. However, dark non-pulsatile blood does not exclude the possibility of arterial puncture. Using the Seldinger technique, introduce a flexible guide wire through the needle and into the vein. While holding the guide wire in place, remove the needle. At this point, the guide wire within the lumen of the vein can be visualized on the screen in both cross-sectional and longitudinal views. If you have any doubt about the location of the wire, the blood pressure can be measured by advancing a small catheter over the wire and then removing the wire and connecting the catheter to a transducer. Once the possibility of arterial cannulation is excluded, reinsert the guide wire through the catheter and then remove the catheter while leaving the guide wire in place. Use a scalpel to make a small incision in the skin to widen the opening. Thread the guide wire through the distal opening of a dilator until it exits through the proximal end of the dilator. Confirm that it has reached the proximal end of the dilator, hold the wire in place, and advance the dilator through the skin and into the vessel. While holding the guide wire in place, remove the dilator. Bleeding frequently occurs after the dilator is withdrawn. Minimize it by applying pressure until the bleeding subsides. Insert the guide wire through the distal opening of the central venous catheter until it exits through the proximal end of the catheter. Secure the proximal end of the wire to prevent inadvertent advancement into the vessel and then advance the catheter into the vein. Hold the proximal end of the guide wire at all times when advancing the dilator or catheter. This avoids complications from unintended advancement of the guide wire. Using ultrasound, verify that the catheter is properly placed within the lumen of the vessel. Once proper placement is achieved, remove the guide wire and anchor the catheter to the skin with sutures. Each port should be flushed with saline solution and fluid should be administered as needed. Obtain a chest radiograph to confirm proper placement of the catheter. Cannulation of the internal jugular vein is an invasive procedure that can result in infection, air embolism, or death. Complications from mechanical injury include carotid artery puncture, skin hematoma, pneumothorax, hemothorax, and catheter misplacement. Mechanical irritation of the heart by the guide wire is also possible, and it may cause atrial or ventricular arrhythmias. If this occurs, withdraw the wire into the superior vena cava. Arrhythmias are usually transient, but if persistent, immediate attention is required. The unintended placement of a large bore catheter into the carotid artery, for example, a 9 French introducer, will be evident when bright red pulsatile blood appears. Such an event is an emergency and requires immediate consultation with a surgeon. Although ultrasound guidance is the recommended technique for internal jugular vein cannulation, complications may occur. Ultrasound-guided internal jugular vein cannulation should be considered complementary to the landmark technique, and its success depends on the provider's skill and understanding of ultrasound technique and function, as well as on his or her knowledge of neck anatomy. Proper use of ultrasound guidance can substantially minimize potential complications while reducing procedure time and facilitating proper catheter placement.
This is a video in clinical medicine from the New England Journal of Medicine.
The flow-directed balloon-tipped pulmonary artery catheter, also known as the Swan-Ganz catheter, permits measurement of intracardiac filling pressures. The catheter is inserted directly into the right atrium, right ventricle, and the pulmonary artery. The catheter permits measurement of the wedge pressure in the pulmonary artery, which approximates the left atrial pressure. The catheter also permits determination of cardiac output using various techniques. Pulmonary artery catheterization can be used to diagnose and manage pulmonary hypertension, cardiogenic shock, mixed shock states, cardiac tamponade, and mechanical complications of ST segment elevation myocardial infarction, known as STEMI, including right ventricular infarction, ventricular septal rupture, and papillary muscle rupture. Pulmonary artery catheterization is also part of the standard evaluation of patients being considered for heart or lung transplantation. Pulmonary artery catheterization should not be part of the routine treatment of patients who are undergoing high-risk surgery or who have septic shock, acute respiratory distress syndrome, or acute decompensated heart failure. In these populations, randomized trials have shown no benefits and possible harms. Instead, cardiac function and volume status should be assessed using non-invasive means, such as physical examination, measurement of serum B-type natriuretic peptide concentration, echocardiography, sonographic assessment of inferior vena cava diameter during respiration, and measurement of pulse pressure variation during respiration. Absolute contraindications include right-sided endocarditis or right-sided intracardiac masses or thrombi. Relative contraindications include severe coagulopathy or thrombocytopenia, which may complicate sheath placement and should be corrected before the procedure is performed. Exercise caution and consider using fluoroscopy in patients with tricuspid regurgitation, which makes catheter passage more difficult, and in patients with left bundle branch block, in whom catheter passage may induce complete heart block. To create a sterile field, you will need chlorhexidine and a sterile fenestrated drape and towels. You will also need a surgical cap, sterile gloves, a surgical mask with eye shield, and a sterile gown. To place the introducer sheath, you will need gauze, sterile saline flushes, a 25-gauge needle with syringe, 1% lidocaine, an 18-gauge introducer needle with syringe, a guide wire, a scalpel with a number 11 blade, the introducer sheath itself with an internal obturator, sutures, a needle driver, scissors, and an antibiotic-impregnated adhesive dressing. If the sheath is being placed with the use of ultrasound guidance, which is recommended, then you will also need an ultrasound device and probe, a sterile sleeve for the probe, and sterile conduction jelly. To place the pulmonary artery catheter, you will need the catheter, a plastic sleeve, sterile saline flushes, appropriate tubing, and an electronic pressure monitor, preferably one capable of displaying multiple tracings at the same time. Because arrhythmias may occur during placement of a pulmonary artery catheter, you should have resuscitation equipment on hand during the procedure. If you are placing a catheter in a patient with a left bundle branch block, you should be prepared to place a transvenous pacemaker in case complete heart block occurs. Finally, if you are going to use fluoroscopy, you will need lead aprons and thyroid guards for everyone in the room but the patient, who may be selectively shielded in a manner that does not cover the chest or interfere with sheath insertion. Before the procedure, review the design of the standard pulmonary artery catheter. The marks along the catheter indicate the distance from the tip. Thin marks indicate 10 centimeters, and thick marks indicate 50 centimeters. A proximal port, usually blue, connects to a lumen 30 centimeters from the catheter tip and is used to transduce right atrial pressures once the catheter is in its final position. A distal port, usually yellow, connects to the catheter tip and is used to transduce all pressures during catheter insertion or pulmonary artery pressures once the catheter is in its final position. Some catheters contain an additional port, usually clear or white, that connects to a second lumen 30 centimeters from the catheter tip and may be used for infusions. A pink or red port is used to inflate the balloon at the catheter tip. Use only the syringe packaged with the catheter, as it fills only to the balloon's capacity. When fully inflated, the balloon should completely encircle the tip of the catheter, which reduces mechanical trauma during insertion. It is essential that the balloon be inflated whenever the catheter is advanced, and then deflated whenever the catheter is withdrawn. The final port is connected to a thermistor near the catheter tip and can be connected to a computer for measurement of cardiac output by thermodilution. After you have obtained informed consent and have reviewed a checklist about the patient and the procedure with the treatment team, place the patient in the supine position. Select a central vein and, if possible, visualize it with ultrasonography to confirm its location and patency. The right internal jugular vein and the left subclavian vein are ideal sites because the curvature of the pulmonary artery catheter facilitates passage through the heart. Advancing the catheter from the left internal jugular vein, right subclavian vein, or femoral vein as shown here can be more challenging and often requires fluoroscopic guidance. After thoroughly washing your hands and donning the sterile garments and sterile gloves, prepare the skin over the vein with chlorhexidine. Place the sterile towels and drape over the patient. Cover the ultrasound probe with the sterile sleeve. Flush the ports on the sheath and the pulmonary artery catheter with sterile saline. Inflate the balloon at the tip of the catheter to ensure there is no air leak. And finally, slide the plastic sleeve over the catheter toward the ports. You will approach the central vein using the modified Seldinger technique, which involves accessing the vein with a needle, passing a guide wire through the needle, and then introducing the sheath into the vein over the guide wire. To begin, use the 25-gauge needle to infiltrate the skin with lidocaine. Next, advance the 18-gauge needle toward the vein while applying negative pressure to the syringe. If you are cannulating an internal jugular or femoral vein, use ultrasound to guide the needle. Once dark red, non-pulsatile blood is aspirated, remove the syringe from the needle and insert the guide wire. Use the scalpel to stab the skin adjacent to the needle and then carefully remove the needle. While stabilizing the guide wire to ensure that it remains accessible and does not embolize, insert the sheath and obturator over the guide wire until the hub of the sheath fills the incision. Remove the guide wire and obturator, leaving only the sheath. Using a sterile flush, test the port to ensure adequate blood flow. Instruct your assistant to connect the pulmonary artery catheter to the pressure monitor. While holding the catheter level with the patient's heart, instruct your assistant to set the pressure reading to 0. Orient the catheter so that its curvature follows its expected path, and insert the catheter into the sheath. Insert the catheter 15 centimeters so that its tip is outside of the sheath, then inflate the balloon. Continue to advance the catheter until a right atrial waveform is transduced. From an internal jugular or subclavian vein, the distance to the right atrium is typically 15 to 20 centimeters. The right atrial waveform has several identifiable components: an A wave, which indicates atrial contraction, an X descent, which indicates atrial relaxation and contains a small C wave, which indicates closure of the tricuspid valve, a V wave, which indicates passive atrial filling, and a Y descent, which indicates opening of the tricuspid valve and passive atrial emptying. Instruct your assistant to write down the mean right atrial pressure. Advance the catheter another 5 to 10 centimeters until a right ventricular waveform is transduced. This waveform is notable for a swift upstroke and downstroke, representing ventricular contraction and relaxation, as well as a slower upstroke, representing passive ventricular filling, followed by atrial contraction. Instruct your assistant to write down the systolic and diastolic right ventricular pressures. Next, advance the catheter another 5 to 10 centimeters until a pulmonary artery waveform is transduced. This waveform is distinguished from the right ventricular waveform by a decline rather than increase in pressure during diastole, an increase in overall diastolic pressure, and a dicrotic notch, which represents the closure of the pulmonic valve. Instruct your assistant to write down the systolic, diastolic, and mean pulmonary artery pressures. Continue to advance the catheter until the wedge pressure waveform is transduced. This waveform is similar to that of the right atrium, except that greater variation may be noted with respiration. Instruct your assistant to write down the mean pressure at the end of expiration, whether the patient is breathing spontaneously or receiving mechanical ventilation. Note that in mechanically ventilated patients, positive end expiratory pressure, or PEEP, may increase the measured wedge pressure. However, when the PEEP is less than 10 centimeters of water, the effect is typically negligible. Now, deflate the balloon. The pulmonary artery pressure waveform should reappear. If it does not, slowly withdraw the catheter until it does. Aspirate blood from the distal port to measure the mixed venous oxygen saturation. Measure cardiac output by connecting the thermistor to a computer and injecting a saline bolus into the right atrium. On a plot of temperature against time, the area under the curve is inversely proportional to the cardiac output. Fasten the plastic sleeve to the sheath and secure the catheter. Suture the sheath to the skin and apply an antibiotic-impregnated adhesive dressing over the wound. Obtain a portable chest radiograph to confirm appropriate positioning of the catheter and to rule out a pneumothorax. The tip of the catheter should not extend more than 4 or 5 centimeters beyond the midline. With the catheter in place, the right atrial and pulmonary artery pressures can be monitored continuously. The balloon can be periodically reinflated to reassess the pulmonary artery wedge pressure, but it should always be deflated afterward. Technical problems can occur during catheter insertion. If a right ventricular waveform cannot be obtained, the catheter may be coiling in the right atrium or exiting through the opposite vena cava. Tricuspid regurgitation may also be present and is suggested by large V waves on the right atrial tracing, which represent retrograde atrial filling. If a pulmonary artery waveform cannot be obtained, the catheter may be coiling in the right ventricle. In each instance, the balloon should be deflated and the catheter withdrawn about 10 centimeters. The balloon can then be reinflated and the catheter readvanced. If catheter passage remains unsuccessful, the procedure should be attempted again with fluoroscopic guidance. Common early complications include ventricular arrhythmias and right bundle branch block, which are generally self-limited. Complete heart block may occur in patients with pre-existing left bundle branch block. If complete heart block occurs, transvenous pacing may be necessary. In rare cases, the guide wire may embolize and become inaccessible, or the catheter may become knotted in one of the cardiac chambers, preventing withdrawal. A vascular surgeon or interventional radiologist must be consulted in either case. Two final complications, also the most dangerous, include air embolism and pulmonary artery perforation. Air embolism may occur if the ports of the catheter are not properly flushed with saline before the procedure, or if the saline-filled tubing becomes disrupted. Manifestations include dyspnea, chest pain, tachycardia, hypotension, and in some cases an acute increase in right heart pressures. The patient should be placed in Trendelenburg's position, which will limit the outflow of air from the right ventricle, and high-flow supplemental oxygen should be administered, as it reduces the nitrogen content of blood and thereby promotes reabsorption of air. In severe cases, hyperbaric oxygen must be provided. Pulmonary artery perforation is very rare. Identified risk factors include older patient age, prolonged balloon inflation, pulmonary hypertension, and systemic anticoagulation. The typical manifestations are hemoptysis, hypoxemia, and shock. If immediate action is not taken, the risk of death is extremely high. Inflate the balloon to limit further bleeding. Intubate the patient with a dual-lumen endotracheal tube, and then place the patient in the lateral decubitus position with the affected side down. A thoracic surgeon and interventional radiologist must be consulted immediately because this is a true emergency. Late complications include thrombosis, catheter-related infection, and pulmonary infarction. To reduce the risk of pulmonary infarction, ensure the catheter tip is in a position where full balloon inflation is required to measure a wedge pressure. Also, be sure to deflate the balloon after measurements of the wedge pressure have been completed. Normal right atrial mean pressure is 1 to 5 millimeters of mercury. Normal right ventricular systolic and diastolic pressures are 15 to 30 over 1 to 7 millimeters of mercury. Normal pulmonary artery systolic and diastolic pressures are 15 to 30 over 4 to 12 millimeters of mercury, with a normal mean of 9 to 19 millimeters of mercury. Finally, normal mean pulmonary capillary wedge pressure is 4 to 12 millimeters of mercury. You can calculate several additional values using the data obtained from the catheter. The cardiac output can be calculated with the Fick equation, shown here. The variables involved in these calculations include VO2, or oxygen consumption, Ca, the oxygen content of arterial blood, and Cv, the oxygen content of venous blood. The cardiac index is equal to the cardiac output divided by the body surface area, or BSA. For details about how to perform these calculations, see the supplementary appendix that accompanies this video, available at NEJM.org. Once cardiac output has been measured, systemic and pulmonary vascular resistances can be calculated with the equations shown here. The variables include SVR, or systemic vascular resistance, MAP, or mean systemic arterial pressure, RA, or right atrial mean pressure, PVR, or pulmonary vascular resistance, PA, or pulmonary artery mean pressure, and PCWP, or pulmonary capillary wedge pressure. Normal values for cardiac index and vascular resistance are shown here. In patients with shock of unknown cause, the pulmonary capillary wedge pressure, cardiac output, systemic vascular resistance, and mixed venous oxygen saturation can often help to guide the diagnosis. In cardiogenic shock, wedge pressure and vascular resistance are high, while cardiac output and mixed venous oxygen saturation are low. In the early phase of distributive shock, cardiac output and mixed venous oxygen saturation are high, and wedge pressure and vascular resistance are low. Finally, in hypovolemic shock, vascular resistance is high, and wedge pressure, cardiac output, and mixed venous oxygen saturation are low. It is possible to diagnose many more conditions by examining pressure waveforms. For a complete discussion, please consult the supplementary appendix that accompanies this video, available at nejm.org. Pulmonary artery catheterization yields hemodynamic data that may facilitate the diagnosis and treatment of patients with a wide range of cardiopulmonary conditions. When appropriate precautions are taken, the procedure is generally safe. However, all providers must be aware that because fatal complications can occur, the procedure should be performed only when the results are expected to aid clinical management.
This is a video in clinical medicine from the New England Journal of Medicine.
Abdominal paracentesis is performed as a diagnostic procedure to establish the etiology of new-onset ascites or to rule out spontaneous bacterial peritonitis in patients with pre-existing ascites. Large volume paracentesis is performed in hemodynamically stable patients with tense or refractory ascites to alleviate discomfort or respiratory compromise. Many patients undergoing paracentesis will have baseline coagulopathy or thrombocytopenia. However, the incidence of clinically significant bleeding during paracentesis is extremely low, and routine use of fresh frozen plasma or platelet concentrates is not recommended. Paracentesis should be avoided in patients with disseminated intravascular coagulation. The paracentesis needle should not pass through sites of cutaneous infection, visibly engorged subcutaneous veins, surgical scars, or abdominal wall hematomas. Extra caution should be used in pregnant patients and those with organomegaly, small bowel obstructions, or probable adhesions. When available, ultrasound guidance should be used to minimize the risk of intra-abdominal organ injury, especially in patients who are overweight and those with multiple surgical scars. There are various devices which are frequently assembled in prepackaged kits that can be used to perform paracentesis. You should be familiar with the specific devices available at your institution. For sterile preparation and administration of anesthesia, you will need a skin cleansing agent, sterile gauze, sterile gloves and drape, and a face shield. You will also need a skin marking pen, 1 or 2% lidocaine, a 10 milliliter syringe, and a 22 or 25 gauge needle. For collection of acidic fluid, you will need an over-the-needle catheter device, a 60 milliliter syringe, and high-pressure drainage tubing. You will also need specimen tubes, large evacuated containers, and a sterile occlusive dressing. In this video, we will demonstrate the use of a paracentesis-specific needle and catheter assembly. This device has a safety mechanism with a retractable blunt obturator. When pressure is applied to the distal end of the device, the obturator retracts and the bevel of the needle is exposed, allowing penetration of the tissues. An indicator at the top of the device will turn red whenever the obturator is retracted. Once the peritoneal cavity is entered, the obturator redeploys. This safety mechanism theoretically reduces the risk of organ injury. Additional advantages of paracentesis-specific devices include multiple distal drainage holes which facilitate rapid fluid removal, and a pigtail mechanism that curves the distal end of the catheter away from intra-abdominal structures during advancement. If such devices are not available at your institution, standard 18-gauge intravenous catheters may be used. The technique described in the following section is applicable to all over-the-needle catheters. Explain the procedure to the patient and obtain informed consent. Risks of bleeding, infection, intra-abdominal organ injury, and post-procedure hypotension should be discussed. Position the patient supine in the bed with the head slightly elevated. Recommended sites of needle insertion are 2 centimeters below the umbilicus in the midline and either the left or right lower quadrants. If a lower quadrant approach is used, confirm that the entry site is lateral to the rectus sheath to avoid puncturing the inferior epigastric artery. If the subumbilical approach is used, the bladder should be emptied before the procedure. If available, bedside ultrasound should be used to find an appropriate location that contains acidic fluid but is devoid of loops of bowel or solid organs. Mark the site of needle insertion with a skin marking pen. Paracentesis is a sterile procedure. Sterile gloves and a face shield are required. The use of a sterile gown is optional. Prepare the site with an antiseptic solution and then apply a sterile drape. Using a 22 or 25 gauge needle, anesthetize the superficial skin with a wheel of local anesthetic such as lidocaine. Continue to anesthetize the deeper tissues in the anticipated tract of the paracentesis catheter, intermittently pulling back on the syringe every 2 to 3 millimeters. Once peritoneal fluid begins to fill the syringe, inject additional anesthetic to anesthetize the highly sensitive parietal peritoneum. A total of 5 to 10 milliliters of lidocaine is generally used. Begin by making a small puncture in the skin with either a scalpel or large gauge needle to facilitate advancement of the paracentesis catheter. Next, advance the catheter through the epidermis. In this video, we will demonstrate an angular entry technique in which the cutaneous site of insertion does not directly overlie the site of penetration into the peritoneal cavity. Alternatively, a Z-tract technique may be used. In this method, the cutaneous tissues are pulled 2 centimeters caudad prior to needle insertion and advancement through the peritoneum. When the catheter is withdrawn at the end of the procedure, the cutaneous entry site will retract to its original position. Both techniques ensure that the cutaneous and peritoneal insertion sites do not directly overlie each other, theoretically minimizing the risk of an acidic fluid leak following the procedure. Intermittently pull back on the plunger as you continue to advance the needle through the subcutaneous tissue. Bedside ultrasound may be used to confirm proper placement. You may feel a sudden loss of resistance when the needle pierces the peritoneum. Immediately stop advancement once the acidic fluid begins to fill the syringe. Next, guide the plastic catheter over the needle and into the peritoneal cavity, and then remove the needle. If a diagnostic sample is required, attach a large syringe to the catheter and aspirate 30 to 60 milliliters of fluid for analysis. For therapeutic large volume paracentesis, attach the high-pressure tubing to the end of the catheter and then to an evacuated container. Further containers may be used for collection of fluid if necessary. Blood pressure and heart rate should be monitored during large volume paracentesis. Once the desired quantity of fluid has been removed, withdraw the catheter and apply a bandage. Aspirated fluid should be immediately placed into appropriate specimen tubes. A tube without additives should be sent for chemical analysis of albumin and total protein concentrations. An EDTA tube should be sent for evaluation of cell count and differential. Blood culture bottles should be inoculated at the bedside using aseptic technique if spontaneous bacterial peritonitis or other infection is a diagnostic concern. Specimens for other tests, such as cytology or mycobacterial culture, may be sent depending on the clinical scenario and are discussed in further detail in the accompanying written supplement. Analysis of the fluid begins with a determination of the serum ascites albumin gradient. Gradients higher than 1.1 grams per deciliter indicate that the ascites is due to portal hypertension. Gradients less than 1.1 grams per deciliter suggest other causes, such as cancer, infection, or pancreatitis. Post-paracentesis circulatory dysfunction may occur after large volume paracentesis and may lead to hypotension, hyponatremia, renal failure, and shortened survival. Although the use of albumin as a plasma expander is controversial, its use is recommended if more than 5 liters of fluid have been removed. Other complications of paracentesis include localized infection, abdominal wall hematomas, and persistent ascites fluid leak. More serious complications are rare and include hemorrhage, intra-abdominal organ injury, and inferior epigastric artery puncture.
This is a video in clinical medicine from the New England Journal of Medicine.
Thoracentesis is used diagnostically to establish the cause of a pleural effusion. It can also be performed to drain large effusions that lead to respiratory compromise. Limited data exist regarding the safety of thoracentesis in patients with coagulation abnormalities. The procedure is probably safe in patients with mild or moderate elevations of the prothrombin time or partial thromboplastin time. The decision to use fresh frozen plasma or platelet concentrates in patients with clinically significant coagulopathy or thrombocytopenia must be made on an individual basis. The procedure should be used with care in patients who are receiving mechanical ventilation, since positive pressure ventilation may bring the lung close to the thoracentesis needle and increase the risk of pneumothorax. Thoracentesis should be deferred in patients with severe hemodynamic or respiratory compromise until the underlying condition can be stabilized. In patients who have small or loculated effusions, the procedure should be performed by experienced operators, ideally with real-time imaging guidance. The thoracentesis needle should not pass through sites of cutaneous infection such as cellulitis or herpes zoster. Numerous devices which are frequently available in prepackaged kits can be used to perform thoracentesis. You should become familiar with the specific devices available at your institution. In this video, we will use a standard intravenous over-the-needle catheter assembly to demonstrate the procedure. For sterile preparation of the site and administration of anesthesia, you will need a skin cleansing agent, sterile gauze, sterile gloves, a sterile drape, a hemostat, which is optional, 1 or 2% lidocaine, and a 10 milliliter syringe with a 22 to 25 gauge needle. For the collection of pleural fluid, you will need an 18 to 20 gauge over-the-needle catheter, a 60 milliliter syringe, and a 3-way stopcock. You will also need sterile drainage tubing, specimen tubes and a large evacuated container, and a sterile occlusive dressing. Explain the procedure to the patient and obtain written informed consent. You should also verify the patient's identity, mark the correct site, and conduct a pre-procedural timeout. The timeout, which takes place immediately before the procedure is started, consists of confirmation by all members of the care team that the patient's identity, the procedure he or she is to undergo, and the site of the procedure are all correct. You will need an assistant to help position and monitor the patient and assist with the collection of pleural fluid. Place the patient in a sitting position on the edge of the bed with his or her arms resting on a table. The height of the effusion is determined by auscultation and percussion of the posterior chest wall. With a skin marking pen, mark the needle insertion site. The site should be 5 to 10 centimeters lateral to the spine and at least 1 or 2 intercostal spaces below the top of the effusion. The needle should not be inserted below the 9th rib. If available, bedside ultrasonography can be used to help visualize the effusion. In the patient in this video, the pleural effusion is easily visualized, as are the ipsilateral lung and the liver. Prepare the area with antiseptic solution and apply a sterile drape. Using a 25 gauge needle, place a wheel of local anesthetic such as lidocaine along the superior edge of the rib that lies below the selected intercostal space. Switch to a 22 gauge needle and begin to anesthetize the deeper tissues. The inferior surface of the rib must be avoided since the intercostal vessels and nerve are located in this region. At this point, walk the needle over the superior aspect of the rib, alternately injecting anesthetic and pulling back on the plunger as you advance. Once the needle enters the pleural space, pleural fluid will begin to fill the syringe. Inject more anesthetic at this point to anesthetize the highly sensitive parietal pleura. Note the depth of penetration and then withdraw the needle. If available, a hemostat may be attached to the exposed portion of the needle to mark the depth of the pleural space. Attach an 18-gauge over-the-needle catheter to a syringe and advance it along the superior surface of the rib. Keep pulling back on the plunger as you proceed to the predetermined depth of the pleural space. Once fluid is aspirated, immediately stop advancing the needle and guide the plastic catheter over the needle. When the catheter is fully inserted, remove the needle as the patient exhales or hums. The exposed hub of the catheter should be covered immediately with your finger to prevent the entry of air into the pleural space. Next, attach the three-way stopcock and large syringe to the catheter and continue to aspirate fluid. When this syringe is full, adjust the stopcock so that it is closed to the patient. The stopcock should be open to the patient only when fluid is being actively drained. If additional fluid needs to be drained for therapeutic purposes, attach the collection tubing to the stopcock and to the evacuated container. Open the stopcock to the patient and to the tubing and allow the evacuated container to fill. Generally, you should remove no more than 1,500 milliliters of pleural fluid. The removal of larger volumes may result in post-expansion pulmonary edema. On completion of fluid collection, you should rapidly remove the catheter as the patient holds his or her breath at end expiration. Cover the needle insertion site with an occlusive dressing and clean the surrounding skin. At the end of the procedure, make sure that all needles are placed into appropriate safety devices. Aspirated fluid should be placed in specimen tubes before the large evacuated container is filled or while it is filling. A tube without additives should be used for chemical analyses such as the measurement of lactic dehydrogenase, protein, and glucose levels. An EDTA-treated tube should be used for the cell count and differential count. Specimens for cytologic and microbiologic analyses and for other tests may be required depending on the clinical circumstances. These are discussed in further detail in the accompanying written supplement. Analysis of the pleural fluid will help differentiate a transudate, which is commonly caused by congestive heart failure or cirrhosis, from an exudate, which may be caused by processes such as bacterial pneumonia, cancer, or trauma. Pneumothorax is uncommon after thoracentesis, and when present, it rarely requires the placement of a chest tube. Chest radiographs are not required after simple, uncomplicated procedures. Radiography of the chest should be performed if air was aspirated during the procedure, if chest pain, dyspnea, or hypoxemia develops, or if the patient is critically ill or undergoing mechanical ventilation. Other complications of thoracentesis include pain, coughing, and localized infection. More serious complications include hemothorax, intra-abdominal organ injury, air embolism, and post-expansion pulmonary edema.
This is a video in clinical medicine from the New England Journal of Medicine.
Pericardiocentesis is indicated as an emergency procedure in patients with cardiac tamponade. Accumulation of fluid within the non-distensible pericardial sac can increase pressure on the heart, leading to impaired cardiac filling and decreased cardiac output. The use of emergency pericardiocentesis to aspirate the fluid can be a life-saving procedure that restores normal cardiac function and peripheral perfusion. The classic presentation of patients with pericardial tamponade includes Beck's triad of jugular venous distension, distant heart sounds, and hypotension. Most patients will have at least one of these signs. All three rarely appear simultaneously and then only briefly before cardiac arrest. Other signs of cardiac tamponade may include a pulsus paradoxus greater than 10 millimeters of mercury, an electrocardiogram with a low-voltage QRS or electrical alternans, or a chest radiograph with an enlarged cardiac silhouette. Recent clinical studies report that dyspnea and tachypnea are the two most common presenting features among patients with cardiac tamponade. The rate of pericardial fluid accumulation has a sizable effect on the rate of clinical decompensation. A patient with a rapidly accumulating pericardial effusion may present with severe respiratory distress, agitation, tachycardia, and hypotension before his condition quickly progresses to obtundation, bradycardia, and pulseless electrical activity. Patients at risk for pericardial tamponade include those with metastatic cancer, a history of mediastinal radiation, end-stage renal disease, tuberculosis, traumatic injury, and those who have recently had cardiac surgery. Pericardial tamponade should also be considered as a possible cause of cardiac arrest with pulseless electrical activity. Bedside ultrasonography can be used to identify pericardial fluid as well as features of pericardial tamponade. Practitioners without ultrasound expertise should consider consultation with a qualified radiologist or cardiologist. Pericardial fluid and diastolic collapse of the right atrium and ventricle are diagnostic of pericardial tamponade. A finding of a dilated inferior vena cava without respiratory variations in size further supports this diagnosis. Emergency intervention is required. Emergency pericardiocentesis is not indicated for a patient with a pericardial effusion and stable vital signs, as demonstrated here by the same actor portraying a stable patient. This condition should be monitored and appropriate medical management initiated, which may include a scheduled non-emergency drainage procedure. The combination of a traumatic pericardial effusion and unstable vital signs is a relative contraindication to emergency pericardiocentesis, since these circumstances are an indication for emergency thoracotomy. Although pericardiocentesis can be used as a temporizing measure, the patient will still require a thoracotomy since ongoing bleeding can cause a rapid reaccumulation of blood within the pericardium. Other relative contraindications to emergency pericardiocentesis include myocardial rupture, aortic dissection, and a severe bleeding disorder. However, there are no absolute contraindications in a patient whose condition is unstable and in whom emergency pericardiocentesis would relieve a life-threatening pericardial tamponade. Appropriate universal precautions for potential exposure to bodily fluids should be used when performing this invasive procedure. The materials needed for emergency pericardiocentesis include a code cart and resuscitation equipment, hemodynamic monitoring devices, a bedside ultrasound machine, an electrocardiogram machine, an 18-gauge spinal needle, a 3-way stopcock, a 20 cc syringe, antibacterial skin cleanser, a wire with alligator clips, and sterile gloves. Before beginning the procedure, palpate and identify the appropriate surface landmark for the immediate subxiphoid approach to pericardiocentesis, the xiphoid process. After donning sterile gloves, quickly wash a wide area of the patient's anterior chest wall and upper abdominal area using an antibacterial skin cleanser. Drape the area with sterile towels. During an emergency, local anesthesia is not typically used because of the time-sensitive nature of this procedure. However, when the clinical circumstances allow, use local anesthesia to enhance patient comfort. The patient depicted here has cardiac tamponade and pulseless electrical activity, which requires cardiopulmonary resuscitation and an immediate emergency pericardiocentesis. In a patient whose condition is more stable, consider raising the head of the bed by 30 to 45 degrees to permit more direct access to fluid collections. Draping will not be used here so that the viewer can see the surface landmarks. Ultrasound-guided pericardiocentesis is recommended because it allows direct visualization of the pericardial effusion as well as the needle used for drainage as it enters the pericardium. If an ultrasound machine is not available, electrocardiographic monitoring is recommended during the procedure to indicate when the needle makes contact with the myocardium. A blind approach can be attempted if neither electrocardiographic monitoring nor an ultrasound machine is immediately available, but this approach is often associated with unacceptably high morbidity and mortality as compared to one that incorporates ultrasonography or electrocardiography. Use bedside ultrasonography to identify the pericardial effusion and to guide your approach to emergency pericardiocentesis. The immediate subxiphoid approach to emergency pericardiocentesis begins just below the xiphoid process. Insert the spinal needle with the stylet in place to prevent dermal tissue from plugging the needle. Once the needle has punctured the skin, remove the stylet and attach a 3-way stopcock and a 20 cc syringe. Advance the needle toward the left shoulder while aspirating continuously. The internal images presented here show the needle entering the thoracic cavity and advancing toward the heart. After puncturing the pericardium, the needle enters the potential space surrounding the myocardium. Using real-time ultrasound imaging, guide the needle toward the largest collection of pericardial fluid. Withdraw fluid from the pericardial effusion by aspirating with the syringe. Removing even a small amount of fluid can lead to dramatic improvements in cardiac output and blood pressure. Once the needle is properly oriented to remove fluid easily, empty fluid from the syringe by attaching tubing to a 3-way stopcock. Continue to remove pericardial fluid until vital signs normalize and no further fluid can be removed from the pericardium. The parasternal approach is an alternative method for performing emergency pericardiocentesis. Insert the needle perpendicular to the chest wall in the 5th intercostal space, just lateral to the sternum. Use ultrasonography to locate the largest portion of the effusion that is close to the body surface and guide the needle into the pericardial sac to aspirate fluid. If ultrasonographic guidance is not available, attach a sterile alligator clip and wire to the spinal needle and connect the wire to a precordial lead on a continuous electrocardiographic monitor. As you advance the needle, monitor the electrocardiographic tracing for ST segment elevation, which indicates that the needle has been advanced too far and is in contact with the myocardial surface. If this occurs, withdraw the needle until ST segment elevation resolves, then redirect the needle to obtain pericardial fluid. Blind pericardiocentesis can be performed by entering the skin at a 45-degree angle and advancing the needle toward the left shoulder. Again, this approach to the procedure is associated with a higher rate of complications than when it is guided by ultrasonography or electrocardiography. The blind approach should only be used in an emergency, when neither of these two forms of monitoring is immediately available. After completion of the pericardiocentesis, visualize the heart with ultrasonography to confirm the removal of the pericardial fluid and adequate cardiac function. Continue with resuscitation as needed, depending on the patient's hemodynamic response to the procedure. Obtain a chest X-ray after the completion of pericardiocentesis to assess for complications such as pleural effusion or pneumothorax. Continue to monitor the patient for signs of hemodynamic instability and for physical findings that suggest fluid is continuing to accumulate in the pericardial sac. Definitive care may include placement of a soft catheter in the pericardial space or surgical placement of a pericardial window to allow for continuous drainage. As with any invasive procedure, complications can occur. Those most commonly associated with pericardiocentesis are cardiac dysrhythmias, cardiac puncture, pneumothorax, and coronary vessel injury. Other associated complications include peritoneal puncture, liver or stomach injury, puncture of the internal thoracic artery, diaphragmatic injury, and death. Emergency pericardiocentesis can be a life-saving procedure when pericardial tamponade is present. Ultrasound guidance is recommended to minimize the potential complications. After completing the procedure, continue to monitor the patient for signs or symptoms of recurrent tamponade until definitive care can be provided.
This is a video in clinical medicine from the New England Journal of Medicine.
The insertion of a pleural chest tube is often done in a setting where immediate action is required. Nonetheless, adherence to sterility, analgesia, sound technique, and safety are always warranted. The most common indications for chest tube drainage are pneumothorax that is recurrent, persistent, under tension, or bilateral, any pneumothorax in a patient on positive pressure ventilation, hemothorax, recurrent or symptomatic large pleural effusion, empyema, and chylothorax. There are relative contraindications, mainly based on hematologic abnormalities, such as bleeding diatheses or coagulopathy. Blood products or coagulation factors may need to be transfused in order to reduce the risk of bleeding during the procedure. The procedure should be explained and consent obtained whenever possible from the patient or next of kin. A chest X-ray should be performed when possible prior to the chest tube insertion. Sterilized and fully prepared chest tube trays are often available in the hospital. The key materials required in addition are a sterile gown, mask, and gloves, sterile drapes or towels, local anesthetics such as 1% lidocaine, chlorhexidine cleaning solution and sterile pieces of gauze, 25 and 21 gauge needles, 10 cc and 20 cc syringes, a scalpel with size 11 blade, which should be on the chest tube tray, at least 4 or 5 dissecting instruments, such as Kelly curved clamps or artery forceps, which should also be found on the chest tube tray, non-absorbable strong sutures of size 1.0 or greater made of silk or nylon, a chest tube of appropriate size, a sterile drainage system, and dressings for the tube after insertion. The chest tube is sized according to its internal diameter. The length of the tube is marked with numbers to indicate distance into the chest wall. Additionally, there are several drainage holes at the distal end. A radio-opaque stripe runs along the length of the tube and outlines the most proximal drainage hole. This is used to confirm correct placement of the chest tube in the pleural space on a chest X-ray. Choosing the size of chest tube is based on the indications for the tube. In the case of a large pneumothorax in a clinically stable, spontaneously breathing patient, chest tubes with an internal diameter of 16 to 22 French may be placed. In a patient with a large pneumothorax who is clinically unstable, the same rules for chest tube sizes apply. However, if the patient has underlying lung disease, requires mechanical ventilation, or is anticipated to have a large air leak, larger tubes from size 24 to 28 French are recommended. In order to drain a viscous hemothorax or empyema, or to evacuate a pneumothorax in a patient receiving mechanical ventilation, larger diameter tubes sized 28 to 32 French are more often employed. Newer evidence favors the insertion of smaller sized 10 to 14 French catheters, or pigtail drains, for the drainage of pneumothoraces in clinically stable patients, and for malignant pleural effusions. This is done using a Seldinger technique with a guide wire, and often with ultrasound guidance. This technique differs from that used for larger chest tubes and will not be discussed further in this video. Once the chest tube tray is open and all the key instruments are identified, occlude the proximal free end of the chest tube with a clamp or forceps. Next, with another clamp or forceps, grasp the distal end of the tube. This will aid in passing the tube through the tract. The patient should be positioned either supine or in the semi-recumbent position. The ipsilateral arm may be maximally abducted to the side of the patient, or, alternatively, positioned behind the patient's head in order to have optimal exposure of the insertion site. The ideal location for the placement of a chest tube is in the triangle of safety, the anatomical region defined by the lateral border of the pectoralis major muscle anteriorly, the mid-axillary line posteriorly, which is also the anterior aspect of the latissimus dorsi, the apex just below the axilla, and the horizontal level of the nipple inferiorly. The nipple line may be an unreliable landmark for female patients due to breast tissue. To help with landmarking, remember that the triangle of safety should approximately lie between the 4th and 5th intercostal space in the anterior axillary line. Start your landmarking by localizing the clavicle. Next, count the rib numbers as your fingers traverse down the anterior chest wall. Once the correct intercostal space is found, Move your hand along the space laterally towards the anterior axillary line. The incision will be made here. The chest tube will actually be inserted 1 interspace above this point. Mark the incision spot with the imprint of the back of a needle or a pen marking. Once full barrier precautions are employed, use the chlorhexidine cleaning solution and sterile gauze to create a large sterile field on the patient's skin. Cover the field with sterile drapes so that only the procedure site is exposed. Adequate analgesia is a very important step in this procedure, as chest tube insertions can often be very painful for the patient. The skin, subcutaneous tissues, deeper tissue layers, parietal pleura, and periosteal surface of the rib below the intended insertion site must be generously anesthetized. Using the smallest gauge needle, create a wheel of anesthetic in the skin overlying the landmark spot. Using the larger needle, anesthetize the subcutaneous skin layers through the wheel, aspirating as the needle moves deeper. Anesthetize the periosteum of the rib that lies below the intercostal space where the tube will be inserted. Once the parietal pleura is encountered, a flash of pleural fluid will fill the syringe if a pleural collection is being evacuated. If a pneumothorax is being drained, the syringe may only fill with air as the needle enters the pleural space. Withdraw the needle, aspirating along the entire path. Make an incision approximately 1.5 to 2 centimeters in length above and parallel to the anesthetized rib. Introduce the curved dissecting instrument, such as a Kelly clamp, into the incision. Begin dissecting the subcutaneous tissues in order to reach the intercostal muscles. After dissecting through the subcutaneous tissues, stay on top of the rib to guide the blunt dissection. This will create a diagonal path towards the correct intercostal space. When using a larger chest tube of sizes 24 French or greater, use your index finger to explore the tract being created by blunt dissection. This is done to ensure the larger caliber tube will be able to pass through the tract. Once you have dissected through the subcutaneous tissues and deeper intercostal muscle layers, you will encounter the parietal pleura. Push the clamp gently through the parietal pleura. The entry into the pleural space through the parietal pleura is felt as a give or a sudden release of resistance. Alternatively, you may use your finger to penetrate through to the pleural space. Once the pleural space is entered, use your index finger to ensure the lung is not adherent to the chest wall, which may impede passage of the tube into the pleural space. Often, pleural fluid will trickle out through the tract, further confirming entry into the pleural space. Pass the tube through the incision, unclamp the jaws of the Kelly, and then direct the tube through the tract slowly, using your finger as a guide. If the tube is meant to evacuate a pneumothorax, aim it apically towards the top of the lung. If the indication is to drain fluid, aim it basally towards the bottom of the lung. Make note of the depth the tube has passed by keeping track of the numerical markings on the side of the tube. Secure the chest tube to the skin using the heavy sutures. Simple interrupted or mattress sutures are often satisfactory to ensure stability of the tube and avoidance of air leaks around the tube. The free ends of the sutures are wrapped around the tube and tied multiple times to secure it in place. Purse string sutures are not recommended as they yield poor cosmetic results and increase the risk of skin necrosis. Once the chest tube has been secured, a petroleum-based gauze dressing should be wrapped around it. Apply several pieces of sterile gauze around the tube. Secure the site with multiple pressure dressings. A chest X-ray must be done to confirm correct placement. On an X-ray, the radio-opaque stripe is visible with an interruption indicating the position of the proximal hole. This hole must be within the pleural space. Otherwise, it is sitting outside the pleura and not draining effectively. This is an indication to replace the tube altogether. Do not advance the tube into the chest, as this can introduce non-sterile tubing into the chest cavity. Before unclamping the free end of the chest tube, firmly connect it to the sterile drainage system. Now unclamp the free end. If pleural fluid is being drained, the fluid level in the drainage system will rise. If a pneumothorax is being evacuated, air bubbles will appear. Do not reclamp the chest tube while there is bubbling. This may lead to recollection of a pneumothorax and may even result in a tension pneumothorax. Most commercially available drainage systems use the 3-bottle model of closed drainage and suction. The most important bottle is the underwater seal, which serves as a one-way valve that allows air and fluid to leave the pleural cavity without the risk of re-entry during inspiration. All available pleural drainage systems contain the underwater seal bottle. Bubbling may be seen in this bottle. This will indicate whether there is an ongoing air leak either from the patient or from the system itself. The 2 other bottles that may be present in the drainage system are a collection bottle connected directly to the patient for accumulation of pleural fluid and/or debris, and a suction system that connects to wall suction but regulates the amount of suction actually delivered to the pleural space via a column of sterile water. Suction may be applied if there is a persistent pneumothorax despite the underwater seal, or if a viscous pleural collection is not draining effectively. When evacuating chronic large pleural effusions, the risk of re-expansion pulmonary edema has been well described. A stepwise approach to the drainage of chronic large pleural effusions is recommended, not exceeding 1 to 1.5 liters within a 30-minute period. The pleural drainage system must be kept approximately 40 inches below the patient in order to prevent retrograde flow of air or fluid back into the pleural space. There are complications associated with the insertion of a chest tube. These include bleeding and hemothorax, traumatic perforation of the lung, heart chambers, diaphragm, or intra-abdominal organs, intercostal neuralgia due to trauma of the intercostal neurovascular bundle, intermittent blocking of the tube with clot or debris, subcutaneous emphysema, re-expansion pulmonary edema due to more than 1 to 1.5 liters of fluid drainage in less than 30 minutes, infection of the drain site, and empyema. The timing of chest tube removal depends on the indications for the chest tube. In the case of a pneumothorax, bubbling must have ceased, the patient stabilized clinically, and the lung re-expanded on a chest X-ray as minimal criteria to remove the tube. If suction is being applied to evacuate the pneumothorax, most clinicians perform a trial of underwater seal alone in order to ensure there is no further bubbling with the suction turned off. Most physicians will perform a chest X-ray 12 to 24 hours after the last evidence of an air leak prior to removing the tube. The decision to clamp the chest tube to check for a persistent air leak is one that is practitioner dependent, and there is insufficient data to support or refute this practice. If the chest tube was placed to drain pleural fluid, once the drainage volume is less than 200 cc's in a 24-hour period and the fluid is serous, the tube may be removed. If a chest tube was placed for empyema, removal of the tube should be considered only after the patient has stabilized clinically and the drainage criteria are met. If an air leak is persistent or the pleural fluid drainage criteria are not met, a pulmonary specialist or thoracic surgeon should be consulted for more definitive, potentially surgical management. Pneumothorax risk is no different after chest tube removal during end inspiration versus end expiration. Once the sutures are removed, instruct an awake patient to hold his or her breath either after a full inspiration or full expiration, or while performing a Valsalva maneuver. Pull the tube at end expiration if a patient is being mechanically ventilated. Ideally, 2 clinicians should be present during tube removal. Once the tube is removed, quickly seal the incision site with a petroleum-based gauze, reinforced with several pieces of regular gauze on top of it. Secure the site with a pressure dressing. Additional sutures may be required to close the incision. A follow-up chest X-ray should be obtained 12 to 24 hours after the tube has been removed. Closely inspect for any suggestion of a new pneumothorax. Caution must be exercised when removing a chest tube from any patient on a mechanical ventilator, especially in those with high oxygen or positive pressure requirements, chronic lung disease, or other risks for recurrent pneumothorax. Experienced physicians should supervise the decision to remove the tube in these cases. The insertion of a chest tube is often done under extremely critical circumstances. However, using the appropriate techniques and sterile precautions will ensure safe and efficient performance.
This is a video in clinical medicine from the New England Journal of Medicine.
Pneumothorax refers to the presence of air in the pleural cavity. Primary spontaneous pneumothorax may occur in an apparently healthy person who has no other signs or symptoms of a disease process that may have caused the pneumothorax. Observation and oxygen therapy may be the only treatments that are necessary for patients who have small, primary spontaneous pneumothorax. However, for patients with pneumothorax and clinically significant breathlessness, active intervention is required. This may include needle aspiration or the placement of a chest tube. This video reviews the techniques and equipment required to perform needle aspiration of primary spontaneous pneumothorax in adults. Ultrasonography can be helpful in confirming the presence of pneumothorax, in locating the landmarks for catheter insertion, and in determining the depth of catheter insertion. Since local practices and equipment availability vary greatly, ultrasound-guided insertion will not be addressed in this video. Needle aspiration is appropriate for patients with their first episode of primary spontaneous pneumothorax. These patients should have no evidence of underlying lung disease and should either exhibit breathlessness or have a pneumothorax consisting of a rim of air of more than 2 centimeters measured at the level of the hilum. Needle aspiration is contraindicated when a patient has traumatic pneumothorax or when tension pneumothorax is suspected. Hemodynamic instability also constitutes a contraindication. You should also avoid using needle aspiration in patients with underlying pulmonary disease, a history of recurrent pneumothorax, bilateral pneumothorax, or a bleeding disorder. Numerous devices can be used to perform needle aspiration. You should be familiar with the specific devices available at your institution. In this video, we will use an intravenous over-the-needle catheter to demonstrate the procedure. Begin by gathering the necessary equipment. The equipment needed for aspiration includes a 16-gauge or 18-gauge over-the-needle catheter, tubing with a 3-way stopcock, and a 50 milliliter or 60 milliliter syringe. To administer local anesthesia, you will need 1% or 2% lidocaine, a 10 milliliter syringe, and 22-gauge and 25-gauge needles. You will also need sterile gloves, a protective or sterile gown, a face mask, chlorhexidine or another antiseptic solution, a sterile preparation kit, and a sterile drape. Explain the procedure to the patient and obtain written informed consent. Confirm the patient's identity, the indication for needle aspiration, and the absence of contraindications. Confirm that the patient has no allergy to lidocaine and verify whether the pneumothorax is on the right side or the left side. Place the patient in a semi-supine position with the torso at a 30 to 45 degree angle to allow the air to collect at the apex of the lung. Administer oxygen and monitor the patient for pulse oximetry, heart rate, and blood pressure. An intravenous catheter should also be in place. Finally, provide the patient with a face mask. Rub your hands with an alcohol-based formulation and then examine the patient to determine the location of landmarks for the procedure. The preferred location for placement of a needle for aspiration of pneumothorax is the second intercostal space in the midclavicular line on the side with the pneumothorax. Begin by locating the second and third ribs. The second rib is the first palpable rib that can be felt just below the collarbone. Then locate the third rib. The second intercostal space is the area between the second and third ribs. Next, identify the middle of the clavicle and the midclavicular line. The intersection of the midclavicular line and the second intercostal space is the correct place to insert the needle for aspiration of pneumothorax. It can be helpful to mark the needle insertion site with a skin marking pen. Use a checklist to make sure that all the necessary equipment and supplies are ready for use and within easy reach. Put on a face mask, a protective or sterile gown, and sterile gloves. Use chlorhexidine or another antiseptic solution to clean the patient's skin in the area where the aspiration will be performed. And position the sterile drape. Aspirate lidocaine into the 10 ml syringe for use as a local anesthetic agent. Using a 25-gauge needle, inject a wheel of lidocaine at the superior edge of the third rib at the midclavicular line. Switch to a 22-gauge needle and anesthetize the deeper layers of tissue by inserting the needle at an angle perpendicular to the skin. Before injecting the anesthetic, always aspirate the site to make sure the needle has not entered a blood vessel. Progress with the needle just over the top of the third rib through the intercostal muscles in the direction of the pleural space. This will prevent injuries to the intercostal vessels and nerves, which lie just below the rib. Once you have inserted the needle through the intercostal space, continue to aspirate slightly. When you penetrate the pleural space, air bubbles will appear as you aspirate. Before you remove the needle, note the depth of penetration. You will use the depth as a reference point when you insert the over-the-needle catheter. Connect the over-the-needle catheter to the 10 ml lidocaine syringe, which should be partially filled with the remainder of the local anesthetic. Stabilize the skin with the non-dominant hand and puncture the skin with the catheter using the same landmarks that you used for the local anesthetic. Continue to aspirate with the syringe, slowly progressing in the direction of the pleural space. Again, when the needle penetrates the pleural space, air bubbles will appear in the syringe. At this point, move the needle forward a few millimeters to allow the catheter tip to fully penetrate into the pleural space. The appearance of air bubbles will confirm that the catheter has progressed into the pleural space. Ask the patient to exhale or cough to prevent air from being sucked into the pleural cavity. Remove both the catheter and the 10 ml syringe. Immediately cover the opening of the catheter with your finger to prevent the entry of additional air into the pleural cavity. Attach the tubing with the three-way stopcock to the catheter. Use the 50 or 60 ml syringe to gently aspirate the air from the pleural space. Evacuate it through the side port into the ambient air. The correct manipulation of the three-way stopcock is crucial, as the connection of a side port to the ambient air will entrap air in the pleural space and increase the pneumothorax. Numerous models of stopcocks exist, and you should be familiar with those used in your institution. The three white arms of the stopcock used in this video point to an open side port, while the side without an arm points to an obstructed side port with a closed end. When air is being aspirated from the pleural space, The stopcock should be open between the patient and the syringe, but closed to the ambient air. To evacuate the air into the ambient air, you must turn the stopcock so that the syringe is connected with the environment, but not with the patient. Make sure that the pleural space is never connected with the environment while you are turning the stopcock. Measure the volume of the air that is aspirated by counting the number of syringes evacuated. If more than 2.5 liters have been evacuated, the procedure should probably be stopped because such a large volume suggests that there is an air leak. Continue manual aspiration until you cannot aspirate any more air. Remove the catheter, put a sterile dressing on the site of insertion, and order a post-procedural chest radiograph to be obtained with the patient in an upright position. When needle aspiration is successful, the patient's symptoms will improve, and no pneumothorax, or only minimal residual pneumothorax, should be visible on the post-procedural chest film. Most patients are ready for discharge approximately 6 hours after the procedure. If a second post-procedural chest radiograph shows no indication that the pneumothorax has reappeared. The timing of patient discharge will vary according to the institution. Minor complications from needle aspiration of primary spontaneous pneumothorax include localized subcutaneous emphysema. Although serious complications are rare, lung laceration, air embolism, infection, or bleeding may occur. You can minimize the risk of bleeding by placing the catheter at the intercostal space just above the third rib, thereby preventing injuries to the intercostal vessels. Technical failure may occur if you cannot reach the pleural space, if the catheter is too short, for instance. This problem most often arises in patients who are very muscular or obese. Aspiration of more than 2.5 liters of air can indicate the presence of a persistent air leak. If this happens, consider the placement of a chest tube. Needle aspiration is an alternative treatment to the placement of a chest tube for patients with a first episode of primary spontaneous pneumothorax. After local anesthesia is administered, the intrapleural air can be evacuated through a large bore venous catheter. The success of the procedure is confirmed by clinical improvement and by a chest film showing no or minimal residual pneumothorax.
This is a video in clinical medicine from the New England Journal of Medicine.
This video will demonstrate safe and successful methods of performing lumbar puncture. Lumbar puncture is indicated for both diagnostic and therapeutic purposes. Also, the administration of spinal and epidural anesthesia involves the use, essentially, of the same technique. Analysis of cerebrospinal fluid may be helpful in the diagnosis of infectious processes such as meningitis, inflammatory diseases such as multiple sclerosis, cancers such as leukemia, and metabolic processes. Therapeutically, lumbar puncture allows for the intrathecal administration of chemotherapeutic agents and antibiotics. There are specific contraindications to lumbar puncture. The condition of patients with cardiorespiratory compromise may worsen as a consequence of the position they need to assume for lumbar puncture. The procedure should also be avoided in patients with signs of cerebral herniation, incipient herniation, or increased intracranial pressure, and in those with focal neurologic signs. In such patients, cranial CT should be performed before lumbar puncture, although CT may not reveal signs of increased intracranial pressure. Finally, there is an increased risk of a spinal hematoma if a coagulopathy is present or if the patient is receiving anticoagulant therapy. Patients who have previously undergone lumbar surgery should be referred to an interventional radiologist. Before performing the lumbar puncture, you will need a commercially available tray containing the necessary supplies, a spinal needle with a stylet, equipment for skin preparation, drapes, collection tubes, and in some cases a manometer. Typically, a 20 to 22 gauge needle is used, with the length ranging from 1.5 inches or 3.8 centimeters for infants to 2.5 inches or 6.3 centimeters for children and 3.5 inches or 8.9 centimeters for adults. You will also need sterile gloves. Before you begin, you should explain the procedure along with potential risks and benefits to the patient and obtain informed consent from the patient or his or her parent or guardian. After obtaining appropriate patient consent, the patient is positioned. Either the lateral recumbent position or a sitting position can be used. The lateral recumbent position is preferred to obtain an accurate opening pressure and to reduce the risk of post-puncture headache. Instruct the patient to assume a fetal position or to arch like a cat with the back flexed. This position widens the gap between the spinous processes. Ideally, the lumbar spine should be perpendicular to the table if the patient is in the sitting position and parallel to the table if he or she is in the lateral recumbent position. These positions help keep the needle at the midline. A line is visually drawn between the superior aspects of the iliac crest and intersects the midline at the L4 spinous process. Insert the needle in the interspace between L3 and L4 or L4 and L5, since this location is below the termination of the spinal cord. Palpate the landmarks before preparing the skin and before administering local anesthesia, since the anesthesia may make landmarks harder to identify. Use a skin marking pin to identify the site of needle insertion. While wearing sterile gloves, clean a sufficiently large area of the overlying skin with a disinfecting agent, such as chlorhexidine or providone iodine, using a pattern of widening concentric circles. Drape the area with sterile drapes. Lay out the collection bottles in the order of priority for the diagnostic indications. Lumbar puncture is a painful and potentially anxiety-provoking procedure. At a minimum, the use of a local anesthetic is appropriate. Sedation or systemic anesthesia may be required under some circumstances. You can apply anesthetic cream topically before preparing the skin. After preparing the skin, you can inject local anesthetics subcutaneously. Identify the anatomical landmarks once again, and insert the needle, with stylet firmly in place, in the midline at the superior aspect of the inferior spinous process, directing it at an angle of approximately 15 degrees, as if aiming at the patient's umbilicus. Either use a pencil-tipped needle or assure that the bevel of the needle is in the sagittal plane so as to spread rather than cut the fibers of the dural sac. These fibers run parallel to the spinal axis. The use of this needle position should theoretically decrease the leakage of cerebrospinal fluid. If properly positioned, the needle should pass through the skin, the subcutaneous tissue, the supraspinous ligament, the interspinous ligament between the spinous processes, the ligamentum flavum, the epidural space, including the internal vertebral venous plexus, the dura, the arachnoid, into the subarachnoid space, and between the nerve roots of the cauda equina. As the needle passes through the ligamentum flavum, you may feel a popping sensation. Once you have reached this point, The needle should be advanced in 2 mm increments and the stylet withdrawn after each increment to check for CSF flow. If no fluid is detected and bone is encountered, withdraw the needle to the level of subcutaneous tissue without exiting the skin and redirect the needle. Fluid will flow once the needle enters the subarachnoid space. If the lumbar puncture is traumatic, the cerebrospinal fluid may be tinged with blood. As additional fluid accumulates in the barrel, the fluid should become clear, unless the source of the blood is a subarachnoid hemorrhage. If the flow is poor, a nerve root may be obstructing the opening of the needle, and you should rotate the needle 90 degrees. If drops of blood enter the needle, it may become clogged. In this case, you should obtain a new needle and enter the site through a different interspace. For you to obtain an opening cerebrospinal pressure, the patient must be in the lateral recumbent position. Use a flexible connector and attach a manometer to the hub of the spinal needle. After waiting for the column of fluid to rise and possibly seeing pulsation from cardiac or respiratory motion, you may take a measurement. If the cerebral spinal fluid pressure exceeds 25 centimeters of water, you should closely monitor the patient for signs of herniation and determine the cause of the patient's elevated intracranial pressure. You must allow cerebrospinal fluid to drip into the collection tubes. Never aspirate cerebrospinal fluid. Even a small amount of negative pressure can precipitate a hemorrhage. The amount of fluid collected should be limited to the smallest volume necessary for testing. Typically, 3 to 4 milliliters of fluid is sufficient for routine indications. By turning the stopcock toward the patient, fluid in the manometer may be collected. After collecting an adequate specimen, replace the stylet and remove the needle. Although traditionally patients have been told to lie flat for several hours after a lumbar puncture, there is no evidence that this precaution decreases the risk of a cerebrospinal fluid leak, post-puncture headache, or other complications. All sharps should be properly disposed of in appropriate sharps containers or needle lock devices to help minimize the risk of needle stick injury. Obese patients may represent a challenge due to difficulty in identifying landmarks. Other conditions, such as osteoarthritis, ankylosing spondylitis, kyphoscoliosis, previous surgery that has altered landmarks or spaces, and degenerative disc disease also may make the procedure more difficult. If faced with these challenges, consider consultation with an anesthesiologist or perhaps a radiologist, if fluoroscopy-guided lumbar puncture seems to be a better approach. Lumbar puncture has numerous possible complications, including cerebellar herniation, referred pain, headache, bleeding, infection, the formation of a subarachnoid epidermal cyst, and leakage of spinal fluid. You can avoid many of these complications by conducting a careful assessment of the patient before the procedure, including a thorough neurologic examination and retinoscopy, and monitoring the patient throughout the procedure. A subarachnoid epidermal cyst occurs when a skin plug is introduced into the subarachnoid space. The standard use of a needle with a stylet will avoid this complication. Leakage of spinal fluid can occur at the puncture site. A large bore spinal needle is more likely than a smaller bore needle to produce a leak, so the latter should be used whenever possible. In the case of persistent leakage of spinal fluid, an anesthesiologist should be consulted to determine whether a blood patch is needed to occlude the leak. Lumbar puncture is a commonly performed procedure that can be a very useful aid in clinical diagnosis and treatment.
This is a video in clinical medicine from the New England Journal of Medicine.
Diagnostically, arthrocentesis is indicated to rule out septic arthritis in individuals presenting with a single or several inflamed joints. Arthrocentesis can also be used to differentiate between crystal arthropathies, such as gout and pseudogout, inflammatory and non-inflammatory effusions, and hemarthroses. It should be emphasized that a single inflamed joint should almost always undergo at least one diagnostic aspiration. Therapeutically, arthrocentesis may be performed to drain large effusions, hemarthroses, or to inject steroids or local anesthetic. Arthrocentesis should be avoided in patients with cellulitis overlying the site of needle entry out of concern of seeding the joint cavity with bacteria. Known or suspected bacteremia is a relative contraindication to arthrocentesis. However, if there is a concern of septic arthritis, the joint in question should be aspirated. The safety of arthrocentesis in patients with coagulopathy or who are on anticoagulant medications is not established. The relative risks and benefits of arthrocentesis and the use of reversal agents must be individualized. Prosthetic joints are especially susceptible to iatrogenic infection, and the procedure should be discussed with an orthopedist prior to arthrocentesis on patients who have undergone joint replacement surgery. The equipment you need includes a skin cleansing agent, gauze, 1 or 2% lidocaine, a 5 cc syringe and small needle for anesthetic injection, sterile gloves, a skin marking pen, an elastic bandage, and a sterile drape. For collection of synovial fluid, you will need 1 or 2 30 cc syringes and a 1.5-inch 18-gauge needle. Tubes appropriate for the estimation of cell count, crystal examination, and culture should be gathered. The knee joint contains the largest synovial cavity in the body and is thus easy to aspirate in the presence of a significant effusion. The cavity extends from the suprapatellar bursa superiorly to the articular surface of the tibia inferiorly. Note that the knee joint contains several bursae that do not communicate with the synovial cavity. The knee joint may be tapped from either the medial or lateral side. For the medial approach, the knee is extended or flexed to 15 to 20 degrees, and the patella is located. Needle entry occurs along the medial aspect of the superior third of the patella, approximately 1 centimeter medial from the patellar edge. The needle is directed behind the patella and toward the intercondylar notch. The lateral approach uses the same technique from the opposite side of the knee. Informed consent should first be obtained. In this video, we will demonstrate the medial approach to the knee joint. Position the patient supine on a stretcher with the knee fully extended or held in slight flexion. A towel roll may be used if desired. Identify the landmarks by palpating the edges of the patella. Needle entry occurs at a point 1 centimeter medial from the superior third of the patella. The appropriate site may be marked with a skin marking pen. Next, prepare the site. The skin is prepped with antiseptic solution, a sterile drape is placed, and the superficial skin is anesthetized with 1% lidocaine. Approximately 5 to 10 cc's of anesthetic is then injected deeper along the anticipated trajectory of the arthrocentesis needle, with care taken not to inject into a blood vessel. After confirmation of landmarks, an 18-gauge needle with a large syringe is inserted posteriorly behind the patella. The needle should not come into contact with bone in order to prevent injury to the articular cartilage. Constantly pull back on the plunger as the needle is advanced. Once the joint is entered, synovial fluid will begin to fill the syringe. As much fluid as possible should be removed. If necessary, remove a full syringe and replace with a second empty syringe and continue the aspiration. The effusion may be milked to facilitate the removal of residual synovial fluid. The needle is then removed, the skin is cleansed, and the site is covered with a bandage. At the end of the procedure, make sure all needles are placed into appropriate safety devices. The appearance of the fluid should be noted. Normal synovial fluid is transparent and amber. As the number of inflammatory cells increases, the fluid becomes more opaque. Hemarthrosis will yield grossly bloody fluid. Aspirated fluid should be immediately placed into collecting tubes in the order of the priority of the diagnoses sought. An EDTA tube should be sent for cell count and differential, and a sodium heparin tube is sent for crystal examination. Ideally, at least 5 cc's of synovial fluid should remain for gram stain and cultures. Complications of arthrocentesis include iatrogenic infection, localized trauma, pain, and reaccumulation of the effusion.
This is a video in clinical medicine from the New England Journal of Medicine.
Evaluation of blood pressure is essential in assessing cardiovascular health. It is used in screening for hypertension and for monitoring the effectiveness of treatment in patients with established hypertension. In the routine outpatient setting, blood pressure is measured indirectly. Thus, it is important that proper techniques be used in order to produce consistent and reliable readings. In adults, a normal blood pressure is less than 120 millimeters of mercury for systolic and less than 80 millimeters of mercury for diastolic blood pressure. Higher levels are classified as prehypertensive asystolic blood pressure between 120 and 139 millimeters of mercury, and a diastolic blood pressure between 80 and 89 millimeters of mercury. Hypertension is defined as a systolic blood pressure greater than 140 millimeters of mercury or greater than 90 millimeters of mercury diastolic measurement. The purpose of this video is to demonstrate the appropriate technique for the indirect measurement of blood pressure in adults. Blood pressure should be assessed at each office visit. The equipment necessary for measuring blood pressure includes a stethoscope. The stethoscope should have tubing of sufficient length for the clinician to hear Korotkov sounds while viewing the manometer. The bell side of the stethoscope should be used as it permits better auscultation of Korotkov sounds. A sphygmomanometer consisting of a blood pressure cuff containing a distensible bladder, a rubber bulb, and an adjustable valve, as well as flexible tubing. Finally, a manometer that documents the level of pressure within the cuff. Each part of the sphygmomanometer should be examined on a regular basis. The needle on an aneroid manometer should rest at 0 before and after measuring blood pressure. Aneroid manometers should have scheduled recalibration at least every 6 months. Concerns over the toxicity and environmental impact of mercury have led many institutions to use aneroid manometers exclusively. The steps required for accurate indirect measurement of blood pressure are identical whether using an aneroid or mercury manometer. Correct positioning of the patient is essential to accurately measure blood pressure. The patient's back and legs should be supported, with legs uncrossed and feet resting on a firm surface. The patient's arm should be bare to the shoulder. The arm should be supported at heart level. The manometer should be at the eye level of the healthcare practitioner. A common error in taking blood pressure is the use of an improperly fitted cuff. Selection of an appropriately sized cuff requires assessment of the arm circumference. The midpoint position is determined by measuring the distance between the olecranon and acromion processes. The arm circumference is then measured at the midpoint. Once the arm circumference has been determined, the appropriate size cuff can be selected. Cuffs typically are marked with acceptable sizing indicators to facilitate proper fitting. However, it is more important to use a cuff that is appropriately sized for the arm. To assist in selecting the appropriate size, cuffs should be marked with an index line that runs perpendicular to the length of the cuff and a range line that runs parallel to the length of the cuff. The index line should fall within the range line when the cuff is secured to the upper arm. The cuff should be applied 2 centimeters above the crease of the elbow. It should fit snugly, but still allow 2 finger widths under the cuff. Next, find the brachial artery, which is palpable approximately 4 to 5 centimeters from the medial epicondyle on the anterior surface of the elbow. Place the stethoscope lightly against the skin over the brachial artery. There should be appropriate pressure to ensure good sound transmission. The stethoscope should not be in contact with clothing or with the cuff. Inflating the cuff to some arbitrary level runs the risk of excessive overinflation. To avoid this, determine the measurement of the pulse obliteration pressure. Rapidly inflate the cuff to 80 millimeters of mercury while palpating the radial artery pulse. Continue to inflate in 10 millimeter of mercury increments, taking note of the reading at which the pulse disappears. Then deflate the cuff at a rate of 2 millimeters of mercury per second, noting when the pulse reappears. Once the pulse obliteration pressure is determined, you are ready to measure the blood pressure. Inflate the cuff to a level 20 to 30 millimeters of mercury above the pulse obliteration pressure. Then, deflate the cuff at a rate of approximately 2 millimeters of mercury per second while listening for sounds. As the pressure in the cuff is decreased, blood flow in the brachial artery increases, creating turbulence, which generates carot cough sounds. Phase 1 sounds are clear, repetitive tapping sounds that coincide with reappearance of a palpable radial or brachial pulse. The onset of Phase 1 sounds are equivalent to the systolic blood pressure. Phase 2 sounds are audible murmurs in the tapping sounds. Phase 3 and 4 sounds are muted changes in the tapping sounds that occur as the pressure measurement approaches the diastolic pressure, usually within 10 millimeters of mercury of true diastolic pressure. Phase 5 sound is not really a sound, but rather is the level at which sounds disappear. Phase 5 indicates the diastolic blood pressure. To ensure that diastole has been reached, the cuff pressure should continue to be deflated for an additional 10 millimeters of mercury beyond the 5th carot cough sound. You should measure the blood pressure twice at a minimum, waiting at least 1 minute between readings. The average of the measurements should be recorded. In the following example, the patient's blood pressure is 116 over 90 millimeters of mercury. You will hear nothing until the first carot cough sound appears at 116 millimeters of mercury. The various phases of carot cough sounds will be heard until their disappearance at 90 millimeters of mercury. An auscultatory gap is defined as the intermittent disappearance of the initial carot cough sounds after their first appearance. This phenomenon can lead to underestimation of systolic blood pressure. Obtaining the pulse obliteration pressure can be helpful in avoiding incorrect measurement. In the following example, the systolic blood pressure will be heard at 162 millimeters of mercury, followed by an absence of sounds for 4 millimeters of mercury, after which they will reappear. Certain conditions may complicate blood pressure measurement or interpretation. In such settings, decreasing the rate of deflation and averaging several readings may improve accuracy. Observer bias is usually the most common error that occurs in blood pressure measurements. It occurs because practitioners often show digit preference and/or rounding of the terminal digit. When two people use the same correct technique for measuring blood pressure, there should be little inter-observer variation. Measuring blood pressure correctly is required to classify individuals, to stratify their cardiovascular risk, and to monitor the effects of treatment. This video provides the viewer with a standardized methodology that, when followed, will lead to accurate blood pressure measurement.
This is a video in clinical medicine from the New England Journal of Medicine.
Since pulse oximetry was introduced 3 decades ago as a monitoring tool, it has become ubiquitous in operating rooms, intensive care units, and hospital wards. Before pulse oximetry was available, physicians relied on invasive procedures, such as arterial blood gas analysis, to identify the presence of hypoxemia. Pulse oximetry has now become the standard of care in operating rooms and intensive care units in the United States and many other nations. Although the pulse oximeter is easy to use, the clinician must understand the principles of pulse oximetry and must know how the equipment works in order to interpret the information it provides. This video demonstrates the equipment needed and how to use it. It also addresses the common applications of pulse oximetry, explains how to interpret the data generated, and presents its limitations as well as common problems encountered with its use. Oxygen is present in 2 forms in the blood, dissolved and bound to hemoglobin. Hemoglobin can be functional or non-functional in terms of oxygen binding and transport. Functional hemoglobin binds and transports oxygen and is present as oxyhemoglobin and deoxyhemoglobin. Oxyhemoglobin contains bound oxygen, and deoxyhemoglobin is reduced hemoglobin without bound oxygen. Non-functional hemoglobin is unable to bind or transport oxygen and is present as carboxyhemoglobin and methemoglobin. Carboxyhemoglobin is hemoglobin bound to carbon monoxide. Methemoglobin is hemoglobin that contains ferric iron, Fe3+, an oxidized form of the oxygen-carrying ferrous iron, Fe2+, which is found in functional hemoglobin. The partial pressure of oxygen dissolved in arterial blood is termed PaO2. The percent saturation of oxygen bound to hemoglobin in arterial blood is termed SaO2. When measured by a pulse oximeter, SaO2 is termed SpO2. The hemoglobin-oxygen dissociation curve shows the relation between PaO2 and SaO2. The affinity of hemoglobin for oxygen varies at different partial pressures of oxygen, and although the relation is not linear, increases in PaO2 lead to higher SaO2. In general, 80% saturation corresponds to a PaO2 of 50 millimeters of mercury, and 90% saturation corresponds to a PaO2 of 60 millimeters of mercury. Pulse oximetry is indicated in all clinical settings where hypoxemia may occur, such as operating rooms, intensive care units, post-anesthesia care units, emergency departments and ambulances, endoscopy suites, sleep laboratories, cardiac catheterization laboratories, delivery suites, and wards. The use of pulse oximetry in these settings may reduce the need for arterial blood gas analyses and may guide clinical decision-making. There are no contraindications to pulse oximetry, and it is generally safe to use in monitoring all patients. Pulse oximeters consist of a peripheral probe and a small microprocessor unit. Traditionally, the peripheral probe contains a photodetector and 2 light-emitting diodes. The 2 light-emitting diodes emit light of different wavelengths. The light emitted by the diodes is absorbed by tissues, and the amount of absorption is determined by the photodetector. Using this information, the microprocessor determines the concentration of oxyhemoglobin and deoxyhemoglobin, respectively. It then calculates the percentage of oxyhemoglobin and displays the hemoglobin-oxygen saturation in arterial blood, a waveform corresponding to the pulsatile flow in arterial vessels, and the heart rate. Pulse oximeters function on the principle that oxygenated and deoxygenated hemoglobin absorb red and infrared light differently. The light absorption of deoxyhemoglobin is greater at wavelengths of 600 to 800 nanometers, while the light absorption of oxyhemoglobin is greater at wavelengths of 800 to 1000 nanometers. One light-emitting diode emits light in the red spectrum at a wavelength of 660 nanometers, at which the light absorption of deoxyhemoglobin is greater than that of oxyhemoglobin. The other diode emits light in the infrared spectrum at a wavelength of 940 nanometers, at which oxyhemoglobin absorbs more light than deoxyhemoglobin. The microprocessor analyzes the light absorption of the tissues at each wavelength to determine the respective concentrations of oxyhemoglobin and deoxyhemoglobin. It then divides the concentration of oxyhemoglobin by the sum of the concentration of oxy and deoxyhemoglobin to determine the arterial blood oxygen saturation, SpO2. The probe is positioned so that the photodetector and light-emitting diodes face each other, with layers of tissue between them. The photodiodes turn on and off several hundred times per second to record the light absorption during pulsatile and non-pulsatile flow. During pulsatile flow, the light absorption of arterial blood, background tissues, and venous blood is detected. During non-pulsatile flow, only the light absorption of background tissues and venous blood is detected. The microprocessing unit compares the light absorption during pulsatile and non-pulsatile flow to isolate the light absorption of arterial blood and thus determine the arterial blood oxygen saturation. Pulse oximetry provides both qualitative and quantitative data. The qualitative data are obtained through the sounds emitted by the pulse oximeter. These sounds correlate with the level of oxygen saturation. A higher pitch indicates higher oxygen saturation, and a lower pitch warns of decreasing oxygen saturation. The pulse oximeter provides quantitative data through the display of a pulsatile waveform that corresponds to the flow of arterial blood. The numbers displayed indicate the hemoglobin oxygen saturation and the pulse. It is important to adhere to standard precautions before any contact with patients. Hand washing is the single most effective strategy to prevent the spread of infections. The ideal site for placement of the pulse oximeter probe is one that is well perfused, relatively immobile, comfortable for the patient, and easily accessible. The earlobes and the fingers are commonly used sites. Feet, cheeks, nose, and tongue may be used in cases of low peripheral perfusion. In adults, the probe can be placed on either side of the body. In newborns, however, placement on the right upper arm is preferable because of the possibility of a patent ductus arteriosus. Blood flowing to the right upper arm is the least diluted by the shunt and is therefore the most oxygenated. It is important to choose a probe that is the right size for the patient. If the probe is not the right size, the light-emitting diodes may not line up correctly with the photodetector and will provide inaccurate data. For example, a probe that is too large for a patient's finger may slip, and the light may not pass completely across the finger. Venous pulsations may occur if a probe is too small or is placed too tightly on the finger. These venous pulsations will produce interference, resulting in a falsely low pulse oximeter reading. Pulse oximeter probes with adhesive sensors may minimize motion and may yield more accurate results than non-adhesive sensors. Even though it is easy to use, the pulse oximeter can produce erroneous data in certain circumstances. One common problem is the occurrence of movement artifacts when there is movement at the site where the probe is placed. This may interfere with proper function and most often occurs if a patient is shivering, has seizures, or is being transported by ambulance or helicopter. The waveform of the pulse oximeter will be distorted in such circumstances, and the clinician should recognize that the measurement displayed is inaccurate. A bright light, such as an operating room lamp, may cause light interference, leading to an erroneous reading. Electromagnetic radiation, such as that emitted from an MRI scanner, may also interfere with pulse oximetry. If the probe is poorly placed or is the wrong size, light from only one light-emitting diode may pass through the tissues, or the light may not reach the detectors. This will result in falsely elevated or depressed results. Nail polish that absorbs light at 660 nanometers or 940 nanometers may also interfere with the pulse oximeter and result in an inaccurate reading. This problem can be avoided by removing the nail polish. The presence of intravascular dyes such as methylene blue or indigo carmine may alter the red and infrared light absorption properties of the blood and tissues, also resulting in an inaccurate reading. Non-functional hemoglobin can also result in inaccurate pulse oximeter data. At 940 nanometers, the light absorption of carboxyhemoglobin is minimal and does not affect the SpO2. However, at 660 nanometers, the light absorption of carboxyhemoglobin is similar to that of oxyhemoglobin. The pulse oximeter cannot differentiate between oxyhemoglobin and carboxyhemoglobin in this instance, and may erroneously display a normal or near normal arterial blood oxygen saturation when the actual arterial blood oxygen saturation may be low. At 940 nanometers, methemoglobin absorbs more light than either deoxyhemoglobin or oxyhemoglobin. At 660 nanometers, the light absorption of methemoglobin is similar to that of deoxyhemoglobin. In this instance, the pulse oximeter cannot differentiate between methemoglobin and deoxyhemoglobin and may incorrectly detect an elevated deoxyhemoglobin concentration, resulting in a falsely low interpretation of arterial blood oxygen saturation. Carboxyhemoglobin may cause a falsely high SpO2, whereas methemoglobin may cause a falsely high or falsely low reading, depending on the actual concentration of oxyhemoglobin. Newer pulse oximeters are able to emit light at up to 8 different wavelengths. This increase in the number of available wavelengths makes it possible for the oximeter to distinguish carboxyhemoglobin and methemoglobin. There are additional limitations. Peripheral vasoconstriction, hypoperfusion, hypothermia, shock, and anemia may also yield inaccurate results. If you do not get a reading from the pulse oximeter, either when you attach it to the patient or during use, there is a series of steps you can follow to determine the problem. First, make sure the probe has not fallen off the placement site. If it has been displaced, adjust the probe as necessary. If not, make sure the cable connecting the probe to the microprocessor is intact and is in fact connected to the microprocessor. The cable may become loose or detached, making it seem as though the pulse oximeter cannot determine the arterial blood oxygen saturation. If the cable is loose, adjust the connection as necessary. Next, make sure the red light on the inside of the probe is evident. If you do not see the red light, check the power cable. If you can see the red light and have made sure the cable connecting the probe to the microprocessor is intact, clean the probe and place it on your finger to see whether the issue is specific to the patient. If this is not the case, it is possible that either the probe or the microprocessor is not working properly. Replace the probe, the microprocessor, or both as necessary. Although the pulse oximeter is generally a safe device, its use still carries some risk of adverse events. Ischemic pressure necrosis may result if the probe is placed too tightly on the patient. Perioperative corneal abrasion may occur if a patient with a probe on a finger rubs his or her eyes when awakening from anesthesia and in doing so scrapes the cornea. Prolonged placement of a pulse oximeter probe, as may occur in patients in the ICU, may lead to mechanical injury, such as finger stiffness, making it difficult to flex the finger after removal of the probe. Although previously documented, these complications remain uncommon. If used correctly, pulse oximetry is a potentially life-saving tool. Healthcare providers need to be aware of the indications, benefits, and disadvantages of pulse oximetry. Most important, clinicians must be able to interpret the information pulse oximetry provides. With proper training and instruction, pulse oximetry is an invaluable monitoring tool.
This is a video in clinical medicine from the New England Journal of Medicine.
Radial arterial puncture for arterial blood gas analysis is a common procedure performed in medicine. It is a fundamental skill that all medical trainees need to acquire. This video will review radial arterial puncture in the adult population. Puncture of the radial artery is the preferred method of obtaining an arterial blood sample for blood gas analysis. The chief indication for measurement of arterial blood gas level is to obtain values for the partial pressures of oxygen and carbon dioxide, and for arterial pH. This information is needed when assessing a patient with acute severe respiratory distress. Measurements of arterial pH and the partial pressures of carbon dioxide and oxygen provide accurate information on the status of acid-base balance and gas exchange. Another indication for arterial blood gas analysis is co-oximetry in order to assess for methemoglobinemia and carboxyhemoglobin. Radial arterial puncture is contraindicated in the presence of a known deficiency of collateral circulation to the distal upper extremity. Some physicians advocate for the use of the modified Allen test to assess the adequacy of collateral circulation of the radial artery by the ulnar artery. The Allen test is controversial, however, in that its ability to predict the risk of rare ischemic complications accurately is limited. Thus, based on current evidence, its use can be neither refuted nor supported. To perform the Allen test, occlude both the ulnar and radial arteries. Instruct the patient to make a fist to drain the blood from the hand. This should be done for approximately 30 seconds. Instruct the patient to unclench the fist. The patient's palm should appear blanched or pale. Now release pressure only from the ulnar artery. Adequate collateral circulation is indicated by the return of normal color within 10 seconds. Alternative techniques that can be used to measure collateral circulation of the forearm include color Doppler flow study, plethysmography, and MRI. These methods are more often used when assessing the radial artery for more invasive procedures, such as arterial harvesting for coronary bypass. In addition, radial arterial puncture should not be performed in the presence of an overlying skin infection. It is relatively contraindicated in patients receiving anticoagulants or in those with coagulopathies because of the increased risk of bleeding and hematoma formation. Standard arterial blood gas sampling kits are readily available that contain a syringe, a small 23 to 25 gauge needle either with a rubber stopper that may be used to remove the needle from the syringe or with an attached safety cap, and a syringe cap containing dry lithium heparin or sodium heparin. The concentration of heparin here varies depending on the manufacturer of the kit. You will also need the following: alcohol swabs, sterile pieces of gauze, tape, non-sterile gloves and a non-sterile gown, 1% lidocaine without epinephrine for local analgesia, a 5cc syringe with a 25-gauge needle, a small rolled towel to place under the wrist, and a bag of ice in which to transport the sample to the lab if required. Arterial blood gas sampling often takes place in an emergency setting and may not allow for obtaining consent from the patient or next of kin. When possible, the procedure should be explained to the patient and consent obtained. Wash your hands according to good standards prior to examining the patient. Extend the patient's wrist to bring the radial artery close to a more superficial position. The radial artery is located between the styloid process of the radius and the flexor carpi radialis tendon. First, palpate the styloid process of the radius. Next, palpate the flexor carpi radialis tendon located medial to the styloid process of the radius. Now locate the artery between these 2 points. The artery may be difficult to palpate, for example, in the presence of overlying edema or vasospasm. A portable Doppler ultrasound device may be used to identify the location of the radial artery in these instances. Extend the patient's wrist and place a rolled towel under it to maintain it in an extended position. Once the patient's wrist is positioned, put on a non-sterile gown and non-sterile gloves. Open the arterial blood gas kit and identify all the components so they are ready for use. Clean the site with an alcohol swab. Palpate the radial pulse and determine the point of maximum impulse, or use the Doppler ultrasound device to identify the location of the radial artery. Using the 5cc syringe and small needle, draw up 1% lidocaine. Upon introducing the needle under the skin, draw back on the plunger to ensure that you have not punctured a vessel. Inject a small wheel of analgesic around the artery and wait 30 to 60 seconds for the lidocaine to take effect. Again, locate the maximum impulse with the index and middle fingers of the non-dominant hand. Holding the arterial blood gas syringe with the dominant hand, aim the needle away from the hand and toward the upper arm, and puncture the skin at a 30 to 45 degree angle at a point just below the index and middle fingers of the non-dominant hand. Advance the needle slowly until the syringe easily and passively fills with bright red pulsating blood. Ideally, you should obtain at least 1 to 2 cc's of blood. If no blood is obtained, do not pull back on the plunger. Withdraw the needle slowly until it is just under the skin and reattempt the procedure. After the blood sample is collected, withdraw the syringe and have an assistant apply pressure to the site with sterile gauze for approximately 5 minutes. In the meantime, expel the air bubbles from the syringe. Cover the needle with the attached safety cap and remove the needle from the syringe. Or remove the needle from the syringe using the rubber stopper. Attach the heparin-containing cap and, while holding the cap in place, push the plunger of the syringe to ensure the blood encounters the heparin. This will prevent the blood from clotting. Ensure that the syringe is labeled with the patient's name and unit number. Place the entire syringe in the bag of ice if transport to the lab is required. After pressure has been applied to the puncture site for 5 minutes, affix the gauze with some tape. Dispose of all sharps in the designated sharps containers. The most common technical difficulty associated with radial arterial puncture for arterial blood gas analysis is failure to obtain a blood sample because of vasospasm, or obtaining venous instead of arterial blood. If vasospasm is suspected, Abort the procedure and reattempt it on the other wrist. A blood sample is likely to be venous if it is non-pulsatile and dark in color and it flows slowly. It should be noted, however, that very deoxygenated blood in a patient with hypoxemia could also appear dark, even though it is arterial. Serious vascular complications of radial arterial puncture are rare and include radial arterial aneurysm, hand ischemia, and hematoma causing compartment syndrome. Arterial blood gas analysis provides useful information regarding respiratory and metabolic pathology. The partial pressure of carbon dioxide, bicarbonate concentrations, and pH values will assist in diagnosing the presence of primary or mixed respiratory and metabolic acidoses or alkaloses. The partial pressure of oxygen will reveal abnormalities in blood oxygen content and the presence of hypoxemia. With the appropriate technique, radial arterial puncture for arterial blood gas analysis is a skill easily mastered by medical trainees. A more detailed approach to acid-base disorders and hypoxemic respiratory failure, while necessary, is beyond the scope of this instructional video.
This is a video in clinical medicine from the New England Journal of Medicine.
Overview. Carbon dioxide is generated in the body as a metabolic byproduct. Carbon dioxide dissolves in the blood and is transported in the bloodstream until it reaches the lungs, where it diffuses into the alveoli. The alveoli are ventilated through an open tracheobronchial tree and a patent upper airway. Carbon dioxide can then be detected in the patient's expired breath. The measurement of expired carbon dioxide provides insight into important life-sustaining processes that include metabolic, circulatory, and respiratory activity. Capnography is the standard of care for monitoring the adequacy of ventilation in patients receiving general anesthesia. It is also used to monitor ventilation during procedures performed while the patient is under moderate or deep sedation. Capnography is increasingly being used to monitor patients who are receiving mechanical ventilation in intensive care units and to aid in the assessment and treatment of cardiac arrests. Before capnography was available, physicians relied on the physical exam, such as auscultation of the chest, to assess the adequacy of ventilation and proper placement of endotracheal tubes, and on arterial blood gas analysis to determine the partial pressure of carbon dioxide. Capnography allows for non-invasive and continuous monitoring of carbon dioxide levels and can provide valuable information regarding the metabolic, circulatory, and respiratory conditions of a patient. Although capnography is not complicated, the clinician must understand the principles of capnography and how the equipment works in order to interpret the information it provides. Definitions. Capnometry refers to the measurement and numerical display of carbon dioxide concentrations. Capnography refers to the graphic display of the exhaled and inhaled carbon dioxide concentration plotted against time. Colorimetric capnography is a qualitative method of determining the presence of carbon dioxide using a pH-sensitive filter that changes color from purple to yellow when carbon dioxide is detected. PaCO2 denotes the partial pressure of carbon dioxide in arterial blood. End-tidal carbon dioxide is the percentage concentration or partial pressure of carbon dioxide at the end of exhalation, normally 5% of atmospheric pressure or approximately 38 millimeters of mercury at sea level. Hypercapnia and hypercarbia refer to a greater than normal partial pressure of carbon dioxide in blood. Hypocapnia and hypocarbia refer to a lower than normal partial pressure. Indications. Capnography is used in the operating room to aid in the proper placement of endotracheal tubes and to monitor ventilation. Capnography is increasingly being used to assess the adequacy of ventilation and to monitor for hypercapnia or hypocapnia in treatment areas such as intensive care units, post-anesthesia care units, emergency departments and ambulances, endoscopy suites, sleep laboratories, and cardiac catheterization laboratories. Carbon dioxide detection is frequently used during cardiopulmonary resuscitation to aid in determining the proper placement of an endotracheal tube and to assess the effectiveness of resuscitation efforts. While pulse oximetry is a good method for the assessment of oxygenation, capnography provides more direct information on a patient's ventilatory status. Capnography is particularly helpful in patients who are receiving supplemental oxygen, during which a normal hemoglobin oxygen saturation can be present in spite of marked hypoventilation. Contraindications. There are no contraindications to the use of capnography, provided that the data obtained are evaluated in the context of the patient's clinical circumstances. It is generally safe to use capnography for the monitoring of all patients. Principles of operation. Capnography is based on the concentration of carbon dioxide in a sample of exhale gas throughout the respiratory cycle. Because of the chemical properties of carbon dioxide, a variety of techniques can be used to measure its concentration. Infrared absorption spectroscopy is typically used in clinical practice. Infrared light can be passed through a sample of gas to an infrared detector. As the concentration of carbon dioxide increases, the intensity of the light that reaches the detector decreases. Carbon dioxide gas strongly absorbs infrared light with a wavelength of 4.3 microns. At this wavelength, there is minimal interference from other gases that may also be present, such as water vapor, oxygen, nitrous oxide, and inhaled anesthetic agents. There are two types of capnograph devices. Mainstream capnographs use sensors that are placed directly into the breathing circuit of a ventilator. Side-stream capnographs draw a sample of gas away from the breathing circuit to a separate gas sensor. The response of a side-stream device to changes in carbon dioxide concentration is delayed by a few seconds, since the gas must travel through the sampling line before it can be analyzed. However, in patients who are not intubated, side-stream capnographs can be used conveniently with a face mask or nasal cannula to monitor respiration. Nasal cannulas and face masks that feature integrated CO2 sampling are commercially available. You can modify standard face masks by attaching the sampling line directly to the orifice of a mask, or by securing the sampling line inside the mask. Take care that the orifice does not rest against the patient's skin to avoid occlusion of the flow of gas into the sampling line. Alternatively, you can place an integrated sampling nasal cannula underneath a face mask. Data interpretation. A normal capnogram shows a regular, nearly square waveform that oscillates at the same frequency as the patient's respiratory rate. During inspiration, the capnogram should be at 0 as the patient breathes in fresh gas. When the patient starts to exhale, the first gas exhaled will be from the anatomical dead space and will contain little or no carbon dioxide. However, the concentration of carbon dioxide in the exhale gas will rise rapidly and plateau as the alveoli begin to empty. As exhalation proceeds, the concentration of carbon dioxide remains high and increases slightly. The peak concentration reached at the end of exhalation is the EtCO2. As the patient begins to inhale again, the capnogram falls rapidly to 0. indicating the absence of carbon dioxide in the inspired gas. In patients who are not intubated, the samples of the exhaled gas are mixed with the surrounding atmosphere and fresh gas flow, diluting the concentration of carbon dioxide. As the side stream catheter is moved farther away from the patient's airway, the EtCO2 value will decrease progressively. Although the EtCO2 of a patient who is not intubated represents only a qualitative indicator of ventilatory status, the patient's respiratory rate can still be determined from the waveform of the capnogram. Proper use of capnography. In patients who are not intubated, place the side stream sampling catheter close to the patient's airway, using either a face mask or a nasal cannula. Capnography should be started before treatment is begun, so that satisfactory baseline tracings of the patient's spontaneous respiration can be obtained and correct operation of the capnograph can be confirmed before any procedural sedation is administered. Any change in respiration can then be assessed relative to this baseline. In patients undergoing endotracheal intubation, capnography helps to show that the trachea, and not the esophagus, has been successfully intubated. However, if the stomach is insufflated with air that contains carbon dioxide, or if the patient has recently swallowed a carbonated beverage, the capnogram might transiently show the presence of carbon dioxide, even if the endotracheal tube has been erroneously placed in the esophagus. A series of successive, steady, normal capnographic waveforms must be seen to rule out esophageal intubation. In addition, a capnogram tracing indicates gas exchange and does not inform the clinician about whether the endotracheal tube is positioned properly. For example, whether it is in a bronchus or in the oropharynx. Capnography is useful for the measurement of the ventilatory characteristics of intubated patients, and it may reduce the need to measure arterial blood gas. Common problems and limitations. Capnography is valuable for monitoring a patient's respiratory status. However, it is important to be aware of circumstances that may affect its reliability and to be able to recognize and interpret abnormal waveforms that may result from pathologic features or from technical difficulties. Capnograms must always be interpreted in conjunction with other physiological variables, and clinical judgment is important. Loss of the capnographic waveform may be caused by apnea, disconnection of a ventilator circuit, occlusion or dislodgement of an endotracheal tube, or occlusion or disconnection of the sampling line. Waveforms that do not return to zero during inspiration indicate rebreathing of carbon dioxide. This can occur if the carbon dioxide absorber in an anesthesia machine is chemically exhausted, if a valve in the ventilator circuit is not functioning properly, or if the flow of fresh gas is insufficient. An elevated baseline can also be seen if the device is calibrated incorrectly. Decreases in EtCO2 can be due to hyperventilation, pulmonary embolism, cardiac arrest, sudden hypotension, hypovolemia, hypothermia, leaks in the sampling system, or a partial airway obstruction. Increases in EtCO2 can result from hypoventilation, rising body temperature, bronchospasm, adrenergic discharge, release of a tourniquet on an extremity, or ventilation of a previously unventilated lung. Shallow breathing transiently lowers EtCO2 because of dead space ventilation, but EtCO2 rises again when full gas exchange occurs. Cardiac oscillations result from the transmission of cardiac movements to the lungs and airways. These oscillations are usually seen when either respiration is slow or the tidal volume is small. Such oscillations suggest inadequate ventilation, and a capnogram with prominent cardiac oscillations suggests the need to initiate assisted or mechanical ventilation. Although capnography provides a quantitative measurement of EtCO2, it is not as accurate as blood gas analysis for the assessment of the partial pressure of arterial carbon dioxide. A gradient exists between the partial pressure of arterial carbon dioxide and EtCO2. This gradient increases as the dead space volume increases. In disease states characterized by increased dead space and ventilation-perfusion mismatch, such as emphysema, an arterial blood gas analysis is necessary for an accurate determination of the partial pressure of arterial carbon dioxide. Troubleshooting. Artifacts should be the last explanation for changes in critical values. Therefore, when a low or high carbon dioxide reading is obtained, a physical assessment of the patient must be performed before the assumption is made that the values represent equipment malfunction. If the patient appears to be clinically stable, consider the possibility of either leakage or occlusion of the sampling system. Make sure that the side stream sampling line is well connected to the circuit and to the water trap on the capnograph, and that the water trap is firmly attached to the capnograph. To quickly test the integrity of the sampling line and monitor, breathe into the sampling line. A waveform confirms proper sampling, although small leaks diluting the sampled gas may go unnoticed. The sampling line or water trap may become occluded with condensed water. Disconnecting the sampling line and flushing it with air from a syringe can sometimes clear it, but it may be necessary to replace these components. Elevating the side stream sampling line above the ventilator circuit helps prevent the entry of condensed water. A humidity barrier is also useful, although this will increase the response time of the capnogram. Complications. Although capnography is generally safe, its use still carries a small risk of adverse events. Mainstream analyzers may introduce an excessive amount of dead space into the ventilator circuit. Older generation mainstream sensors use heat to inhibit the condensation of water vapor and prevent falsely high carbon dioxide readings. But this increases the risk of burning the patient's skin. Also, to reduce the risk of accidental extubation, caution must be taken to minimize the amount of additional weight placed on the airway. Summary. When used correctly, capnography is a potentially life-saving tool. Healthcare providers need to be aware of the indications, benefits, and disadvantages of capnography and must be able to interpret the information it provides. With proper training and instruction, clinicians will find capnography to be an invaluable tool for monitoring ventilation.
This is a video in clinical medicine from the New England Journal of Medicine.
This video will demonstrate the placement of the laryngeal mask airway, or LMA, as an emergency airway device in patients experiencing a cardiopulmonary arrest. The goal is to provide familiarity with and instruction in its use so that a clinician will be comfortable using this device to provide effective ventilation for patients in cardiopulmonary arrest. Instruction beyond this video is necessary for safe and effective placement of a laryngeal mask airway, and the clinician should seek further training from anesthesiologists or others who have expertise in its use. The laryngeal mask airway is a device used routinely by anesthesiologists for surgical operations. Its use should also be strongly considered for ventilation in pre-hospital and in-hospital cardiac arrests. Both the American Heart Association and the European Resuscitation Council consider the laryngeal mask airway an acceptable device for use by non-experts in tracheal intubation when performing emergency airway management. The laryngeal mask airway is also an important rescue device in situations where tracheal intubation is impossible or has failed, and in situations where access to the head or positioning for intubation is not possible. Use of laryngeal mask airway instead of bag and mask ventilation during CPR has also led to fewer events of pulmonary aspiration during resuscitation. The reasons for laryngeal mask airway placement during CPR are many and include high first-time success rates, rapid placement by both novices and experts, necessitating minimal disruption, if any, of chest compressions, ease of ventilation during prolonged resuscitations, as compared with bag and mask ventilation. It is a good option over placing an endotracheal tube when tracheal intubation is difficult or has failed, and placement can be achieved without head movement in patients with potential instability of the cervical spine, for example in patients with traumatic injuries or rheumatoid arthritis. An adult-sized laryngeal mask airway is a flexible breathing tube of approximately 25 centimeters in length with an inflatable bladder or cuff on its distal end. The proximal end has a standard 15 millimeter connector that allows attachment to any ventilation system. Air exchange occurs through the aperture on the distal end of the tube. This illustration shows the identity and location of the tongue, hard palate, epiglottis, esophagus, and laryngeal inlet. Review of these structures is helpful for understanding proper placement and potential difficulties. Unlike oral airways and nasal airways, the laryngeal mask airway bypasses all pharyngeal structures to provide a more direct conduit to the laryngeal inlet. When properly placed, the laryngeal mask airway requires less pressure than bag and mask ventilation to achieve effective ventilation, thus minimizing the risk of gastric insufflation and subsequent pulmonary aspiration. Current laryngeal mask airway models include both straight and pre-curved tube designs and models intended for either single or multiple uses. Some devices include a separate channel for suctioning the stomach, while others are specifically designed to facilitate oral tracheal intubation through the device. Laryngeal mask airways are available in up to 5 pediatric sizes and 3 adult sizes. Typically, your resuscitation committee will decide upon a model and sizes suitable to your patient population. As a general rule, a number 4 laryngeal mask airway is adequate for the average adult female patient and a 5 for the average adult male patient. You'll need to consult the sizing chart provided by the manufacturer of the device to select the correct size. To prepare for laryngeal mask airway insertion, you'll need an appropriate sized device, a 20 to 40 milliliter syringe, lubricating jelly, and tape. Often, laryngeal mask airways come pre-packaged with an inflation syringe and a small package of lubricant. Prepare the device by first removing all excess air from the bladder. Then lubricate the posterior surface of the cuff to facilitate easy and smooth passage into the mouth. The posterior surface is the side opposite where air exchange occurs. The following sequences will demonstrate the placement of laryngeal mask airway in consenting adults undergoing elective surgical operations. With the patient in the supine position, gently tilt the head backwards to facilitate placement. Do not perform this backwards tilt in an unconscious patient in whom a neck injury is suspected. Place a straight laryngeal mask airway, open the mouth as fully as possible, and insert the device into the mouth, directing the posterior cuff against the hard palate. Continue with this motion until you feel the tube's cuff pass behind the tongue completely, and then until you meet resistance. Successful insertion depends on keeping the leading edge flat to prevent the cuff from folding on itself, and exerting firm pressure against the hard palate during passage. Inflate the cuff with approximately 30 milliliters of air. During inflation, the shaft of the airway often moves out of the mouth 1 to 2 centimeters as it finds its proper location. The cuff should not be visible when the tube is in the proper position. The final resting position is posterior to the tongue at the laryngeal inlet, as shown in this illustration and in this fiber optic view through the distal end of the device. This cutaway view of the head and neck illustrates the path taken by the laryngeal mask airway during insertion and where it rests following insertion. Key structures are labeled to illustrate the relevant anatomy. Use of a pre-curved laryngeal mask airway sometimes allows placement without the need to insert hands inside a patient's mouth. To place a pre-curved laryngeal mask airway, grab the connecting tube with your dominant hand so the cuff points to the patient's head. Your hand should be in a neutral position with the thumb on the upward surface of the tube. As with the straight tube, guide the laryngeal mask airway above and behind the tongue by applying firm pressure along the patient's hard palate. Guide the tube behind the tongue and toward the larynx with a circular motion of the hand. After placement, inflate the cuff and then connect the device to a positive pressure ventilation system. Confirm proper placement by auscultation of breath sounds. Auscultation of breath sounds should take less than 5 seconds, and placement of the laryngeal mask airway during resuscitation should not require interruption of CPR. Improper placement of the laryngeal mask airway can result in a poor seal or an obstruction of airflow. If air leaks from the mouth or you do not achieve adequate ventilation, add an additional 5 to 10 milliliters of air to the cuff. If additional air in the cuff fails to improve ventilation or decrease the air leak, then gently remove and reinsert the laryngeal mask airway. If ventilation is still not achieved or there is still a large leak of air from the mouth, attempt placement of a larger laryngeal mask airway. The most common location of obstruction is at the level of the oropharynx, either because the epiglottis has folded down or because the tongue or redundant oropharyngeal tissue is pushed into the airway. Selection of the proper size laryngeal mask airway, as well as use of proper insertion technique, will reduce the frequency of these problems. Use of a tongue blade to partially retract the tongue and to provide counterpressure against the hard palate is one way to improve entry of the laryngeal mask airway into the mouth. Additional lubrication or briefly dipping the cuff in clean water may also help prevent the cuff from sticking to the tongue and oropharynx. In addition, a small mouth opening or large tongue may prevent use of the operator's finger and hand to get the laryngeal mask airway behind the tongue. In such cases, use of the connecting tube shaft to create downward pressure may be necessary. Once adequate ventilation has been established, secure the laryngeal mask airway with tape to prevent movement of the device. Even when secured, the laryngeal mask airway may become dislodged with motions such as twisting or pulling. When moving patients, place one hand at the base of the laryngeal mask airway and disconnect the ventilation system from the device. Once the laryngeal mask airway is placed, the adult patient should receive 8 to 10 breaths per minute during continuous chest compressions. You should deliver quick breaths, ideally less than 1 second per breath, each with a volume of approximately 500 milliliters. If you hear air leakage during ventilation, you'll have to alternate ventilation and chest compressions. In the latter case, give 2 500 milliliter breaths following every 30 chest compressions. This ratio of 30 compressions to 2 breaths should be continued for as long as CPR is being performed. Delivery of drugs through the laryngeal mask airway to the pulmonary epithelium is unreliable and is not recommended. The laryngeal mask airway may be left in place for the duration of the resuscitation. If a definitive airway is still needed, an experienced provider in airway management should replace the laryngeal mask airway with an endotracheal tube. Complications associated with laryngeal mask airway use are similar to those with other tools used for airway management. However, there may be fewer complications than with bag and mask ventilation and endotracheal intubation. These complications include the potential for upper airway trauma, tooth dislodgement or damage, and the introduction of a large volume of air into the stomach. Despite its numerous advantages for rescue ventilation, the laryngeal mask airway does not provide a secure airway and will not protect against aspiration when the volume of gastric contents is large. It may also be difficult to ventilate a patient with a laryngeal mask airway when high airway or thoracic pressures are encountered, for example during vigorous chest compressions, or in obese patients, or patients with parenchymal lung disease. Additional familiarity with the laryngeal mask airway can be gained with practice on a training head model, on a patient simulator, or on real patients in the operating room under the guidance of an anesthesiologist. The laryngeal mask airway provides a fast and effective alternative to tracheal intubation and is used for an increasing number of clinical indications, including ventilation during cardiopulmonary arrest. Laryngeal mask airway placement is usually successful in the initial attempt. Thus, it is an important procedure to learn and practice.
This is a video in clinical medicine from the New England Journal of Medicine.
Common indications for nasogastric intubation include decompression of the GI tract in patients with bowel obstruction and gastric emptying in intubated patients to prevent aspiration. NG tubes may be placed as an adjunct for the delivery of oral agents such as activated charcoal or oral radiographic contrast media. NG tubes are often placed in patients with suspected upper GI hemorrhage. However, the sensitivity and negative predictive value of nasogastric aspirates for detecting active bleeding is suboptimal, and the absence of bloody return cannot be relied upon to rule out hemorrhage. Nonetheless, nasogastric intubation may be useful in selected patients. Evacuation of blood and clots from the stomach may facilitate the endoscopic visualization of the gastric and duodenal mucosa, and the return of bright red blood does provide prognostic information. Nasogastric intubation and gastric emptying may be beneficial in patients with severe pancreatitis and associated ileus. However, it has been shown that NG tubes are not beneficial and, in some cases, detrimental in patients with mild or moderate symptoms. Nasogastric intubation should be avoided in patients with significant maxillofacial trauma, as the tube may enter the cranial vault if the thin cribiform plate has been disrupted. The procedure should also be avoided in patients with known esophageal abnormalities such as recent caustic ingestion, diverticulae, or strictures, as they are at high risk for esophageal perforation. Since nasogastric intubation may induce emesis, patients who are unable to adequately protect their airway should be intubated with a cuffed endotracheal tube if the procedure must be performed. Begin by gathering equipment you will need. This will include gloves, a protective gown, and face shield, an appropriately sized nasogastric tube, vasoconstrictor spray, and a topical anesthetic such as benzocaine or lidocaine solution with an atomizer. Obtain a lubricant, a glass of water with a straw, towels or blue pads, a 60 cc catheter tip 2mm syringe, a stethoscope for tube confirmation, tape, and a wall suction setup. Have the patient breathe in through each nostril to assess which side is more patent. Premedicate the nasal cavity with a vasoconstricting spray such as phenylephrine or oxymetazoline. Anesthetize the nasal cavity with a topical anesthetic such as 4% lidocaine or topical lidocaine jelly. The posterior oropharynx should also be anesthetized with lidocaine or topical benzocaine spray. Nebulized lidocaine may also be used. The proper depth of tube insertion is approximated by measuring the distance from the xiphoid process to the angle of the mandible and then to the nostril. Lubricate the distal tip of the nasogastric tube with surgical jelly or viscous lidocaine. Position the patient sitting upright in the sniffing position. Insert the tip of the nasogastric tube into the nasal cavity and slowly advance it posteriorly parallel to the floor of the nasal canal. The tube should not be directed upwards. In this endoscopic view of the nasal cavity, note that if the tube is passed in an upwards fashion, it will reach a blind recess at the middle turbinate. When the tube is passed parallel to the nasal floor, it reaches the posterior nasopharynx without difficulty. Continue to pass the tube posteriorly. The patient may gag once the tube reaches the larynx. Temporarily halt the advancement of the tube and ask the patient to begin swallowing sips of water through a straw. Coordinating advancement of the tube with the swallowing mechanism facilitates passage of the NG tube into the esophagus and prevents entry into the trachea. This is a fluoroscopic view of a nasogastric tube being inserted. As the tube reaches the level of the larynx, advancement is temporarily halted. The tube is then inserted as the patient swallows, and, once past the larynx, is rapidly advanced. Note that in this endoscopic view of the larynx, the trachea is frequently open and may be accidentally intubated with an NG tube. Note also that as the patient swallows, the laryngeal apparatus arises and the epiglottis covers the glottis, preventing tracheal entry. Once past the larynx, The tube may be inserted rapidly to the predetermined depth. Check the black markings on the tube to confirm proper depth of insertion. Assure that the patient is in no respiratory distress and is able to speak. If the patient is unable to talk, is in respiratory distress, or if respirations can be heard through the tube, it should be removed immediately, as tracheal intubation has likely occurred. Attach the catheter tip syringe to the main port of the NG tube and insufflate 30 cc of air while auscultating over the epigastrium. A gurgling noise should be clearly audible. Using the same syringe, aspirate the NG tube and ensure that it fills with gastric contents. It should be noted that auscultation and aspiration may occasionally provide false positive results. Therefore, radiographic confirmation of tube placement by visualizing the NG tube's descent below the diaphragm should be obtained prior to infusion of any substance, such as activated charcoal or oral contrast media. The tube should be secured to the patient prior to transport to the radiology suite. Take a 5 to 7 centimeter strip of adhesive tape and tear it vertically for 1/2 of its length. The wide section is placed across the patient's nose and the two tails are then wrapped in opposite directions around the NG tube. You may now connect the nasogastric tube to suction. Turn on the suction and adjust the vacuum force as desired. Minor complications of NG tube insertion include epistaxis, sinusitis, and sore throat. More serious sequelae include esophageal perforation, pneumothorax, aspiration, and, rarely, intracranial placement.
This is a video in clinical medicine from the New England Journal of Medicine.
Urethral catheterization may be performed as either a therapeutic or a diagnostic procedure. Therapeutically, catheters may be placed to decompress the bladder in patients with acute or chronic urinary retention. In addition, catheters may be placed to facilitate bladder irrigation in patients with gross hematuria. Diagnostically, urinary catheters may be placed to obtain an uncontaminated urine sample for microbiologic testing, to measure urinary output in critically ill patients or during surgical procedures, or to measure post-void residuals. The only absolute contraindication to urethral catheterization is known or suspected urethral injury, usually in the setting of a pelvic fracture. Trauma patients presenting with blood at the urethral meatus or with gross hematuria, perineal hematoma, or a high-riding prostate gland should be evaluated with retrograde urethroplasty before catheterization. Relative contraindications to catheterization include urethral stricture, recent urethral or bladder surgery, and a combative or uncooperative patient. Most of the equipment required for urinary catheterization can often be found in a prepackaged catheterization tray. The contents of a typical tray include sterile drapes and gloves, an antiseptic solution such as povidone iodine or chlorhexidine, and cotton balls and forceps for application of antiseptic. Kits also include a Foley catheter, a sterile lubricant, a syringe with water for balloon inflation, and a sterile drainage bag. Additional equipment that is not included in the standard tray includes viscous lidocaine and tape or another device to secure the catheter to the patient. There are many different types and sizes of urinary catheters available. The Foley catheter, a double-lumen urethral catheter with a straight tip, is most frequently used. One lumen is dedicated to urinary drainage, and the second is used to inflate the retention balloon at the distal end of the catheter. A 16 to 18 French is the appropriate size for most adult patients. Larger catheters, 22 to 24 French, should be used for patients with gross hematuria in order to prevent clots from obstructing the lumen. The Coude catheter has a semi-rigid, curved tip that facilitates catheterization in men with prostatic enlargement. Triple lumen catheters, which have an additional port for bladder irrigation, are often used in patients with gross hematuria or clots. The average male urethra is approximately 20 centimeters long and takes an S-shaped course through the penis, urogenital diaphragm, and prostate gland. Note that downward traction on the penis exaggerates this curvature, making catheterization difficult. When the penis is held taut and perpendicular to the body, the urethra straightens, facilitating the procedure. Carefully inspect and prepare all equipment before beginning the catheterization. Sterile gloves should be worn when equipment is handled and while the procedure is carried out. Arrange the contents of the catheterization tray on a bedside table. Check the integrity of the retention balloon and securely attach the catheter to the collection tubing on the drainage bag. Finally, pour the antiseptic solution onto the cotton balls and lubricate the distal tip of the catheter. Place the patient in a supine position on the stretcher. The foreskin should be fully retracted in uncircumcised patients. Next, inject 10 to 15 milliliters of viscous lidocaine into the urethra. This not only anesthetizes the mucosa, but also distends the urethra, facilitating catheterization. Firmly pinch the end of the penis for several minutes to retain the lidocaine within the urethra. Place the sterile drape over the patient's thighs and the fenestrated drape over the pubic region. Grasp the shaft of the penis with your non-dominant hand. This hand is now considered to be non-sterile, and it should not let go of the penis or touch any sterile equipment throughout the remainder of the procedure. Cleanse the glands in a circular motion using the forceps and antiseptic-soaked cotton balls. It is helpful to place the box from the catheter kit on the patient's thighs before the catheter is placed. During insertion, the penis is held upright, perpendicular to the plane of the body. In this demonstration, a Coude catheter is being used. When using a Coude, be sure that the tip of the curved catheter is pointing upward in the 12 o'clock position. Place the tip of the catheter into the meatus and advance it slowly and gently through the urethra. Never force the catheter, since this may create a false passage or other urethral trauma. Continue to hold the penis upright to straighten the penile urethra. Some resistance may be encountered as the catheter reaches the level of the external sphincter. Instruct the patient to breathe deeply to relax the sphincter. Apply slow continuous pressure to the catheter and advance the catheter to the level of the side channel. Before inflating the balloon, confirm proper placement by observing the flow of urine into the collecting tube. If no urine is returned, the catheter is probably obstructed by lubricating jelly and should be flushed with normal saline. Gentle palpation of the bladder may also promote urinary flow into the collecting system. Once proper placement is confirmed, inflate the retention balloon with 10 milliliters of water. Air or normal saline should not be used. It is important to inflate the balloon while the catheter is fully inserted to avoid inflation while the balloon is still in the urethra. Next, gently pull the catheter back to seat the retention balloon against the bladder wall. If the patient is uncircumcised, pull the foreskin back over the glands to prevent the development of a paraphimosis. Finally, secure the collection tubing to either the thigh or the anterior abdominal wall and hang the collection bag in a dependent position to prevent the reflux of drained urine back into the bladder. Catheterization may be difficult to perform in patients with prostatic enlargement. This is usually sensed as resistance to the advancement of the catheter at approximately 16 to 20 centimeters. Use of the Coudet catheter may alleviate this problem, since its firm, curved tip may traverse the exaggerated curve of the prostatic urethra. If a Coudet catheter is not available, a larger Foley catheter, size 20 to 24 French, may be used. Although counterintuitive, the use of the smaller catheter does not facilitate catheterization, since it is less firm than a larger catheter and is likely to kink at the neck of the bladder. Urology consultation should be obtained if you are unable to enter or advance through the urethra due to phimosis, meatal stenosis, or urethral stricture. The catheter should never be forcefully advanced, as this is unlikely to be successful and may result in urethral trauma. Urinary tract infections are common after urethral catheterization. Although many cases are limited to asymptomatic bacteriuria, significant illness or death may result. The single best way to avoid catheter-related infections is to avoid catheterization whenever possible. Additional complications of urethral catheterization include paraphimosis, trauma to the urethra and bladder, and non-deflation of the retention balloon.
This is a video in clinical medicine from the New England Journal of Medicine.
This video will demonstrate how to perform a comprehensive pelvic examination, which includes an examination of the external genitalia, a Papa-Nicolau test, a bimanual examination, as well as a rectovaginal examination. Women should undergo a pelvic examination when they have vulvar and/or vaginal complaints such as pain, discharge, abnormal bleeding, itching, and/or a mass. A pelvic examination is also indicated when pregnancy is suspected or proven and in women who have been exposed to sexually transmitted infections. Pap testing is the main screening tool for detecting precancerous lesions of the cervix. We will now highlight the American Cancer Society recommendations. Cervical cancer screening should begin approximately 3 years after the onset of vaginal intercourse, or no later than 21 years of age, and should be performed annually until age 30. Women aged 30 years or older who have had 3 consecutive normal Pap results can be screened every 3 years, unless they have risk factors such as infection with the human immunodeficiency virus, immunosuppression, or a new sexual partner. Pap testing can be discontinued in women who have had a total hysterectomy for benign lesions, or in low-risk women once they have reached 65 to 70 years of age. Before you perform this procedure, elicit the patient's recent history. Ask about the date of her last menstrual period and review her gynecological and obstetrical history, including any history of abnormal Pap smears and the type of birth control she is using or has used. For women undergoing routine screening, inquire about issues relevant to the vulva and vagina, such as whether she has itching, abnormal discharge, or dyspareunia. Also, ask about total number of sexual partners, patient's sexual orientation, if there is concern about the possibility of a sexually transmitted infection, or has experienced prior discomfort during a pelvic exam. Before examining the patient, wash your hands and put on gloves. Before starting the procedure, you will need to gather the following materials: speculum, gloves, water-soluble lubricant, and materials for the Pap test: brush and liquid-based fixative or wooden spatula, cervical brush, and glass slide with fixative. You may also need wet mount materials: pH paper, glass slides, cotton swabs, potassium hydroxide, and saline, as well as materials for testing for sexually transmitted infections. Depending on your clinic setting, testing for gonorrhea and chlamydia may include DNA probes, culture media, and/or PCR. Ensure that the examination light is working, that the speculum blades approximate where the speculum is closed, and that the screw on the speculum thumb piece is functional. Make sure the patient has emptied her bladder before the exam, as a full bladder may compress the vaginal canal and obstruct the view of the cervix. Provide some privacy as the patient changes into a gown. Ask her to sit on the examination table with a drape covering her legs. Make sure she has been offered the opportunity to have a chaperone in the room during the examination. Help guide the patient into the lithotomy position by placing her feet in the stirrups, having her slide her buttocks to the edge of the examining table, and having her relax her legs into abduction. She should be draped in a way that allows minimal exposure, and you should be able to easily visualize her vulva, but still keep her knees covered. Examine the entire vulva, perianal area, vaginal canal, and Bartholin glands. Observe for erythema, swelling, excoriation, rashes, lesions, masses, trauma, and palpate for tenderness. To examine the Bartholin glands, separate the labia with your non-dominant hand, and then place the index finger of your dominant hand into the introitus. Gently compress the anterolateral tissue bilaterally. This is the area of the Bartholin gland. Examine the patient for areas of discomfort, irritation, or pain. Some of the more common findings include lichen sclerosis, a chronic inflammatory dermatosis that results in white plaques with epidermal atrophy. Vulvar dermatitis results in redness and excoriation. Vulvar ulceration. Condyloma is seen here as multiple cauliflower-like eruptions, and vaginal varicosities, often associated with pregnancy. Put on a clean pair of gloves and warm the speculum with warm water. Ensure the temperature is comfortable for her by touching it to her thigh. Apply a water-based lubricant to the speculum. Insert the speculum gently and slowly at a slight downward angle through the introitus. Once past the introitus, insert the speculum further into the vagina using a downward pressure to a depth of 4 to 5 centimeters. The speculum handle should be approximately 2 centimeters away from the introitus before opening the speculum blades. After inserting the speculum, if the cervix is not visualized, identify the folds of the vagina in front of the speculum opening. These vaginal folds aid in identifying the cervix. Close the speculum, back up 1 to 2 centimeters, and then gently insert the speculum further into the vagina using downward pressure in the direction of the vaginal folds. Reopen the speculum slightly and search again for the cervix. This maneuver may need to be repeated several times. After inserting the speculum, open the speculum slightly and look for the cervix. The cervix has a smooth, firm appearance. No vaginal rugae. You may only see the anterior or posterior portion of the cervix. If the cervix is visualized immediately, open the speculum further to encircle the cervix, and then lock the speculum in place by turning down the screw on the speculum thumb piece. There are several methods used to obtain cervical cells for examination: the liquid-based cytologic screening technique and the traditional glass slide sampling technique will be reviewed here. In both techniques, it is important to obtain samples of both the endocervix and the exocervix. With liquid-based cytologic screening, use a broom-shaped brush to obtain the samples. Once you see the cervix, place the brush against the cervix and gently rotate the brush several times. Remove the brush from the vagina, disconnect the brush tip, and place it in the liquid-based pap container. To keep the outside of the pap container from contamination, make sure the gloved hand holding the container is clean, or ask an assistant to hold the container. The traditional glass slide sample technique is shown here on the same patient. It is unnecessary to perform both techniques. To obtain a traditional glass slide sample of cervical cells, place the wooden spatula on the face of the cervix and rotate 360 degrees. Then place the endobrush in the cervical os and turn 360 degrees. Transfer specimen to the slide by rolling or twisting the spatula and brush on the slide. Apply fixative. Before or after obtaining the pap smear, you can obtain a specimen for wet mount and cervical cultures. Using a cotton-tipped swab, Obtain a sample of the vaginal discharge in the posterior or anterior fornix or along the vaginal walls. Swab this sample onto a piece of pH paper to determine the vaginal pH. A healthy adult female vaginal pH is 4. This will appear yellow on the pH paper. If the vaginal pH is more alkalotic, blue, you should be concerned about possible infection, for example, bacterial vaginosis. Then swab the sample onto a glass slide, apply potassium hydroxide and saline to opposite sides of the slide, and then cover the slide with cover slips. Using the microscope, examine the saline prep sample for clue cells and trichomonads. Trichomonads will appear to vibrate on the slide. Examine the potassium hydroxide prep sample for budding hyphae. To perform DNA, gonococcal, or chlamydia probes, position a cotton-tipped swab in the cervical os for 30 seconds. Place this end in the medium provided, and then secure the top. Make sure the patient's name and other necessary information are on the container. In addition, the pathologist will require information such as the date of the last menstrual period and a history of prior abnormal pap smears. Note whether the patient is postmenopausal, pregnant, on hormonal contraception, and or using an IUD, or on hormone replacement therapy. Warn the patient before unlocking and removing the speculum. Unscrew the lock in the speculum handle and gently detach the blades from the cervix. As you are removing the speculum, slowly close the blades. The blades should be completely closed when exiting the introitus. Make sure you examine the walls of the vagina as you are retracting the speculum. Let the patient know she may have a small amount of bleeding after pap smear sampling. At this time, a bimanual examination can be performed if indicated. To avoid contamination of the patient's abdomen when switching from the speculum exam to the bimanual exam, remove or replace the glove on your non-dominant hand. Place the index finger and middle finger of your dominant hand into the vagina to examine the vagina, cervix, uterus, and adnexae. The abdominal hand should be used to sweep the pelvic organs downward, while the vaginal hand is simultaneously elevating them. It should only take a moment to determine the size, shape, symmetry, mobility, position, and consistency of the uterus. Check the adnexal regions for the presence of appropriately sized.
This is a video in clinical medicine from the New England Journal of Medicine.
Female urethral catheterization, the insertion of a catheter through the urethra into the urinary bladder to permit drainage of urine, is a fundamental skill for the practicing healthcare professional. This video discusses the indications for catheterization, the equipment available, the current methods of catheter insertion and maintenance, potential complications, and how to troubleshoot common problems. Female urethral catheterization is indicated for both therapeutic and diagnostic purposes. Urinary catheterization is therapeutic in several circumstances. It permits effective bladder drainage in patients with acute or chronic urinary retention. A urinary catheter may be used to instill medication for local intravesical therapy. Urethral catheterization and irrigation may be used to remove blood and clots from the urinary bladder in patients with gross hematuria. Urethral catheterization facilitates diagnosis in several circumstances, such as obtaining sterile urine specimens for urinalysis or culture, measuring post-void residual volumes, and monitoring urinary output during surgery or in critically ill patients. Catheterization also allows installation of contrast media during various imaging procedures, such as voiding cystourethography and retrograde urethography. Suspected or confirmed urethral injury can be a contraindication to catheterization. Urethral injuries are rare and are most commonly a result of pelvic fractures or multisystem injuries. If blood is found at the urethral meatus, or if there is evidence of gross hematuria or a perineal hematoma, then urethral or bladder neck injury should be considered. If there is any question of injury, Both genital and rectal exams should be performed, and retrograde urethography considered before catheterization is attempted. In this setting, consultation with a specialist prior to catheterization, if feasible and if time permits, is prudent. Patients who are unable to cooperate may require extra time for calming or may even need sedation for the procedure. Consultation with a urologist should be considered in patients with a recent history of urethral or bladder surgery. Since urinary catheterization can cause infection or trauma, this technique should not be used for routine management of urinary incontinence, but should be reserved for circumstances in which non-invasive methods fail. A variety of prepackaged urethral catheterization kits are commercially available. A typical kit includes a water-absorbent underpad, a sterile fenestrated drape, sterile gloves, 4 or 5 swabs, forceps, an antiseptic solution, a 10 cc syringe pre-filled with lubricating jelly, a 10 cc syringe pre-filled with sterile water for balloon inflation, a pre-connected closed Foley system, and a specimen container with cap and label. Other items, such as those for securing the system to the patient or the bed, may need to be gathered separately. There are many types of catheters varying in construction material, design, and size. Catheters are most often made from latex. However, the use of silicone catheters is becoming more widespread, as latex hypersensitivity and even anaphylaxis related to latex are increasingly recognized. Silver alloy hydrogel-coated latex catheters may decrease bacterial colonization and growth and should be considered for patients with recurrent infections. The Foley catheter is most frequently used in female patients requiring an indwelling catheter. It is a double-lumen, straight-tip catheter with a balloon at its end that is inflated after insertion into the bladder to help retain the position of the catheter. Other types of catheters include the triple-lumen catheter, which can be used for continuous bladder irrigation after bladder surgery or for patients requiring irrigation to prevent retention of clots within the bladder, and the straight catheter, which may be used for intermittent catheterization or on a one-time basis to obtain a urine sample. The size of the catheter is categorized most frequently in French units, circumference in millimeters. The narrowest and softest tube that can effectively be used is recommended, thereby limiting discomfort and decreasing the risk of infection. Smaller catheters are used for narrow urethras or in patients with a history of strictures or scarring. 14 French to 16 French catheters are appropriate for most adult women. Larger catheters, 18 to 24 French, may be used in patients who are at risk for obstruction of the lumen, for example, patients with gross hematuria with clots. Explain the procedure to the patient, addressing any specific questions or concerns. Possible complications such as urethral and bladder trauma, bleeding, and infection should be discussed. With the bed flat, the patient should lie supine in a lithotomy position or a frog-legged position with legs apart and feet together. If available, a table with stirrups may be used to facilitate visualization. Begin by inspecting the genital area to identify the urethral meatus. The adult female urethral meatus, typically 5 to 6 millimeters in diameter, is an ovoid opening with the long axis on the vertical. The female urethra is a fibromuscular tube that is approximately 3.5 to 4 centimeters long. It is located below the clitoris and above the vaginal orifice in the superior fornix of the vulva. Inspect the sterile catheterization kit. Remove it from its outer packaging and place it within reach. Open the inner paper wrapping to form a sterile field. To reduce the risk of infection, urethral catheterization should be performed under sterile conditions, which include wearing sterile gloves when handling the equipment and throughout the procedure. To avoid contaminating the sterile gloves, once you have washed your hands carefully, Retrieve the absorbent pad from the top of the kit and place it with the plastic side down beneath the patient's buttocks before putting on the sterile gloves. If pad placement is difficult, re-wash your hands before putting on sterile gloves and proceeding. Then, cover the patient's abdomen and superior pubic region with the fenestrated drape. Now, with the patient draped, organize the contents of the tray on the sterile field. Pour the antiseptic solution over the preparation swabs in the tray compartment. Set aside 1 or 2 of the swabs, in case excess antiseptic solution needs to be blotted. Squeeze some sterile catheter lubricant onto the tray or into the sterile field to lubricate the catheter tip before inserting it into the urethra. After preparing the tray, using your non-dominant hand, identify the urethra by spreading the labia majora and minora, by placing the thumb and index finger medial to the inner labia, spreading the finger slightly, and with gentle traction, pulling upward toward the head of the patient. This hand is no longer sterile. Do not release this non-sterile hand from this position. After you identify the urethral meatus, use an expanding circular motion to clean the opening with the remaining prep swabs. Lubricate the distal end of the catheter with the sterile jelly. Though lubrication is necessary, too much lubricant may delay the flow of urine. Holding the catheter in the dominant hand, gently introduce the catheter tip into the meatus and slowly advance it through the urethra into the bladder. If the catheter is accidentally inserted into the vagina, or if the tip is contaminated, discard it and obtain a new sterile catheter before proceeding. Because the female urethra is short, urine may begin to flow before the balloon has completely entered the bladder. Once you can see urine flowing through the catheter, continue to advance the catheter for another 3 to 5 centimeters to ensure the complete insertion of the balloon in the bladder. You may feel resistance before the catheter is fully inserted in the bladder at the external sphincter. Instruct the patient to breathe deeply and to relax, which should facilitate passage of the catheter into the bladder. Never force the catheter through the urethra, as this may cause urethral trauma or perforation. Insert the catheter completely into the urethra, and do not inflate the balloon until there is return of urine in order to avoid trauma due to intraurethral inflation. Inject the entire 10 cc syringe of sterile water to inflate the 5 cc balloon completely. Note that the labeled volume of the balloon does not indicate the higher volume required to fill it properly. Partially filled balloons may lead to catheter displacement and urethral or bladder trauma. Saline should not be used because it may cause crystallization and valve malfunction. Air also should not be used because it allows the balloon to float in the bladder, possibly kinking the catheter. With the balloon completely inflated, pull gently on the catheter to fix the balloon against the bladder wall. Secure the catheter to the medial thigh of the patient with tape or a catheter securing device. Finally, place the drainage bag in a convenient location below the level of the bladder. To remove an indwelling catheter equipped with a balloon, first deflate the balloon completely, ensuring that all of the previously injected water is retrieved. After that, gently pull out the catheter. If there is difficulty in removing the catheter, consultation with a specialist is advised. The most common complications of urethral catheterization are trauma and infection. Trauma may result from incorrect insertion of the catheter into the urethra or removal of the catheter with the balloon inflated. Strictures, narrowing, and scarring of the urethra may result from such traumatic injury and can make catheterization difficult. Infection is common in patients with indwelling catheters. Within 48 hours, up to 85% of catheters may be colonized with bacteria, which may lead to bacteriuria. The best way to prevent complications is to avoid catheterization whenever possible. Continue to review the patient's need for an indwelling catheter and remove it as soon as possible. The urethra of some female patients may be difficult to catheterize for various reasons that include previous operative procedures, obesity, previous childbirth, and anatomical variants of pelvic organs. Catheterization may also be difficult in patients for whom positioning may be limited, such as those with chronic arthritis. If you are unable to pass the catheter through the urethra, or if you encounter resistance, the urethra may be kinked because of pelvic organ prolapse. If the prolapse is large and protrudes from the vaginal opening, it may be necessary to reduce it by gently applying pressure to the prolapse and guiding it back into the vagina. If the urethra is not easily visualized, place the index finger of your non-sterile hand inside the vaginal orifice and gently apply pressure superiorly, both to straighten the urethra and to allow the finger to serve as a guide into the superior urethral opening. If you feel the catheter beside the finger, it is incorrectly placed inside the vagina. In this case, the catheter should be removed and properly discarded. Use a new sterile catheter and attempt catheterization again. In morbidly obese patients, an assistant is often necessary to aid in retraction and to maintain sterility. If the flow of urine is slow or non-existent, the catheter may be obstructed or in the wrong site, or the bladder may be empty. Flush the catheter with saline. If saline or urine freely returns, the catheter is properly inserted. Massaging the bladder by gently pressing on the patient's abdomen may also facilitate the free flow of urine. Female urethral catheterization performed with proper sterile technique is an invaluable, reliable method for both therapeutic and diagnostic purposes. It is important for all practicing health professionals to master the proper insertion technique and understand the risks and benefits of the procedure.
This is a video in clinical medicine from the New England Journal of Medicine.
Patients frequently present to primary care offices, urgent care, and emergency departments with musculoskeletal injuries such as fractures, sprains, and dislocations. Many distal extremity injuries can be initially managed in an outpatient setting using basic splinting techniques. Splinting immobilizes injured extremities and prevents further injury, decreases pain and bleeding, and allows healing to begin. While there are many indications for splinting an extremity, three main types of injuries are commonly treated in outpatient settings. Fractures. Splinting is used to stabilize fractures of the upper and lower extremity, providing patient comfort and maintaining proper bone alignment. Dislocations. After reduction of a dislocated joint, splinting is used to maintain anatomic reduction during healing. Sprains. Splinting may be used to maintain the position of function and to alleviate pain for patients with ligamentous sprains. While there are no absolute contraindications to applying a temporary splint to an injured extremity, there are some unique circumstances that must be considered. The natural swelling of an extremity that occurs in the initial phase of healing can lead to challenges in determining the safest method of immobilization. Circumferential casting of an extremity fracture is often avoided in the acute setting, as continued swelling can lead to neurovascular compromise inside a rigid cast. Splints are an excellent alternative because they provide the necessary immobilization while allowing for the natural swelling process to occur without marked neurovascular compression. For injuries that are prone to severe swelling, even a splint can become restrictive as the swelling increases. Additional padding may allow room for expansion in these circumstances. The presence of neurovascular compromise at presentation mandates reduction of the injury to establish vascular perfusion of the extremity prior to splinting and definitive care. An orthopedic specialist should be consulted for fractures requiring urgent surgical evaluation, such as open fractures, which may require operative management. Temporary splints can be placed to alleviate pain and to prevent additional injury while awaiting evaluation by a specialist. Use appropriate universal precautions for potential exposure to bodily fluids when open wounds are present. The materials needed for basic extremity splint placement include a stockinette, cotton padding, plaster or fiberglass rolls or sheets, elastic bandages with clips or adhesive tape, heavy-duty scissors, and a bucket of water. Use sheets or pads to protect the patient's clothing during splint application whenever possible. As an alternative to plaster rolls or sheets, you may also use prefabricated splint materials. Before placing a splint, carefully examine the injured extremity. Failure to expose the injury site fully may result in unidentified injuries and subsequent poor outcomes. Evaluate pulses, motor function, and sensory function to determine whether emergency intervention or evaluation by a specialist is necessary. Treat skin or soft tissue injuries appropriately before placing a splint. Analgesics or anesthetics may be necessary to control pain during the splinting procedure. Place the patient in a comfortable position that allows you to have adequate access to all sides of the injured extremity. Remove all jewelry from the involved extremity before beginning splint placement. This section demonstrates the application of a volar splint to an upper extremity. Apply the stockinette to the extremity, avoiding wrinkles and using sufficient length to extend 10 centimeters beyond each end of the splint. Use scissors to cut an opening for the thumb. Cut a small hole in the stockinette where it lies across the base of the thumb and then pull over the digit to prevent wrinkles. Use cotton padding material to pad the injured extremity for comfort and to allow for anticipated swelling. Wrap the padding around the extremity, overlapping the previous layer by 25 to 50% to place 2 layers of padding over the entire area. In areas of bony prominence or expected irritation, apply extra layers of padding. If substantial swelling is expected, continue wrapping for 3 to 4 layers of protection. The cotton material can easily be stretched or torn as needed for uniform application. Take care to avoid too much circumferential pressure caused by excessive stretching of the padding during the application. Select a piece of dry plaster that is slightly wider than the limb to be immobilized. Measure the length of the splint material required, and then cut or tear the dry plaster material to the appropriate length. Use at least 8 layers of plaster material for upper extremity splints and 12 layers for lower extremity splints to provide adequate strength to the completed splint. Consider using the unaffected extremity to measure the length of plaster that will be needed to limit the discomfort caused by moving the injured limb. Use additional layers of plaster if extra strength is required, keeping the total splint thickness less than 24 layers to minimize the risk of thermal injury from the plaster as it dries. Fill a bucket with lukewarm water less than 50 degrees Celsius and immerse the plaster material until it is saturated. Hold the wet plaster sheets vertically over the bucket and use 2 fingers to manually compress the layers in a downward motion. This removes wrinkles and excess water and will laminate the layers together. Place the plaster material over the cotton padding. Smooth the plaster to mold to the contours of the extremity in the appropriate anatomical position. Apply an additional layer of cotton padding to hold the splint in place and fold the ends of the stockinette back over the splint. Use an elastic bandage to secure the splint in place by wrapping it in a distal to proximal direction. Avoid excessive compression of the extremity when applying this elastic bandage. Before the plaster dries, place the extremity in the desired anatomic position. Use the palms of your hands to mold the splint gently to the extremity, taking care to avoid creating indentations that might lead to pressure points. Allow the splint to dry without further manipulation or patient movement. Avoid resting the splint on a pillow during this time, as heat buildup can cause thermal injuries as the plaster dries. Once the splint has dried completely, check for adequate immobilization, strength of splint, and patient comfort. A volar splint can be used to immobilize a sprained wrist, a triquetral fracture or lunate dislocation, or a 2nd through 5th metacarpal head fracture. This splint should extend along the volar aspect of the forearm from the metacarpal heads to just proximal to the radial head, allowing unencumbered flexion of the elbow. Place the forearm in a neutral position with the thumb upward and the wrist in 20 degrees of extension. Ulnar gutter splints are designed to immobilize fractures along the ulnar aspect of the hand, including injuries to the 4th and 5th phalanges and metacarpals. This splint extends from the distal interphalangeal joint of the little finger to the proximal forearm. Place the forearm in a neutral position with the wrist in 20 degrees of extension. The metacarpophalangeal joints should be flexed at 50 degrees, with the proximal and distal interphalangeal joints in slight flexion. Thumb spica splints are applied to the radial aspect of the forearm to immobilize the thumb and prevent flexion and extension of the wrist. This splint is useful for fractures of the scaphoid and lunate, first metacarpal, and thumb. This splint extends from the tip of the thumb to the proximal forearm. Place the forearm in a neutral position with the wrist in 20 degrees of extension and the thumb slightly flexed. A long arm splint will immobilize proximal forearm and elbow fractures. It can also provide temporary stabilization of intra-articular fractures of the distal humerus and olecranon while awaiting surgical care. When splinting a joint at an angle, be sure to wrap the extremity in the expected final position. Avoid excessive padding around the anterior aspect of the elbow joint in long arm splints, as this can result in skin pressure points and swelling under the splint. This splint prevents flexion and extension of the elbow and limits supination and pronation of the forearm. It extends along the posterior arm from the wrist to the proximal humerus. Place the elbow in 90 degrees of flexion while maintaining a neutral position for the forearm and wrist. A forearm sugar tong splint is used for wrist and distal forearm fractures. It immobilizes the wrist and forearm and prevents supination and pronation of the forearm. The splint extends from the metacarpophalangeal joints on the dorsum of the hand, along the forearm, around the elbow, and back to the volar aspect of the mid-palmar crease. Place the elbow in 90 degrees of flexion while maintaining a neutral position for the forearm and wrist. A posterior leg splint is used to stabilize severe sprains, reduced ankle dislocations, and fractures of the distal leg, ankle, and foot. The splint extends from the metatarsal heads to just below the fibular head while maintaining a 90-degree angle at the ankle. Be sure to keep the fibular head free to avoid compression of the adjacent perineal nerve. Lower extremity splints are not designed for weight bearing, and the patient should use crutches to walk safely. Adding a lateral stirrup component to a posterior leg splint increases splint stability and prevents inversion or eversion of the ankle. This splint provides greater mobilization and stability for fractures near the ankle. The stirrup splint is similar to the sugar tong splint for the upper extremity. Apply the splint to the medial and lateral leg extending from the tibial tuberosity to wrap around the foot and end just below the fibular head. Mold the splint with the ankle at a 90-degree angle. Commercially available ankle splints may be used to enhance comfort after a sprain, but typically do not provide the necessary stability for fractures. Similar products are available for upper extremity sprains, such as a soft wrist splint. Prefabricated splinting materials are available and can be used to create a wide variety of splints for injured extremities using modifications of the techniques demonstrated in this video. Re-evaluate the extremity immediately after completing the splint placement. Evaluate distal motor and sensory function. Palpate for pulses, evaluate the color of the extremity, and assess for appropriate capillary refill. Be sure that the completed splint is comfortable and not overly restrictive, and that the patient's pain is controlled. Address any discomfort by applying additional cotton padding or loosening the elastic bandage. Typical care after the application of a splint should include extremity elevation, application of ice packs, administration of analgesics, and appropriate communication of instructions for medical follow-up. Instruct the patient to keep the splint clean and dry and not to remove it until instructed. Give the patient verbal instructions and an easily understood written list of signs and symptoms that would necessitate urgent return for further evaluation. These include development of any signs of neurovascular compromise or compartment syndrome, such as increased swelling, worsening of pain, discoloration of the distal extremity, difficulty moving the fingers or toes, or change in sensory function. Splinting plays a major role in the initial management of musculoskeletal injuries, particularly those involving extremity fractures, joint dislocations, and severe sprains. A properly applied splint will stabilize the injured extremity, increase patient comfort, and allow the healing process to begin. Depending on the type of injury, a splint may be the only treatment required, or it may be an important temporizing measure until further evaluation or surgical intervention is completed.
This is a video in clinical medicine from the New England Journal of Medicine.
The purpose of this video is to demonstrate the equipment and techniques used to provide intravenous conscious sedation for minor procedures in adults. Practice guidelines may vary in different regions of the world. The American Society of Anesthesiologists has developed practice guidelines for sedation and analgesia by non-anesthesiologists and defines sedation as a continuum, but considers 3 different levels of sedation. Minimal sedation provides a drug-induced state of anxiolysis during which patients respond normally to verbal commands. Moderate sedation, analgesia, or conscious sedation creates a drug-induced depression of consciousness during which patients respond purposefully to verbal commands, either alone or accompanied by light tactile stimulation. No interventions should be required to maintain a patent airway during conscious sedation, and spontaneous ventilation should be adequate. Deep sedation, analgesia, is a drug-induced depression of consciousness during which patients cannot be easily aroused but respond purposefully following repeated or painful stimulation. The ability to maintain ventilatory function may be impaired. Procedures that are particularly invasive or painful may require deep sedation analgesia rather than conscious sedation. Conscious sedation may be considered for any procedure that causes patient discomfort or pain. Contraindications for conscious sedation include a patient with a past history of allergic reaction to analgesic or sedative medications, unstable cardiorespiratory function, and a non-fasting state. Patients undergoing conscious sedation should have had no clear liquids by mouth for 2 hours before the procedure and no food for 6 to 8 hours before the procedure. As sedation is a continuum, a patient undergoing conscious sedation may become deeply sedated and develop impaired airway reflexes and hypotension. Thus, the clinician providing sedation must be capable of providing cardiorespiratory support to one level beyond the anticipated level of sedation. This means, if you intend to induce conscious sedation in a patient, you must be capable of supporting your patient's ventilation, oxygenation, and hemodynamics in the event that he or she becomes deeply sedated. Ultimately, it is your responsibility to ensure that conscious sedation is performed by qualified personnel. Many hospitals and institutions have developed their own guidelines and credentialing systems for sedation providers. It is your responsibility to know these guidelines and to be appropriately credentialed. A thorough history and physical exam is required immediately before a patient is given conscious sedation. Informed patient consent is required. The physical exam should include vital signs and should focus on evaluation of the patient's airway, neurologic, and cardiorespiratory systems. Physical signs that a patient has a potentially difficult airway include obesity, a limited range of motion in the neck, a small mandible, and a limited ability to open his or her mouth. If there are concerns that the patient may have a difficult airway, such as a history of severe sleep apnea or marked obesity, an anesthesiology consult should be considered. Appropriate laboratory tests should be obtained and reviewed, particularly in patients who have potential risks for altered drug metabolism, such as those with liver or kidney disease. Since sedation is a continuum, and a patient's level of sedation can change rapidly, you should have the ability to monitor the patient's level of consciousness, hemodynamics, ventilation, and oxygenation. The patient must have a working intravenous line prior to initiating conscious sedation. Emergency equipment for intubation and resuscitation must be immediately available. You must know how to use this equipment and how to administer appropriate medications in case cardiopulmonary resuscitation is required. Monitors include hemodynamic variables of heart rate and blood pressure. End-tidal carbon dioxide monitoring may improve detection of airway obstruction. Oxygenation is monitored with a continuous pulse oximeter. Vital signs should be recorded at least every 5 minutes while the patient is being sedated. In order to provide conscious sedation, you must know the pharmacology and contraindications for every medication that you use or may use. This brief set of descriptions constitutes an overview. You should review each medication in detail before proceeding with conscious sedation. The benzodiazepine, midazolam, is a commonly used sedative. The opioid agonist, fentanyl, is a commonly used analgesic. Both are available in intravenous formulations. These drugs have a rapid onset and offset. They are titratable, and pharmacologic antagonists are available to reverse their effects in the event of an overdose. Midazolam is a potent benzodiazepine that may be administered intravenously. Its action on gamma-aminobutyric acid, or GABA receptors in the brain, causes anxiolysis and amnesia. Clinically effective doses for sedation vary widely. It is important to titrate the drug to the desired effect. For adults, a dose of 0.5 milligrams can be administered intravenously and repeated as needed every 5 minutes. Flumazanil is a benzodiazepine antagonist used to treat benzodiazepine overdose. To reverse the sedative effects of midazolam administered for conscious sedation, an initial dose of 0.2 milligrams of flumazanil is administered intravenously over 15 seconds. If the desired level of consciousness is not obtained after 1 minute, a second dose of 0.2 milligrams can be injected, and that dose repeated at 1-minute intervals to a maximum total dose of 1 milligram. You should avoid giving flumazanil to patients with severe liver disease or to patients who require long-term benzodiazepine use, since the drug is associated with seizures. Patients given flumazanil need to be monitored closely, because they may become sedated again when the flumazanil effect abates. Fentanyl is a potent opioid that may be delivered by multiple routes. Intravenous fentanyl acts on mu-opioid receptors in the brain and causes rapid onset analgesia and sedation. Clinically effective doses for sedation vary widely. It is important to titrate to the desired effect. For adults, an intravenous dose of 25 micrograms can be administered, and that dose repeated as needed every 5 minutes. Naloxone is an opioid antagonist used to reverse the respiratory depression of opioids. The dose of naloxone should be titrated to patient response. To reverse respiratory depression, naloxone may be administered in increments of 0.1 to 0.2 milligrams intravenously at 2 to 3 minute intervals. Larger than necessary doses of naloxone may cause pain and hypertension. Rapid reversal may cause nausea, vomiting, and diaphoresis. Naloxone administration should be avoided in patients physically dependent on opioids. If you give naloxone to reverse the action of opioids, you must monitor the patient, since the duration of action of some opioids may outlast the duration of action of naloxone. One clinician should be responsible for providing conscious sedation, while another clinician performs the intended procedure. Adequate equipment for monitoring and patient support must be prepared. Before starting conscious sedation, make sure you have the following equipment: an ambu bag and a source of oxygen in the event you need to support your patient's oxygenation and ventilation. Both rigid and flexible suction catheter tips and active suction devices should be at hand. You should continuously monitor your patient's level of consciousness. Other monitors include a blood pressure measurement device, a pulse oximeter, and devices to monitor heart rate and respiratory rate. Although current American Society of Anesthesiologists guidelines do not absolutely require them for conscious sedation, we also recommend an electrocardiogram and an end-tidal carbon dioxide detector. Airway equipment, such as a face mask or oral and nasal airways, should be present. You will need equipment for obtaining intravenous access, such as fluids, catheters, needles, and syringes. You should have the drugs that you will or might need to use, including sedatives, analgesics, reversal medications, and emergency medications. Finally, an emergency or crash cart with advanced airway devices and medications must be immediately available. There are many different ways to induce conscious sedation. As a general rule, start with small incremental doses and titrate to effect. When combining sedatives and analgesics, reduce the dose of each. You may start with midazolam boluses every 5 minutes, with constant re-evaluation of the patient's status. Start with a small intravenous dose, such as 0.5 milligrams, and evaluate the patient's response. At this point, if necessary, you may inject an intravenous bolus of a small amount of fentanyl, initially 25 micrograms, paying particular attention to ensure that the patient's respiratory function is preserved. Depending on the length of the procedure and the patient's response, you may repeat the dose of the medications as required to maintain conscious sedation. Each patient responds differently to sedatives and analgesics, and you must remain vigilant in monitoring your patient's status throughout the procedure. The most serious complications of conscious sedation are when a patient becomes deeply sedated and develops respiratory and cardiovascular depression. Respiratory depression, or apnea, can lead to death, and thus conscious sedation requires appropriate consent, adequate preparation, monitoring, and qualified personnel. Cardiovascular depression, such as hypotension, can be associated with respiratory depression or can occur in isolation. If hypotension develops, sedative medication should be held, and intravenous fluids and medications such as phenylephrine or ephedrine should be used to increase the blood pressure to baseline. After conscious sedation is complete, the patient should be monitored until he or she returns to a baseline level of consciousness. Conscious sedation can provide benefits to both the patient who is undergoing and the clinician who is performing an invasive procedure. Sedation is a continuum, and clinicians performing conscious sedation must be able to provide cardiorespiratory support to one level beyond the intended level of sedation. A thorough patient evaluation is required to identify any contraindications. When performing conscious sedation, appropriate monitoring and equipment for resuscitation must be available. The clinician must be knowledgeable in the pharmacology of the chosen sedatives and analgesics. The most serious complication of conscious sedation in a patient is respiratory and cardiovascular depression. At the completion of the procedure, the patient should be monitored until he or she returns to a baseline level of consciousness.
Primary percutaneous coronary intervention for acute myocardial infarction with ST segment elevation. Under normal circumstances, the flow of oxygenated blood to the myocardium in the coronary arteries is unimpeded. As a result, the oxygen demands of the heart muscle perfused by the artery are met by an appropriate oxygen supply. In this drawing, the myocardium on the anterior wall of the left ventricle is perfused normally by the left coronary artery. The electrocardiogram reflecting that area of myocardium is normal. Over time, an atherosclerotic plaque develops in the coronary artery. For reasons that are not well understood, the layer of endothelial cells covering the plaque, the so-called fibrous cap, may rupture, thereby becoming a nidus for thrombus formation. Within minutes, an occlusive thrombus forms. Blood flow in the coronary artery ceases, and all the myocardium supplied by the artery becomes ischemic. This is reflected on the electrocardiogram as ST segment elevation. If the ischemia is unrelieved, all the ischemic myocardium will die within a few hours. The objective of balloon angioplasty and stent placement is to restore blood flow in the occluded coronary artery as quickly as possible, thereby preventing ischemic myocardium from dying. During balloon angioplasty, a thin metal guide wire is advanced into the occluded coronary artery and past the occlusive thrombus, after which a deflated balloon catheter is advanced over the wire, positioned at the site of the occlusion, and inflated for 1 to 3 minutes. Then the balloon is deflated and retracted. Coronary arterial blood flow is restored, thereby relieving the ischemia. As a result, the ST segment elevation begins to resolve. Alternatively, blood flow in the occluded coronary artery may be restored by the placement of a metal stent. A thin metal guide wire is advanced into the occluded coronary artery and past the occlusive thrombus, after which a deflated balloon catheter with a metal stent affixed to it is advanced over the wire, positioned at the site of occlusion, and inflated for 1 to 3 minutes. Inflation of the balloon expands the stent. The balloon is then deflated and retracted. The now expanded metal stent remains in place. Coronary arterial blood flow is restored, thereby relieving the ischemia. The ST segment elevation begins to resolve. This is a video in clinical medicine from the New England Journal of Medicine.
Incision and drainage is the primary therapy for cutaneous abscess management, as antibiotic treatment alone is inadequate for treating many of these loculated collections of infectious material. Most localized skin abscesses without associated cellulitis can be managed with simple incision and drainage and do not require antibiotic treatment. Cutaneous abscesses have been described in all areas of the body, but are most commonly found in the axilla, buttocks, and extremities. This outpatient procedure is appropriate for many office settings, as well as for urgent care and emergency department practice environments. Diagnosis of a skin abscess is the first step in a successful procedure. This can be accomplished in 3 ways. Physical examination of the affected area will often allow diagnosis of an underlying abscess based on swelling, pain, redness, and fluctuance. Spontaneously draining skin abscesses are also amenable to diagnosis by physical examination alone. Needle aspiration of a suspected skin abscess can assist the clinician in making the diagnosis of a localized abscess when results of physical examination are equivocal. Bedside ultrasound is a valuable adjunctive tool for identification of localized areas of fluid under the skin that may represent isolated areas of infection. An abscess that is diagnosed in one of these 3 ways may be appropriate for incision and drainage if it is larger than approximately 5 millimeters and found in an accessible location. Extremely large or deep abscesses in areas difficult to anesthetize may be more appropriate to treat in a formal operating room setting. Abscesses of the palms, soles, or nasolabial folds can be associated with complications and may require consultation with an appropriate specialist. Incision and drainage is not indicated for cutaneous cellulitis without an underlying abscess. The need for preoperative antibiotics for conditions such as abnormal or artificial heart valves may require reconsideration of the timing for the procedure. Input from an appropriate specialist may be important for areas of the body with cosmetic concerns because of the expected scar formation after an abscess drainage. Appropriate universal precautions for potential exposure to bodily fluids should always be used. Materials needed for the incision and drainage of an abscess are similar to those needed for a laceration repair. A pre-assembled laceration kit may contain many of the necessary items. For preparation and anesthesia, obtain a skin cleansing agent, sterile gauze, local anesthetic, and a 5 to 10 milliliter syringe with a 25 to 30 gauge needle. 1% lidocaine is an appropriate anesthetic for this procedure. Lidocaine with epinephrine offers advantages such as reduced bleeding and an extended duration of action, but is typically avoided in areas with a single blood supply. Bupivacaine is another option that offers an increased duration of action for the anesthesia. Items important for the incision and drainage itself include a scalpel blade with handle, a small curved hemostat, normal saline with a sterile bowl, and a large syringe with a splash guard or a needleless 18-gauge angiocatheter for irrigation of the wound. Swabs for bacterial culture, wound packing material, scissors, gauze, and tape should all be available to complete the procedure and dress the wound. Obtain informed consent by discussing the risks and benefits of this procedure, including pain, bleeding, and scar formation. Wash your hands with antibacterial soap before beginning the procedure. Protect yourself from exposure to bodily fluids, as many abscesses are under pressure. A face shield and gloves should be used. Place all equipment on a bedside table that is easy to reach. Position the patient so that the area for drainage is fully exposed. Apply a skin cleanser, such as chlorhexidine or povidone iodine, in a circular motion starting with the peak of the abscess. Cover a wide area outside of the wound to prevent contamination of other equipment. Anesthetize the top of the wound. This should be done by inserting a 25 or 30 gauge needle parallel to the skin and injecting into the intradermal tissues. Once the entire open bore of the needle is under the skin, gentle pressure should be used to infiltrate with the anesthetic agent. You will note blanching of the tissue as the anesthetic spreads out. Continue with infiltration until you have covered an area over the top of the abscess large enough to anesthetize the area of incision. Some abscesses may require additional injections of anesthetic in a local field block pattern or moderate procedural sedation for additional patient comfort. Hold the scalpel between your thumb and forefinger. Make an incision directly over the center of the abscess that is oriented along the long axis of the fluid collection. Resistance may be felt as the incision is initiated, and steady firm pressure will allow a controlled entry into the subcutaneous tissues. Purulent drainage will begin when the abscess cavity has been entered successfully. Cosmetic results can be optimized if the incision is made parallel to existing skin tension lines. The incision should be extended to create an opening large enough to ensure adequate drainage and prevent recurrent abscess formation. It may need to extend the length of the abscess borders. Care must be taken to control the scalpel during the stab incision to prevent puncturing through the back wall of the abscess. The goal is to allow enough access for introduction of a hemostat to break up loculations and place internal packing. Use a swab to obtain a sample from the interior of the cavity for bacterial culture. While most patients will not require antibiotics after an abscess drainage, culture information is useful if the patient's condition later worsens and antibiotic treatment becomes necessary. After allowing the wound to drain spontaneously, gently express any further contents. Additional injections of local anesthetic may be helpful during this portion of the procedure if there is significant patient discomfort. Use a curved hemostat for further blunt dissection to break loculations and allow the abscess cavity to be completely opened up. Insert the hemostat into the wound until you feel the resistance of normal tissue, then open the hemostat to perform blunt dissection of the internal portion of the abscess cavity. Continue this procedure of breaking up loculations in a circular motion until the entire abscess cavity has been explored and any deep tracts that extend into surrounding tissues have been identified. Gentle irrigation of the wound should be performed using sterile normal saline. Appropriate wound incision size will enhance irrigation and prevent excess buildup of pressure within the abscess cavity. The irrigation should continue until the effluent is clear. Using wound packing material, such as 1/4 inch or 1/2 inch packing strips, gently pack the abscess by starting in one quadrant and gradually working around the entire cavity. Place sufficient packing to keep the walls of the abscess separated and to allow further drainage of infected debris. Overpacking may cause ischemia of the surrounding tissues or interfere with desired wound drainage and should be avoided. Appropriate packing will allow healing by secondary intention and avoid premature closure of the wound, which can lead to reaccumulation of bacteria and recurrent abscesses. For a simple abscess, the now openly draining wound allows the body's host defenses to clear the infection without the need to expose patients to the side effects or risks of antimicrobial therapy. After most incision and drainage procedures are performed in healthy patients, antibiotics are not required. Patients with extensive cellulitis beyond the abscess area or with significant comorbidities may require supplemental antibiotic treatment. Providers are encouraged to use their local bacterial culture susceptibility data to guide any such empiric therapy. Community-acquired methicillin-resistant Staphylococcus aureus has garnered heightened attention because of increasing prevalence in skin infections. It is imperative to know and follow your regional management guidelines for this pathogen. Cover the abscess wound with a sterile, non-adherent dressing. Topical antibiotics have a limited benefit and are not required. As with any wound, be certain that the patient's tetanus immunizations are up to date. All abscesses should have packing removed in a few days, and most patients with wounds that have packing in place should be scheduled for a return visit for follow-up and packing removal 2 to 3 days after the procedure. Patients should be given written instructions telling them to return earlier if there are any signs of worsening. On subsequent visits for wound care, packing should be removed to allow assessment of the ongoing healing by secondary intention. Use of fresh packing material may be necessary to continue the healing process if significant wound drainage is still ongoing. A follow-up visit should then be rescheduled for 2 to 3 days later. This is common for abscesses that required extensive drainage. In the absence of other complications, the need for repacking is not an indication for antibiotic treatment. The acidic environment of infected tissue leads to difficulties with adequate anesthesia provided by local anesthetic agents. Using appropriate amounts of anesthetic, allowing sufficient time after injection, or supplementing with oral and parenteral agents can increase patient comfort. Finally, additional complications to watch for include the progression to surrounding cellulitis, development of a fever, or other signs of clinical worsening. These may prompt consideration for repeat incision and drainage of an abscess or the need for antibiotic therapy. Most abscesses will respond well to simple incision and drainage and will not require treatment beyond packing changes and local wound care practices.
This is a video in clinical medicine from the New England Journal of Medicine.
Paraphimosis occurs when the tight penile foreskin of an uncircumcised or a partially circumcised male has been fully retracted behind the ridge of the glans and cannot be pulled back to its normal position. The tight preputial ring can then constrict the glans, leading to swelling and impairment of both lymphatic and venous return. If left untreated, this condition may have severe consequences, including strangulation of the glans and tissue necrosis. This video shows the reduction of paraphimosis in children and is applicable up until adulthood. However, demonstration of the procedure in adults is beyond the scope of this video. In boys, paraphimosis occurs when someone, most often the child, an uninformed caregiver, or a healthcare professional, retracts the prepuce and then leaves it in its retracted position. Paraphimosis may occur after foreskin retraction, self-manipulation, genital cleansing, detailed penile examination, or urethral catheterization. Any condition that impairs preputial softness favors the development of paraphimosis. Examples of these conditions are angiomas, or warts of the prepuce, preputial scarring after burns or inflammation, and preputial piercing, which is usually seen in adolescents. Any patient who presents with a paraphimosis is in urgent need of medical attention. Reduction should be performed immediately. Manual reduction of paraphimosis should be avoided in patients with significant necrosis or ulceration of the foreskin or glans. The procedure should also be avoided in patients with angiomas, warts, or other dermatological lesions of the foreskin or glans. If these contraindications are present, obtain surgical consultation right away to evaluate the need for formal surgical reduction of the paraphimosis. Since many patients are allergic to latex, you should not wear latex gloves during the procedure. Before beginning the procedure, gather the necessary equipment. You will need non-sterile gloves, gauze pads, non-alcoholic antiseptic solution containing chlorhexidine or povidone iodine, and an anesthetic gel or cream that does not contain epinephrine. To prepare the patient for the procedure, explain it in detail to the patient, parent, or caregiver. Obtain informed consent to perform the procedure. Before attempting the reduction of a paraphimosis, it may be useful to administer conscious sedation or inhaled nitrous oxide to the patient in addition to a local anesthetic. Your decision will depend on the needs of the patient and the protocols of your institution. The paraphimosis lesion may be effectively anesthetized by applying a liberal amount of anesthetic gel or cream to the glands and foreskin. After applying the anesthetic, wrap a dry gauze pad around the swollen area of the penis, directly over the anesthetic gel or cream, in order to prevent the gel from leaking. Leave it in place for a minimum of 10 minutes before attempting the reduction procedure. An alternative approach is the use of penile block. Before you begin the procedure, make sure that you are comfortably seated beside the patient, since the reduction may take longer than you anticipate. It generally takes about 10 to 15 minutes until a reduction that uses manual pressure is successful, but it can take up to 30 minutes. The bed or examination table should be at a height that allows you to rest your elbows on its surface while performing the procedure. Once you are sure that you will be comfortable during the procedure, wash and disinfect your hands and put on non-sterile gloves. Place the patient in the supine position. Gently disinfect the genital area using antiseptic-soaked pad swabs. Check the effectiveness of the topical anesthesia before you attempt the reduction. Remove any urethral catheter or preputial implant if present. Carefully inspect the penis to make sure that no constricting bands or foreign bodies are present. If the swelling of the foreskin is moderate, attempt gentle reduction. Using the tips of one or both thumbs, push the glands through the foreskin opening, while simultaneously using the index and middle fingers of both hands to pull distally on the retracted foreskin in order to slide it back over the glands. This step may take longer than expected because the swelling resolves slowly. In patients with severe swelling of the foreskin, reduce the swelling before attempting to perform the procedure. You can accomplish this by firmly grasping the swollen area and gently squeezing its circumference for several minutes. You may need to use a gauze pad to keep the penis from slipping out of your hands. Once the edema of the foreskin has been reduced and the foreskin looks flaccid, you may attempt manual reduction. The paraphimosis is considered reduced when the phimotic ring is drawn back over the glands. Confirm that the reduction is complete by ensuring that the foreskin now fully covers the glands. The patient's pain should be resolved once you have successfully reduced the paraphimosis. If manual reduction procedure is unsuccessful, a surgical specialist should be immediately consulted to manage the situation. To prevent the recurrence of a paraphimosis, inform the patient, parent, or caregiver that the prepuce should be drawn back over the glands every time the penis is manipulated. Instruct the patient, parent, or caregiver that the foreskin should not be retracted for any reason for about 1 week after the paraphimosis has been reduced. A follow-up appointment should be made so that the clinician will be present the first time the foreskin is retracted. This appointment has two purposes. It will serve as a teaching session, during which the practitioner shows the patient how to clean the penis, and it will give the practitioner an opportunity to make sure that everything has healed. Although minor, the most frequent complication of manual reduction of a paraphimosis is the tearing of the preputial ring. It can be avoided by a gentle but sustained reduction of the preputial edema before the foreskin is slid back over the glands. If tearing occurs, treat it by applying antiseptic solution to prevent the development of an infection. This complication predisposes the patient to preputial scarring and the recurrence of phimosis. Paraphimosis is a urological emergency that must be treated immediately in the emergency department. In most cases, manual reduction, which is the non-invasive technique, is effective and should follow these steps. After adequate confirmation of the diagnosis and a decision that the indication is appropriate, obtain informed consent from the patient, the parents, or the caregivers. Prepare the material and the patient. Seat comfortably, reduce the paraphimosis, and confirm the reduction.